Multidisciplinary Oncology Conference. We're really pleased to have you all here today. For the interest of time, I think we can make a start. Just a couple of things I would like to say before we start. Uh, all the talks are for 15 minutes, so I would request all the speakers to please stick to the time. After 10 minutes, you will be reminded that 5 minutes are left. This is a slightly different meeting. In the panel discussion session, um, as you all have the questions, just to give you some idea what we will be discussing in the panel discussion. Uh, so during the panel discussion, the moderator will be asking the question for the first 10 minutes. Yeah. For the last 5 minutes of the panel discussion, we will open the floor for the audience. If they have any question, they can ask. So without any delay, we can start our first session of early breast cancer. Our first speaker is Dr. Olga Economido. She's an academic consultant medical oncologist specializing in breast cancer and leads the Breast Cancer Translation Research Group at the Institute of Genomics and Cancer, University of Edinburgh. She combines a busy breast oncology clinical practice with leadership of clinical trials and translation research. She's also a clinical expert in National Institute of Clinical Excellence and SMC, and serves as the chief investigator and principal investigators in multiple national and international clinical trials. Her research focuses on biomarkers of treatment response and breast cancer clinical trials across all phases. I would welcome Dr. Olga to the stage.
Thank you, Dr. Farouk. It's a great pleasure and honor to be here. So I was asked to give a talk on the preoperative neoadjuvant therapies in early breast cancer, focusing on triple-negative breast cancer HER2, which is a big task for 15 minutes. I hope I will be able to deliver on time. So these are my disclosures. So we'll start with a quote from Hippocrates. Healing is a matter of time, but it's also a matter of opportunity. Triple-negative breast cancer is the most aggressive type of breast cancer, followed by HER2 positive, followed then by estrogen receptor positive breast cancer. It's the more aggressive subtype of cancer than other subtypes. There is a high risk of recurrence, and these cancers, they tend to recur very early, giving not just visceral metastasis, but also CNS metastases. The survival for women with triple-negative breast cancer is poorer than in women with other types of breast cancer. And if we look at these graphs, with the bottom one, the green one, being the triple-negative breast cancer stage 3, stage 4, and the fuchsia pink above that, which is all other breast cancers, even though this is an old study, this shows how poor the survival of triple-negative breast cancer patients is, despite the significant advancements we had in the breast cancer field the last few years. I believe that the gap remains pretty big between triple-negative and all other types. Event-free survival now correlates very well with PathCR, complete pathological response, which is considered as a good surrogate for prognosis. Looking at the event-free survival in patients with or without PathCR, on the left, we see that the event-free survival in 3 years is 95%, when actually non-PathCR is 78%. In the DRFS now, in patients with PathCR and non-PathCR, is 95% versus 81%, with hazard ratios in both ends, suggesting a reduction in the recurrence rate of about 80%. Achieving a PathCR doesn't mean 0% of risk recurrence. And of course, achieving non-PathCR doesn't mean 100% of risk recurrence, as we saw in a large meta-analysis by Laura Spring a few years ago. We managed to improve the post-operative treatment by adding additional agents like capecitabine, adjuvant capecitabine for triple-negative breast cancer patients that they had residual post-neoadjuvant chemotherapy, which improved the event-free survival with a hazard ratio of 0.52 for patients that they carry a BRCA1, BRCA2 mutations, and they had a stage 1 to stage 3B cancer, either receiving NAC, having residual disease, or adjuvant TTRN plus disease. They received olaparib for 1 year if they had residual or adjuvant treatment for these with these characteristics versus placebo. And what we have seen is that the IADFS at the 4 years was given an additional absolute benefit of 7.3%. Overall survival was also improved, given a 3.4% with a hazard ratio of 0.68, reducing the chance of death by 32. Now, all these years we have seen studies investigating the role of platinum. Gepard-6 brightness have shown that the addition of carboplatin to anthracyclines and taxanes improve the PATCR rates with a hazard ratio of 0.56 with Gepard-6 brightness 0.57. CLGB was a negative study in terms of showing differences between the addition, and perhaps this was because the bevacizumab, an angiogenic drug, was included. However, we know that the PATCR rates in triple negative increased to more than 50% with improvement of the event-free survival and overall survival. The use of immunotherapy in the metastatic setting and the good data in terms of improving PFS and OS have led to moving the immunotherapy to the early setting. But why immunotherapy works in early breast cancer? And you can see here the differences between early breast cancer and metastatic. We have high antigen presentation, reduced tumor clonality, reduced tumor heterogeneity, increased TILs. We know that this is a good predictive factor, and there is a high PD-L1 positivity. These are the main pivotal immunotherapy trials in triple-negative breast cancer. The KEYNOTE-522, which has actually changed the gold standard practice, introducing immunotherapy in the neoadjuvant setting. And we have also the IMpassion131 using atezolizumab. These are the reference papers for KEYNOTE-522, a randomized placebo-controlled phase 3 study, randomizing patients with triple-negative breast cancer to receive carboplatin paclitaxel plus or minus pembrolizumab, followed by anthracyclines plus or minus pembrolizumab. This was followed by surgery, and patients on the adjuvant setting had pembrolizumab or placebo. The primary endpoint was the PCR and the event-free survival. And this is the definitive PCR analysis to test the primary hypothesis of PCR based on the pre-specified test in 600 patients. So we have seen an absolute delta value of 13.6 between the two groups, patients receiving pembro versus non-pembro. The pembro patients achieved a nearly 64% PCR rates versus 51% for the non-pembro. And I have to note that the PD-L1 testing was not required on the neoadjuvant setting. Looking at the event-free survival, we have the interim analysis 4 on the left and the interim analysis 6 on the right, giving a delta value, absolute delta value, and absolute benefit of 9% for the patients receiving pembrolizumab versus the patients not receiving pembrolizumab. The 16-month event-free survival rate for pembrolizumab was 81.3 versus 72.3 in the placebo arm with a hazard ratio of 0.63. As I said, PD-L1 was not required, the testing, and from the subgroup analysis, we can see that every subgroup actually received benefit from the addition of pembrolizumab. The subgroup analysis based on the SPS score with SPS 1, SPS less than 1, and SPS more than 10, we can see that every single group receives a benefit from the addition of pembrolizumab with delta values ranging from 18% to 14%. Obviously, we can see that the CPS1 score defines the rate of achieving a PATCR with the CPS1 score achieving less PATCR rates, still though pretty important of 45%, but with higher for patients that they have a CPS score of more than 10. And the question is, and this was one of the debates that we had following the initial data from the KEYNOTE-522, does it worth continuing pembrolizumab on the adjuvant setting once we have received the pathology report following the surgery and the patient has the residual disease? If you can focus on the bottom graph showing the patients that they had no PATCR, we can see that still the patients that they have received pembrolizumab and have not achieved PATCR, they do better in terms of the overall event-free survival versus the patients that have not received, have not achieved PATCR and have not received pembrolizumab with 62.6% versus 52.3%. So what are the implications of Keynote 522? The presence of PATSIA is predictive of long-term outcome. The absence of PATSIA, though, does not rule out any substantial benefit. And last but not least, this is the first study that have actually shown that immunotherapy in the neoadjuvant setting offers a statistically significant overall survival benefit. And this is at the 60 months, the overall survival was 86.6 for the patients receiving pembro versus 81.7 for the non-pembro group. Based on the Keynote 522 data, pembrolizumab in combination with chemotherapy as neoadjuvant treatment and then continued as monotherapy in the adjuvant setting should be offered to all patients with early triple-negative breast cancer stage 3 or 3, unless, of course, there are contraindications. And these are the ESMO guidelines, which describe what I have already mentioned, so I'm not going to spend time discussing this. What are the future considerations now in terms of the early triple-negative breast cancer? The escalation is very small. I can't see anything on my screen. Good, I can see now. Thank you. Sorry. Let's go back. In patients with node-negative disease and TILs which are more than 75%, we know that the TILs more than 75% is a very good predictive factor. Shall we escalate when we have an RCP score of 3? What is the role of antibody-drug conjugates plus or minus immunotherapy? And we had several studies like the TROPION-B03, ASCEN-05, and the NEOSTAR investigating the combination of these drugs. Shall we tailor the treatment based on the TILs and PD-L1? How expensive this might be, and is the infrastructure across the world to actually do this kind of high-end biomarker testing? And what is the optimal adjuvant treatment? Trofuso 12 and the TROPION-B03, they're looking at antibody-drug conjugates, reducing the risk in patients that had residual. ctDNA surveillance. We had trials that they were negative. They had an early closure like the CEST. I think there's a big progress that has been done in terms of the ctDNA, still though further progress is required in terms of the breast cancer. And again, who needs full intensity therapy and who can safely de-escalate, and what is the best treatment for each of the patients based on the characteristics and comorbidities we need to tailor. Again, sorry, but my screen is switching off. Now, moving on to discuss the HER2, and these are the ESMO guidelines. We know for patients that they have a T2 cancer or a node-positive cancer, neoadjuvant chemotherapy is the gold standard. And usually for us in UK and assume across the world, the anthracyclines followed by docetaxel, carboplatin, and Phesgo or IV trastuzumab, pertuzumab is the gold standard. My screen is off again. For patients that had PATSIA and had node-negative disease, the patients will have adjuvant trastuzumab. For patients not achieving a PATSIA and had residual disease, they will receive TDM1 as per Catherine trial data. For the ones achieving PATSIA, they will receive Phesgo and they had node-positive disease. Shall we put the slides? Good. So this is a timeline in terms of the progress and the timeline based on the progress that we have seen since 2005 in HER2-positive breast cancer. And especially in the neoadjuvant setting, and of course the affinity and the Catherine study was on the adjuvant setting. We haven't seen any major improvements in terms of the neoadjuvant setting. So the Catherine study, which looked at the addition of TDM1 and actually replacing the Phesgo on the adjuvant setting by TDM1 in patients that they had the residual disease, and this is the final analysis at 8.4 years follow-up, has shown an absolute IDFS benefit of 13.7% at 7 years. Looking now at the overall survival interim analysis, again at the 8.5 years, the absolute overall survival benefit was 4.7 for patients receiving TDM1, and this has led to the approval of TDM1 on the adjuvant setting for patients that they had high-risk disease to start with and they had residual post-neoadjuvant chemotherapy. But the groundbreaking and most possibly trials that will change the treatment landscape where the Destiny Breast 011 and the Destiny 05 that we've seen in ESMO only a couple of months ago. But let's start with the Destiny Breast 011 and the study design. A randomized global multi-center open-label phase 3 study looking at patients with previously untreated HER2 positive early breast cancer. They recruited both HR positive and HER2 and HR negative patients. They had to be high risk, meaning either 5 centimeters node negative disease or T4 to 0 plus node positive disease. Inflammatory breast cancer patients were included. So the patients were randomized 1-to-1 to receive, to 3 groups to receive either TDXD plus THP 4+4 or the standard regimen according to the investigators, which was anthracyclines followed by THP 4+4 or monotherapy TDXD for 8 cycles. Surgery followed, and then the recommended post-neoadjuvant treatment as per study protocol, depending on the path-CR or the non-path-CR, with patients achieving path-CR, receiving radiotherapy and FESGO for up to 1 year. The non-path-CR patients received radiotherapy TDM1 as per Kathleen trial. And the HR positive, they received endocrine therapy. The primary endpoint was path-CR. The demographics and the baseline characteristics were very well balanced. The majority of the population that participated were Asian. 73% had HR positive disease. And this is absolutely important to know in this study because the HR positive, HER2 positive breast cancer patients, they do not achieve these high rates of complete pathological response that we see with HR negative HER2 positive patients. And 90% of the population were node positive. So the primary endpoint, as I said, was the path-CR. And what we have seen is that the path-CR rates achieved in the TDXD plus THP was 67% versus 56% with an absolute value of 11.2%. Looking now at the different groups, the HR positive achieved 61.4 path-CR rates in the TDXD THP group versus 52.3 in the standard according to the investigators' regimen, anthracyclines plus THP. In the HR negative, as expected, the path-CR rates were higher, achieving 83.1 complete response in the TDXD versus 67.1. So the neoadjuvant TDXD followed by THP demonstrated statistical significant and clinically meaningful improvement in path-CR versus the standard regimen, the dose-dense AC followed by THP, and the improvement was observed in both groups. The RCB outcomes now were important to note, and this is the reason is that the RCB is not as dichotomous as the path-CR. Looking therefore at the RCB 0-1 on the left in the intent to treat population, 81.3% in the intended to treat population achieved an RCB score of 0 to 1 versus 69.1 with a delta value of 12.2. Looking at the subgroup analysis in the HR positive, HR negative on the left, 78 in the HR positive, which again is pretty impressive, versus 64.7 on the standard regimen. For the HR negative, a 9.2% difference with patients achieving 90% path-CR rates in the HR negative TDXD group. Event-free survival still very immature, but a good positive trend is noted with a hazard ratio of 0.56. I guess we need to wait to see more data so as to conclude the benefit. And when it comes to TDXD, I'm sure we all have an anxiety about IELD. So it was interesting to see that the IELD rates were not actually different between the two groups. The left ventricular function was actually better on the TDXD arm compared to the anthracyclines, which is expected given that anthracyclines are cardiotoxic drugs. So overall, the safety profile was favorable for the TDXD versus the DDAC-THP with reduced rates of grade 3 toxicities. So the path-CR rates improved 67.3, so more than 2/3 of patients in the TDXD-THP arm had a path-CR, and the improvement was seen in both HR positive and HR negative. My only comment is that when it comes to these trials, that the patients had not carboplatin, obviously, and I'm sure that the majority of us were using carboplatin. So in UK, TCHP, so docetaxel carboplatin HP, is the recommended usually for patients with HR negative, HER2 positive, but also the addition of carboplatin on the THP is recommended on the second part of the neoadjuvant when this is followed, when this follows the adjuvant anthracyclines. Moving on to discuss quickly the Breast-05, which is a study that in a good way copied the design of the Catherine study, which means replacing TDM1 with TDXT. So this study looked at patients with residual invasive disease in the breast or the axillary lymph nodes after neoadjuvant chemotherapy with patients that they had residual disease. The patients were randomized to receive 14 cycles of TDXT versus 14 cycles, which is the standard of care of TDM1. The primary endpoint was the IDFS, and you can see here the key secondary endpoints. So what is interesting looking at the category of first IDFS events is that, first of all, we have less events in the TDXT arm versus the TDM1, 50% less. And when we look at the events themselves, we see that we have less CNS involvement and less non-CNS compared to the patients that receive TDM1. So we have seen lower distant and local regional recurrences with the TDXT versus TDM1, including the CNS metastases. Looking at the disease-free interval, 92.3% for TDXT versus 83.5%, with an impressive hazard ratio of 0.47 and delta value of 8.8. Secondary endpoints, disease relapse recurrence-free interval, brain metastasis-free interval, and overall survival. So for the DRFI, the delta value was 7.8 between the two groups. For the brain metastasis-free interval, again, we have seen a difference of 2.1 with a hazard ratio of 0.64, and the overall survival was also 2.3% difference with a hazard of 0.61. And these are the future considerations in terms of the developments in the HER2 early breast cancer. De-escalation for selected patients. The key challenges are who can we safely identify just to receive treatment without compromising the cure. Escalation guided by response and not just the stage. One of these very fancy studies, which I really like the design from our colleague Javier Cortez's Fairgain, looking to use PET scans to define and determine the treatment. So pathological complete response already guides the adjuvant therapy, but the real-time adaptation, mid-treatment escalation or de-escalation is a key thing. Early identification of the resistant disease, biomarkers is a key thing in all breast cancers, not just in HER2. Combining the PATHCR with ctDNA or molecular disease residual matters, and the future priorities are reduced cumulative HER2 targeted exposure, anthracycline sparing regimens, and patients that we cure without a really lifelong morbidity. So in summary, smarter biology-driven, response adaptive therapy, less for those who don't need more and more only for those who truly need to. And I'm going to finish with a quote that I've started my talk. Healing is a matter of time, but it's also a matter of opportunity, and we just need to identify which opportunity for each of our patients. Thank you very much for your attention.
Thank you, Dr. Olga, for a comprehensive presentation covering neoadjuvant therapies and early breast cancer. So we'll move on to our next talk, surgical oncology. It's my pleasure to invite my friend and colleague, Dr. Jay Angel. He's a clinical professor of surgical oncology in MBRU, and he's a consultant surgical oncologist in Dubai Health. Dr. Angel brings more than 30 years of academic and clinical leadership in surgical oncology, having previously served as head of surgical oncology at Queen's University, Canada, for over 16 years. He is internationally recognized for his expertise in complex oncological surgeries, education, and mentorship. He is a graduate of the Royal College of Surgeons in Ireland and holds a fellowship with leading international surgical and medical colleges. So his topic of his talk will be surgical management of axilla after neoadjuvant therapy. This is something we usually discuss in MDTs every week. Thank you.
Thank you very much. And that was a very nice, overblown introduction, but I appreciate it. So today I'd like to chat with you about management of the axilla following neoadjuvant chemotherapy. I have no conflicts of interest. So as you're well aware, the management of the axilla has changed quite dramatically, especially in my career. And unfortunately, there are still wide variations in clinical practice. So currently, there are three types of axillary surgery: axillary lymph node dissection, sentinel lymph node biopsy, and more recently, targeted approaches. So axillary lymph node dissection, as you're aware, was the traditional way we managed invasive carcinomas of the breast. It was important for staging, local control, but we were never able to show that it had a survival advantage. It requires a drain that is often in place for 2 to 3 weeks. It causes numbness and pain in the axilla that may extend right down to the elbow. If the patients aren't diligent with their exercises, they may have issues with range of motion in that shoulder. And 15 to 25% of individuals will develop lymphedema. Sentinel lymph node biopsy was a dramatic change, and that came about in the 90s. Dr. Don Morton and Armando Giuliano at UCLA developed this technique, and we're able to see that using sentinel lymph node biopsy, if it was negative, we did not need to do an axillary lymph node dissection. Z11 showed us that even if there were up to 2 nodes positive, we didn't need to do an axillary lymph node dissection, and the Amoros trial confirmed that. So more recently, targeted approaches have appeared. These basically, any abnormal node clinically or radiologically is biopsied. If it proves to be positive for malignancy, then it is marked, and the patient then proceeds with neoadjuvant chemotherapy, and the objective is to remove that node at the time of sentinel node biopsy after neoadjuvant therapy. So the approach to the axilla depends on the presence or absence of nodes before neoadjuvant chemotherapy and after neoadjuvant chemotherapy. So it's important initially to do a very thorough clinical examination, and in most centers, ultrasound is also done prior to neoadjuvant therapy. Any abnormal node is identified, biopsied, and usually marked with a clip. We then proceed with neoadjuvant chemotherapy, and we know that neoadjuvant chemotherapy can downstage a significant number of these patients. So individuals that are clinically node negative before and after neoadjuvant chemotherapy can safely undergo sentinel lymph node biopsy. It is recommended that this is done concurrently with the breast surgery. Some individuals are doing it before neoadjuvant therapy, but there's no evidence to really support that. Several studies are looking at de-escalation as well in very early stage breast cancers with no sentinel lymph node. So sentinel lymph node biopsy post-neoadjuvant therapy is the standard for clinically and radiologically negative nodes. One must try to reduce the false negative rate, and the best way to do that is to use dual tracer, so both blue dye and radioisotope. We aim to remove a minimum of 3 nodes, and in doing so, we are able to minimize the false negative rate. If the sentinel node biopsy does not work, and that happens sometimes, we're not 100% sure why. Theories would include that there's fibrosis in the lymphatic system after the chemotherapy that prevents the nodes from either picking up dye or radioisotope. If it is unsuccessful, though, we should proceed with axillary lymph node dissection. Some individuals are performing a frozen section at the time of the surgery, and then proceeding with axillary node dissection at that time if the node is positive, but that really prolongs the surgery, and most of us are not doing that. So individuals that are clinically node positive and pathologically node positive, but have a complete clinical response following neoadjuvant therapy, should again proceed with sentinel lymph node biopsy. And we do know that the PCR rates in the breast correlate well with axillary PCR rates. And you can see that the PCR rate is quite variable depending on the hormonal status of the tumor. So in hormone receptor positive, HER2 negative, less than 20% of patients are having a complete response. However, with HER2 positive and triple negative cancers, we see a much higher PCR. So we can support doing a sentinel lymph node biopsy after neoadjuvant chemotherapy. And again, if we're going to do that sentinel node biopsy, we need to make every effort to reduce the false negative rate, because that's always a concern. Are we missing nodes that may guide our treatment? That's where targeted axillary node dissection comes in. So targeted axillary dissection, what that means is you're doing a traditional sentinel lymph node biopsy. However, you are also aiming to remove any abnormal nodes that were marked either pre or post neoadjuvant chemotherapy. So usually that is done with a clip, and at the time of the surgery, we can use ultrasound guidance to identify the clip, or we can inject those nodes with a radioisotope preoperatively and remove the node. We do intraoperative specimen x-rays to make sure that we have removed the targeted nodes. And we know that this reduces the false negative rate quite significantly down to 2 to 12%. And surgeons have always sort of held this 10% false negative rate as the standard, so we're well within that. If we do the targeted axillary dissection, we're also more likely to get 3 or more lymph nodes. And interestingly, in studies, we found that 75% of the sentinel lymph nodes that we remove actually contain that abnormal node anyway. There's no long-term evidence currently that targeted therapy is better, but a recent study shows that the majority of European breast surgeons have now adopted targeted axillary dissection in this setting. So those that are clinically node positive pre and post neoadjuvant therapy should currently undergo an axillary lymph node dissection. We don't have the evidence long-term yet to say that we can get away with sentinel node biopsy. So although the omission of axillary lymph node dissection is becoming increasingly accepted, again, we need the evidence. Those that have clinically node positive and pathologically node positive tumors and post-sentinel node, the the nodes are positive as well. Axillary lymph node dissection remains the standard of care in that circumstance. One thing that has changed is previously, in the event where isolated tumor cells were the only cancers identified in the lymph nodes, we would proceed with axillary lymph node dissection. That is no longer warranted. So isolated tumor cells do not mean proceed with axillary lymph node dissection. What do we do if we need to do an axillary dissection? we should, number one, advise all of our patients at the time of surgery that even though we're aiming to do a sentinel lymph node biopsy, we may proceed with axillary lymph node dissection if there's an issue. So again, for axillary dissection, we remove all of the level 1 and 2 lymph nodes. So level 1 lies lateral to the pectoralis minor, level 2 lies deep to the pectoralis minor. It should be considered if the patients are clinically node positive or pathologically node positive after neoadjuvant chemotherapy. If our sentinel lymph node biopsy is not successful or we obtain fewer than 3 nodes, then we should consider axillary node dissection again. Some studies would suggest if the clip node is not removed, then again, consider complete removal. And if you are doing frozen sections, obviously, if it's positive, you should convert to an axillary lymph node dissection. We do know that neoadjuvant chemotherapy is an independent predictor of lymphedema after axillary lymph node dissection as well. So all of these patients should also be considered for radiation. So what we really don't know at this point in time is whether radiation to the axilla is as effective as surgical excision. And to date, most of the studies looking at sentinel node biopsy have indicated that, but we're still waiting for the results. Alliance has showed that there was no difference, we're waiting for the results of those studies to make a final decision. Thank you.
Thank you so much, Prof. I think we'll move on to the next speaker. But before that, I would like to congratulate my hospital team, my amazing friend, for this excellent conference. Very well put agenda. So we'll move on to the next speaker. It's who's going to talk about early breast cancer and the landscape of adjuvant therapies in high-risk hormone receptor-positive, HER2-negative early breast cancer. Dr. Farhat Raja, who's a consultant medical oncologist specializing in breast cancer and acute oncology at UCL. She's one of the experts from the UK. Welcome, Dr. Raja. Please go ahead.
Thank you very much. It's a real pleasure to be here. I left a very wet, rainy and grey London to be here in sunny Dubai. Right, let me see. Okay, so I'm going to run through early breast cancer and adjuvant therapies. We will cover what the issue is with late recurrence risks, where we are in our current solutions with CDK4/6 inhibitors, emerging biomarkers with ctDNA, what is the evidence that we have so far, and the next generation. So ER-positive, HER2-negative breast cancer is clearly the most common subtype. We're very much aware 70% of our cancer is ER-positive, and the majority are diagnosed at early stage, which is really good news because we can really cure these patients and make a big impact in this very high prevalence disease. It's almost been called an epidemic, breast cancer, but if we can even deliver marginal clinical gains, then we are actually making a big impact on our populations, and that is important at a global level. Hormone receptor positive breast cancer has a very long natural history. So what that means is that late recurrence becomes an issue that we are facing for many decades with our patients. If we look at the ongoing risk of late recurrence, what we know is that there is this very high level of cumulative risk even out at 20 years. If we have high-grade patients, in the top graph here, we can see that there is a 17% cumulative risk at 20 years, but it's still 10% for our low-grade patients. Then if we come to the lower graph here, what we see in those patients who have 4 to 9 lymph nodes or N2, they have a cumulative risk of recurrence of over 50%. So these are really high numbers that we are dealing with. How have we dealt with it so far? We've improved overall survival in incremental ways. First of all, the advent of tamoxifen more than 50 years ago, we improved risk of death by reducing it by 30%, improved mortality at 15 years by nearly 10%. We then had a better class of drugs with the aromatase inhibitors. We reduced the risk of death 15% with these and improved breast cancer mortality by a further 2%. We then extended the treatment, so manipulated the data that we had and had a further smaller incremental benefit. And then we introduced ovarian suppression in our premenopausal patients with a further incremental benefit of 5%. So we have done everything we can to optimize single agent hormone treatment in reducing the risk of recurrence. Then we had the entry of the CDK4/6 inhibitors, which we had brought from the metastatic setting into the early setting. We've had a number of clinical trials, and not all of them have been positive. The reasons for that has been rehearsed very well, but we have the Marquis and Natalie trial. So this is our standard of care. We're all aware that Marquis is a very high-risk patient. I've tended to start calling this the ultra-high risk to try and differentiate some of the risk stratifications. We had our main cohort, which had more than 4 positive lymph nodes or 1 to 3 positive lymph nodes with a second high-risk feature, such as a large tumor size or a grade 3 tumor. We had this very small cohort, less than 10% of the Marquis criteria population, who had a high Ki67 of more than 20%, as well as having a node positive. Then we come to the Natalie trial, and the Natalie trial really broadened the number of patients that we were treating with CDK4/6 inhibitors. So we encompassed the whole Marquis population, and then we had this node negative population, which included those patients who were grade 3 but T2, but also grade 2, high Ki67, high oncotype score or genomic risk, and they were also eligible. So coming to Marquis, you're very familiar with this trial. Reminder that this was a very large study, more than 5,500 patients randomized on a one-to-one basis to abemaciclib and endocrine treatment, which could be tamoxifen alone or endocrine treatment on its own. And these are the updated IDFS results, which were presented by Stephen Johnson at ESMO last year. And we see this very steady, very stable, sustained benefit of 6.5% at a median of 6.3 years. So a really good result for us, and we've moved the needle forward really with this. However, it is sobering to see that despite the benefits that we've had, nearly a quarter of the patients in the abemaciclib arm are still recurring. So although we have made a lot of strides, there is still a long way to go, despite this strong hazard ratio of 0.7. Coming to overall survival, this was presented for the first time, excuse me, a significant improvement, a statistical significant improvement in overall survival. The absolute number is small, 1.8, but I think seeing a significant improvement in overall survival is a feat in itself. So a hazard ratio of 0.8, and that equates to a nearly 16% risk of reduction in death. When we are treating our patients adjuvantly, what are we trying to do? We're trying to stop them from developing metastatic disease, and in the Marquis study, 30% fewer patients were living with metastatic disease in the abemaciclib arm. Now, I'm not somebody, and I think as a community, we like to use our best drugs up front. We want to treat our patients and ensure that they have the greatest chance of cure. However, with a quarter of our patients recurring, even with CDK4/6 inhibitors, what do we do when they recur? So these data were presented for the first time, and what we saw, that those patients who were recurring, a third of them were going on to have chemotherapy as their first-line metastatic setting, but a third were still having CDK4/6 inhibitors. Now, when we split up those patients further and look at those patients who were early recurrers, what we saw was that nearly half of those patients were receiving chemotherapy as their first-line treatment, whereas nearly half received CDK4/6 inhibitors at the first line when they were a late recurrer or more than a year after completing the CDK4/6 inhibitors. So the differences in those patients who were recurring in the Monarchy study was really in the early recurrers, with the late recurrers having very similar treatments given to them. The Natalie study, another study that you are very familiar with, a reminder again, 5,100 patients randomized to ribociclib at the lower dose of 400 milligrams with an aromatase inhibitor alone, or aromatase inhibitors in the control arm. These results were also updated, presented at ESMO, and the 5-year updated results again, a very steady improvement, 4.5% at 5 years. And you'll see that the figures are much better in this lower risk population. So 85.5% were recurrence free at 5 years compared to 81% in the standard of care arm. So looking at these key secondary endpoints, what I would draw your attention to, if I have a pointer here, is that the stage 2 and the stage 3 patients benefited, as did the patients who were node positive and node negative as well. And then what we saw were the overall survival data presented, and you can see that there is this small benefit of 1.6, which is not statistically significant, and we will await to see what this shows with more mature data. Now, we are very much aware of the improvements with the CDK4/6 inhibitors. It's changed our treatment and our standard of care, but has it? This is a poster which was presented at the Miami Breast Cancer Conference last year, and it caught my eye because I was really shocked to see these results. 60% of patients in the US, which I think we'll agree is high income, were not getting abemaciclib. So these are data from the Flatiron database. So these patients all would have been eligible for abemaciclib. 60% not receiving the treatment is a massive gap. And this is before we're thinking about the low-income countries or where access is not possible. So I think there is a lot of work to do globally in ensuring that our positive trials, our positive results are actually being passed on to our patients. Then we have this small but significant minority of patients who are BRCA positive. What do we do for them? Do we choose olaparib or do we sequence? And the Olympia study did have ER positive patients. The high-risk ER positive patients formed about 20% of that population. The neoadjuvant patients who had chemotherapy, if they had significant residual disease, so a CPS score of more than 3, then they were enrolled, as were patients who had 4 or more lymph nodes as well. So a year of olaparib. And you can see here on the right, these are the ER PR positive patients, and we can see this strong hazard ratio of 0.681, an improvement in IDFS with olaparib. Now, in our practice, where we can, we do sequence olaparib with a CDK4/6 inhibitor. That, at the moment, is only possible in the private sector as the National Health in England. I've got somebody here from Scotland, so I really don't need to be speaking for Scotland, but certainly in England, we are not able to sequence in the National Health Service. So coming on to early detection and minimal residual disease, I don't know about you, but I don't think a day goes by without a patient asking me about this testing. This technology is very readily available now, and patients are able to access it even without us. They can go online and get tested. And these are results from Monarch-E. This is a translational biomarker, and this is looking at those patients in this biomarker cohort, which, by the way, was enriched for IDFS events. So we have our high-risk population in Monarchy, and these were even more high-risk because these were of the IDFS population. And what we see is this huge difference in recurrence-free or invasive disease-free survival of those patients who are ctDNA positive, with 80% of them recurring. But then it gets even more interesting. So if we look at the dynamics of the ctDNA, what we see is that those patients who are positive and remain positive, 100% of them relapsed. I mean, that is quite extraordinary. Then who were those patients who were positive but became, sorry, who were negative and became positive, also have an abysmal survival with nearly 90% recurring. There was some good news in that those patients who cleared their ctDNA had a fairly good outcome, with nearly 60% of them being recurrence-free, and the patients who did best were those who were ctDNA negative all the way through. So ctDNA testing is got to become part of what we do in adjuvant treatment, and in helping us discover which patients are going to do very poorly, because what is clear is that the detection of ctDNA is a very, very poor prognostic marker. However, in this very high-risk population, less than 10% did have ctDNA positivity, rising to 17% at any time during the study. So it's clear that it is uncommon in patients, which is, of course, good news given its very poor prognosis. And then these are the PALIS data. So this was presented at San Antonio just in December, a few weeks ago. And although the PALIS study was negative, there's a very rich translational work that is going on with this study. And this looked at ctDNA, both at cycle 1, cycle 6, at the end of the study, treatment at 2 years, and then 5 years, 7 years, and 10 years. This was a random cohort. It was not enriched for patients who had IDFS events. And we see this very large difference in patients who are ctDNA positive at baseline, hazard ratio of 15. I mean, these are extraordinary numbers. And what we see is that nearly 75% of these patients are recurring if they were ctDNA positive at baseline. At the end of study, those patients who were still ctDNA positive, what we're having is more than 70% of them have recurred within the first 3 years, a very high hazard ratio of 21 again. In this population, the baseline ctDNA, those patients who were negative, 92% of those patients were negative, and they had excellent outcomes at 5 years, being distant recurrence-free interval rates of 93%. However, those patients who were positive, which was about 8% of that whole population, they had poor outcomes with a 5-year recurrence-free interval of only 28% and very large hazard ratios. So coming to the next step, where are we going? And that is with our oral SERDs, or giredestrant. There were a number of clinical trials that were presented last year with giredestrant, and this one was in the early setting. So giredestrant is a potent next generation oral SERD. It has full ER antagonist activity, and it's designed to really drive deep and sustained inhibition of ER signaling, both ligand dependent and ligand independent. So the lidERA study, or the leadership study, was a global multi-center phase 3 trial. It took high-risk patients and intermediate-risk patients. So it did have some stage 1 patients, and those patients had a tumor size of 1 centimeter, but they also had to have a second risk factor, which was grade 3 or Ki67 of more than 20%. They were randomized between giredestrant 30 milligrams or standard of care. And these are the baseline demographics, and I think it's worth pointing out a few things. So 40% were premenopausal, 60% were postmenopausal, and we had nearly 80% of patients who were node positive, and nearly 80% of patients who were stage 2 and 3. So mostly high-risk patients. And these are the primary endpoint, IDFS. And what we can see here is, I mean, it was quite hard to see in this, but I used to work with a professor who said, can you get your credit card between the Kaplan-Meier curves? And I'd say we can here. So we do have a difference. And just in case you couldn't see it, this is inset with the y-axis starting at 70%, and we can see that the difference starts fairly early, and then by the time we get to 32 months, we've got this IDFS difference, which equates to a 30% reduction in the risk of an IDFS event with a hazard ratio of 0.7. Distant recurrence-free interval as well, a similar magnitude of benefit, hazard ratio of 0.69, and a 31% reduction in the risk of developing metastatic disease. So this is a small benefit, but I think it is a milestone. We have a new group of drugs that we will be using as soon as they're approved. It's the next step that we have taken in our endocrine treatments. Overall survival is incredibly early. This is 32-month data, so to look at survival is really too early. It is worth pointing out the toxicities. It's a new class of drugs that a lot of us have not really used, and really the toxicity was very good, well tolerated, and no different or greater, I would say, than the aromatase inhibitors. Arthralgia rates, hot flashes were very similar. However, the discontinuation of giredestrant was actually less compared to the aromatase inhibitors. However, there is an issue here. Lidera has occurred in the era of CDK4/6 inhibitors, and this is a problem that we keep having, that we are in a situation where our standard of care is moving so quickly that our clinical trials are not keeping pace. So this is an intermediate and high-risk population. However, we had 16% of patients in this study who just had tamoxifen, even though 80% of these patients were node positive and more than 30% had N2, N3 disease. So this population really should have had a CDK4/6 inhibitor, and they didn't. So what do we do with an oral SERD in this situation? I think this was a very good slide that Lisa Carey put together, and we can see if we compare what with our standard of care clinical trials at the moment. If we look at Monarch E at 2 years or Natalie at 3 years, we are seeing absolute differences which are very, very similar with the Lidera. So it clearly is an effective drug. It clearly will be something that we will be using, and it will be interesting to see when it gets approved. So where are we going with this? I think at the moment it's a little bit confusing as to what we do with the oral SERDs when they are approved, and this is the group of single agent oral SERDs that will be coming out with results fairly soon. We've got a very small abemaciclib combination arm of 100 patients in the Lidera study as well. But this is, I think, where the situation will become more interesting, where we are looking at the switch strategy. And I think that looking at camizestrant, elacestrant, and imlunestrant after we've completed the CDK4/6 inhibitors will probably where we will be seeing benefits and where we will want to be fitting these drugs in. 1 second to say that we can't just keep adding more and more drugs. We've got to look at more holistic ways. Exercise is repeatedly shown as a good adjuvant treatment in reducing risk of recurrence, but we are not implementing it. How many of us have exercise programs for ourselves, let alone our patients? Very few. So we must concentrate on this, and also the other factors to improve global health and improve things holistically for our patients, and not just keep adding drugs and improving profits. So where are we today? We have endocrine treatment, which we have fine-tuned, we have extended, we've added ovarian suppression. We're using adjuvant CDK4/6 inhibitors as our standard of care in our high-risk and intermediate populations, but accessibility, adherence, tolerability are critical factors, and our patients will not benefit if we don't address these issues. How is the landscape evolving? We've got oral SERDs that have shown already a benefit with the giredestrant and Lidera study, and I believe that this will be approved, and we will have to work out how we're going to use it, be that as a switch therapy or be that as an adapted therapy with the use of ctDNA. And I think we still need to continue focusing on de-escalation. So far, apart from using genomic assays to omit chemotherapy, we are not really de-escalating many of our patients. So thank you very much. I've had this time is up flashing at me for a while, which I've ignored, I think, very well. I apologize for that. Okay.
Thank you so much, Dr. Raja. That was an excellent recap of how to manage patients with high risk hormone receptor positive, HER2 negative early breast cancer. So we'll move on to the next speaker, my dear brother and colleague, Dr. Ibrahim Abu Ghaido, who is the CMO of Barjeel Medical City. Dr. Ibrahim is an expert radiation oncologist in breast cancer, and he has the training in Cleveland Clinic, Ohio, MD Anderson, and Harvard University. Welcome, Dr. Ibrahim.
Thank you, dear Aida. Congratulations. Good morning, everyone, and congratulations for organizing this great talk. I've been asked to shorten my talk just to make up for time, so I'm gonna disregard the last couple of slides, and we'll focus mostly on the updates in early stage breast cancer adjuvant radiotherapy treatment. I have no conflict of interest, so this is the outline of the presentation. So very simple, why do we need to add radiation? And the first question, so we know improve local control, improve local regional recurrence, minimize long-term toxicity, and also to preserve cosmetic outcomes and quality of life of breast cancer patients. So just a reminder for everyone, the Oxford meta-analysis have shown significant improvement adding radiotherapy to breast conserving surgery with almost half decreased risk of reduction. This has been proven on long-term also follow-up, as well as in the node-positive patients as well, and it has decreased the death. So we know that recurrences drop, breast cancer death has also reduced, and we can see this across all subgroups of breast cancer patients. So it almost reduces the recurrence by half. Also, one death is preserved for every four recurrences that happens in breast cancer. So again, I'm not going to bore you with this. What's happening in the short now, what we're moving to shorter courses of radiotherapy. We know from the standard, the current standard is actually hypofractionated treatment. And I'm moving, this is based on the UK START and the Canadian protocols. And it also showed that the 10 and 15-year outcome was as good. In fact, it was a better cosmetic outcome as well. So now it has been adopted even by ASTRO as the guidelines since 2018. Moving to ultra hypofractionated treatment, shorter courses, we have the results from the FAST and from the FAST forward trials. It's important to understand the value of FAST because the FAST is actually the one that gave us the radiobiological concepts of ultra hypofractionated trials. And we also have the FAST forward, and I'll present the ASTRO 2025 updates, which is the long-term updates from FAST forward. So the FAST trial, it is 5 fractions over 5 weeks, 1 fraction a week, and it compared 2 different fractionation. The important part is to remember that all these patients were eligible more than 50 years. The tumor should be less than 3 centimeters, accelerated node negative patients, and all they received whole breast radiotherapy. And also important to note that in this trial, a boost was not allowed as well, and lymphatic treatment was not allowed. So it included about 1,000 patients, and they did the follow-up. And for this follow-up, they have shown that one fraction per week has actually better outcome, but the toxicity was slightly higher in the higher dose. So just again, for the sake of time, we can see that all these compared, and this is all regarding the toxicity. These were published in JCO in 2020. So it allows for optimal dosing for 5 fraction. I think it's a very attractive protocol for patients who are living really far, cannot come on a daily basis, and who meet the criteria. And the 28 in 5 fraction is actually an appropriate alternative to no treatment as well. But more importantly and more interestingly, and this is where I take more time, is the fast forward trial, because this is very easy and attractive option for patients that come, rather than coming 25 sessions or 15 sessions of radiotherapy, now they can come on 5. And this is the updated slides from ASTRO 2025. The first paper came out during COVID at the 5-year outcome. A lot of people were skeptical in adopting it just because it's only 5-year outcome. And we know these patients might tend to recur in later years. But now I think with the long-term outcomes at 10 years, a lot of people started adopting it, including myself. So in this trial, this is a patient with invasive breast carcinoma, PT1 to PT3, N0 or N1, and 4,000 patients were included. So this is 4 times the number of patients in the FAST trial. And they were randomized into, radiotherapy trials are very nice and simple. There's the 40 in 15, which is the standard of care, 27 in 5, and 26 in 5. And they looked at the clinical assessment up to for 10 years with the patient-reported outcome measures, also measured very rigidly in this trial. The primary endpoint was ipsilateral breast cancer recurrence, and it was a non-inferiority trial design, and they also had a lot of secondary endpoints, which we'll be tackling through. So interestingly, the primary endpoint, here we can see that the patients who had received the 26 gray in 5 fractions it was a non-inferiority, so we cannot assume superiority of this trial, but they had actually a lower risk of ipsilateral recurrence, and the percentage was overlapping. So we can see that it's actually as good as the 40 and 15. And when you look at the recurrence-free survival, the curves are overlapping. The breast cancer-free interval is also all the curves are overlapping. Important to report the patient-reported outcomes, and this is where really breast and prostate cancer are very important to look at the long-term patient-reported outcome data. And in this data, we can see that the patient who received the 40 gray and 15 fractions had slightly less feeling of long-term breast hardness and firmer compared to the other fractionation. And in terms of the breast appearance, they were similar. Feeling that the breast is smaller is similar. The swallowing, the breast being swollen was slightly higher in the 27 in 5 fractions. So the takeaway message from the fast-forward 10-year outcome that is actually, this trial confirms that 1 week of whole breast radiotherapy achieved outstanding 10 years outcome with low incidence of ipsilateral breast cancer recurrence. And it actually confirms that 26 in 5 fraction is an appropriate standard of care for those patients. Now we're talking about de-escalation, and where are we in the area of de-escalation in early stage breast cancer? Because we know, I really like the first slides of the first that was presented by my colleague, Dr. Olga, about really tailoring the patient's treatment as well. So what is partial breast? So for the non-radiation oncologists in the room, partial breast is that when we don't treat the whole breast, we only treat the tumor bed with a margin around it. And it's actually a very well-established technique, and ASTRO has actually published a guideline about the eligibility criteria for partial breast. So this is kind of a slide that summarizes. So for patients with invasive cancer or DCIS, we look for invasive, they should be grade 1 to 2, ER positive, age more than 40, T1 and 0. For DCIS, it's low or intermediate grade, age more than 40, with a DCIS less than 2 centimeter, and these are considered suitable patients for partial breast radiotherapy. There is the borderline suitable, and there is the unsuitable patients where we tend to offer whole breast radiotherapy as well. So very important in this patient population that we see, we tend to see younger patients, so we really need to make sure that BRCA testing should be done before we offer partial breast radiotherapy in these patients, because BRCA positivity is never a contraindication for breast conserving surgery, but it is a contraindication or relative unsuitable criteria for partial breast radiotherapy. So we need to keep that in mind. So the ways of partial breast radiotherapy, the preferred and most acceptable partial breast radiotherapy outcome came from the Italian Florence IMRT trial, and it was actually a 30 gray in 5 fractions every other day, and then they modified it to every day. I've actually adopted this. Patients really love it. The cosmetic outcome is excellent, but you really need to look at the breast size as well, because there is the most trickiest part of this is how much normal breast is being irradiated, and we're giving 30 gray in 5 fractions, either every other day or every day. And then there's also other partial breast regimen. The import low is 40 in 15, but again, this is de-escalating the volume of the breast radiated, but the number of fraction is still 15. And there is also the brachytherapy. It is when we insert either seeds into the tumor bed during surgery, or we add a balloon, and there are different fractionations with that. I think the preferred regimen based on the guidelines is always the external beam, and it's less invasive, and it's actually showing better cosmetic outcomes as well. So again, we're talking about de-escalation. We know the trials about the boost radiotherapy is when we add an additional 5 fractions towards the end of treatment. We tend to do this in young patients as well, premenopausal, high-grade disease. But it's very important also that some patients might not require boost. So when we look at this very nice analysis from the HERA trial done by Dr. Abu Jawda and Dr. Yusuf Zaidan, and you can see that patients were analyzed who had an excellent response to neoadjuvant anti-HER2 therapy and had a complete response. You can actually skip the boost in those patients as well. So boost, it should be tailored as well. It's not for all premenopausal. We really look at response as well to neoadjuvant treatment. Now to talk about the extreme de-escalation, which is omission of radiotherapy. Sorry, I think, okay, yeah. So we know very solid data from the CAGB, patients more than or equal to 70. This is reflected in the guidelines. We have the PRIME2 trial from the UK, more than 65. This is reflected in the UK NICE guidelines. And so the radiation therapy omission does increase the risk of local recurrence. We know that, but without impacting survival. So we really need to look at who would really benefit from adjuvant radiotherapy. We included patients with early stage T1, ER positive, node negative, and clear margins. Very important and highlight is endocrine therapy compliance. A lot of patients, we assume that they're going to be taking endocrine therapy regularly and compliantly, but when you ask about the patient, there's a lot of trials comparing even the cost effectiveness of 5 years of hormonal therapy versus 5 fractions of radiotherapy. A lot of patients, including a lot of people in the room, will choose 5 days of radiation rather than 5 years of hormonal therapy. Also, when we're talking about the biomarkers right now, we know from the Lumina trial, this patient included luminal A patients with the Ki-67 of less than 13%. Also, studying the omission of radiotherapy showed no difference. And the idea used the Oncotype DX of less than or equal to 18 score with the patients group even lower, 50 to 69. And you can see also there is no benefit of added radiotherapy in these patients. Now, if you look at last year's ASTRO, this is an abstract that came out for patients. So this is from the NCDB analysis with patients with clinically T1 to T2 and 0 HER2 positive patients received neoadjuvant chemotherapy with targeted therapy and had breast conserving surgery with pathological complete response. So I know this is Dr. Saeed Rafi's favorite topic, those patients who had complete response. Do we really need to even give them adjuvant whole breast radiotherapy after breast conserving surgery? So this included 3,500 patients. Out of those, 367 had no radiotherapy, and radiation omission was mostly for patients with older age, more than 60, clinical T1 initially. And interestingly, by race, it was mostly seen in the Hispanic and Asian patients. And the survival data was available for 2,900 patients. Out of those, 270 patients had no radiotherapy. So again, from this analysis, this is not a prospective trial, but the radiation omission was not associated with increase in death. However, to study this in a proper phase trial, we have the NRG-BR008, which is a ongoing phase 3 randomized control trial for radiotherapy optimization in low-risk HER2 positive breast cancer. So this is exactly the same patient population. It's called the HERO trial. And it's for early stage node-negative HER2 positive breast cancer, T1 disease, or neoadjuvant therapy for T1 to T2. Tumor size should be less than 3 centimeters and 0 converted to YPT 0. And the primary endpoint is recurrence-free survival. And this study is still open to accrual. So as of now, adjuvant radiotherapy is still the standard of care post-breast conserving surgery, even in the setting of complete pathological response. Again, just because I promised to stick to time, I'm going to skip this part. This is for node-positive patients. about the value of regional lymph node radiation. But just to go quickly, the ASCO has a very nice guidelines for the indication of post-mastectomy radiotherapy. And just a few words about the very interesting Supremo trial that was published in the New England Journal of Medicine with those patients with intermediate risk node positive breast cancer, adding post-mastectomy radiotherapy versus not. It shows that for simple readers, for intermediate risk, you can actually omit post-mastectomy radiotherapy. However, please, 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 for everyone in this room, don't take this as a yes, no. If you look at the details of this trial, all patients with node-positive disease underwent axillary lymph node dissection, not sentinel lymph node biopsy in this trial. The minimum number of lymph node removed was 8. We know that these patients do not require axillary lymph node right now. If you look at the AMAROS trial that was nicely presented, you can actually omit axillary dissection in those patients with sentinel lymph node and adjuvant radiotherapy. A lot of those patients in this trial received chest wall radiotherapy alone. The current standard of care is post-mastectomy radiotherapy is for the chest wall and the lymphatics. And many patients, the Supremo, would not qualify for the post-mastectomy radiotherapy using the current guidelines. 25% had no negative patients. 41 had a single micro or macrometastatic lymph nodes with low baseline risk, and only 3% developed chest wall recurrence without radiation. So the amount of recurrence is very low. So currently the MA39 is the study that's studying this in a prospective trial, and it's using the Oncotype DX as well as a biomarker. So the ASTRO actually released this very nice scientific statement that post-mastectomy radiotherapy remains the standard of care for these patients as well, pending outside the enrollment of the MA39, pending the results of this trial. So again, I will keep this for Dr. Aida's conference, I promised her, which is happening in 2 weeks. So congratulations also for your great conference. So finally, this is my conclusion slide. Adjuvant radiotherapy is the standard of care post-breast conserving surgery. However, we are in the era of de-escalation, decreasing the number of visits for the patients, hypofractionation, ultra-hypofractionation. In the de-escalation era, boost can be omitted in HER2-positive breast cancer patient who had a complete pathological response. There is no data supporting the omission of radiotherapy post-breast conserving surgery in pathological complete response pending the HERO ongoing trial. Partial breast radiotherapy is a very attractive standard of care for patient who meets the very solid criteria that we have there. Radiotherapy omissions also for selected patients based on the Lumina and IDEA trial should really keep in mind as well. And for T1 to T3 and positive standard of care post-mastectomy remains radiation. I'm talking about upfront setting. Post-neoadjuvant setting, that's a different discussion. I will leave it for next meeting. With that, thank you so much, and I wish you a very pleasant stay in Dubai. Thanks.
Thank you, Dr. Ibrahim, for coming to the time. Can I ask all the speakers to please come on the stage for the panel discussion? And I would also like to invite Dr. Manal Abdurrahim. She's a consultant anatomic pathologist and chief of anatomical pathology division Dubai Hospital. Dr. Irfan, consultant breast surgeon, and Dr. Alia, consultant radiologist and head of radiology Dubai Hospital. And Dr. Basil Jalal, sorry. Okay. Thank you. So I would just like to start with Dr. Alia, if I may, because that's the first test patients do if they have suspected breast cancer, especially the mammogram and ultrasound. So we've seen the talks, we're using neoadjuvant chemotherapy quite a lot in early breast cancer, especially in HER2-positive and triple-negative breast cancer. Surgical, obviously the imaging is very important because all the neoadjuvant treatment decisions are based on imaging, based on the T stage and nodal stage. We also see the data suggests there is around 30% discordance between what we see on the clinical imaging and what we see pathologically post-operatively, especially in the ER-positive patients who do not have neoadjuvant chemotherapy. So how do you think we can minimize this discordance, Dr. Ali?
As well recognize the percentage you just said. we can reflect this by decreasing this by pre-treatment MRI, in addition to mammogram and ultrasound, and also by standardize the report to include the non-mass enhancement, and by ensure that the clip insertion pre-treatment, and also by finalizing the management and MDT discussion.
Okay, that's great. Thank you. And coming to the surgical side of it, excellent talk by Dr. J. Dr. Fan, what do you think is the verdict? Patients who have node-positive disease preoperatively, they have neoadjuvant chemotherapy, and then before surgery, we do ultrasound and mammogram, they are node negative. So how do we treat? I mean, I know in our practice, we still go ahead with axillary dissection for those patients. And what do you think the current evidence is?
I think looking at the evidence of the data, we are going more towards de-escalation nowadays. And I think it's very important that we adapt the new data in our practice. Now, if we have a patient who has moved from being node positive pre-neoadjuvant to radiologically and clinically negative after neoadjuvant, I think it's sensible if we have the right criteria to adapt the sentinel lymph node biopsy in this case. And obviously, we have to pick the patients through the MDT to make sure that we have the setup data to do this by, if we're doing sentinel lymph node biopsy, there was no clip node, to make sure we take the 3 lymph nodes out. And we obviously make sure that the disease initially was not very high burden in the axilla. So if we do that, then I think it's quite sensible to do it. But if we have the clip node, I think, which is very important beforehand, that we adapted the targeted axillary dissection method to reduce the false negative rates, which we really want to make sure is there.
And how do you select out patients for sentinel lymph node biopsy versus targeted axillary dissection? Dr. Angel, if you can comment on this. Jay?
So with the targeted techniques, as I mentioned, most of those abnormal nodes will show up in the sentinel lymph node biopsy already, but I think just to be certain that we are minimizing the false negative rate, we do need to include those abnormal nodes that we have targeted with a clip preoperatively through the radiology department.
Okay, thank you. Dr. Manal, just regarding pathology, we moved away from binary reporting of PCR. We used to report PCR versus no PCR. Now you're doing residual cancer burden for reporting. So patients who have, in cases of extreme heterogeneity, where a large tumor bed contains only isolated tumor cells, how do you report, and do you normally repeat the markers, especially ERPR, HER2, after neoadjuvant chemotherapy postoperatively?
Okay, thank you. Great question. I'll start with the first question, which is assessing the RCB scoring. So obviously, for accurate scoring of residual cancer burden, it always ultimately starts at the initial stage with grossing the specimen. So sampling and adequate sampling is absolutely critical to identify the correct area of tumor and adequately sample it. And that is often guided by our colleagues, the radiologists, who put in a tissue marker or a clip, which actually helps us identify the area in cases which there is a good response. So to answer your specific question when it comes to tumors that have multiple areas, so for staging, it's different than for residual cancer burden. For the residual cancer burden, we measure the area, the tumor bed is where the tumor used to be, with the areas of fibrosis in between. And the measurement included in the RCB is two-way measurements, so the two greatest dimensions, from the start of tumor cell till the end of the tumor cell. So the area in between is included in the RCB calculations. However, this is not to be confused with staging, because for staging, you're supposed to only measure, if it's multiple foci, the largest contiguous focus that is used for staging purposes. And then we can get into what is contiguous, the definition of a contiguous measurement, which For pathologists, we use a lot of parameters. I will not bore the oncologists with it, but if you want me to go through, I can go through it. Um, to answer your second question about biomarkers, so we don't routinely repeat biomarkers in post-neoadjuvant therapy. However, there are certain scenarios which we must. So for example, if the biomarkers were negative initially, then ultimately we do have to repeat them, because ultimately what you're looking for is having more options for treatment options. So if something was reported as negative and it was positive on a resection, then you do have other options for therapy, for example. So in cases that are negative, we do repeat them, post-neoadjuvant therapy. Also in cases where morphology might be different, so you might think there's tumor heterogeneity. The morphology can be a key as to that perhaps there is tumor heterogeneity. We would repeat in those cases. And then if for whatever reason the initial biopsy had technical issues or any concern about the testing itself, that we would repeat as well.
Okay, thank you. Dr. Aida, can you please take over?
Okay, so thank you so much. That was an excellent comments, discussion, feedbacks on the questions. So we'll move on to medical oncology right now. And we have amazing 3 medical oncologists in the panel as well. So in overlapping patient population, how would you decide between, adjuvant the 2 different CDK4/6 inhibitors? Dr. Farhat, maybe we start with you.
I think I would tend to go with the ultra high risk population. I would tend to go with the monarchy data. We have more data with it, longer, sustained, and I think I would prefer also 2 years of treatment rather than 3. However, options are good, and it allows us the ability to personalize treatments and tailor it to each patient. And therefore, if a patient wasn't tolerating abemaciclib or had a preference, I would absolutely change them to ribociclib, taking into account also their comorbidities, etc. So yes, I'd start with abemaciclib and then move on if need be.
Excellent. I totally agree with you. Thank you. Any further feedback, Dr. Olga?
I totally agree with Farah. Patient comorbidity is a key thing. It's good that we have options. I think that most of the patients that come to the clinic after using ChatGPT and Google, and it's good to make sure that we have data and because they will ask, okay, why you have not offered me the drug that offers overall survival? You see, everyone's very well aware of the data now, and I think the fact that we have overall survival benefit, which is really difficult to actually achieve for adjuvant drugs. First selection should be for high-risk patients, adjuvant abemaciclib, but of course there will be patients that they're not going to be able to tolerate, and therefore we can choose to the ribo.
Dr. Saeed, do you have a comment or a question?
A question. Good morning, everybody. So I don't know whether in your centers you have adapted to do SAND or enzema basically surgery where you do not actually do sentinel lymph node biopsy for patients who have low risk disease, or they have an ultrasound scan which is originally negative. But if you look at SAND and SEMA, around 15% of patients who did not actually have the sentinel lymph node biopsy, I'm talking about the control arm that they did, actually they were the sentinel lymph node positive. So they became N1. So how do you marry these 2 things together? The CDK4/6 inhibitor in the absence of correct staging at the beginning.
So I think that's an excellent point. And de-escalating the axilla, I feel, where it is appropriate and possible, certainly should be done, because we know that patients have better outcomes. And having the two CDK4/6 inhibitors, I think allows us not to worry about going fishing for more lymph nodes just in case those patients require abemaciclib. So I think in those situations, most of those patients would be eligible for ribociclib, and I would proceed with ribociclib for them. I wouldn't want to subject a patient to an axillary lymph node dissection just to see if they were eligible for abemaciclib.
And if I can make an additional comment, I think it's a matter of time that we will see a benefit from adjuvant ribociclib. It's just that it's a study that started much later for the monarchy, so we just need to wait and see. But it's an excellent point, and using the pre-diagnose, the pre-starting treatment, imaging, whatever this might be, mammogram, ultrasound, and especially with having access to even to node negative, we can give ribociclib, then de-escalating the axilla should remain the gold standard.
Those patients, they are not actually going to be eligible because, you know, SAND and INSEMA, they put patient T1 disease, and basically they omitted sentinel lymph node biopsy if the ultrasound scan was negative. What 15% of those patients who are T1 turned out to be N1. So T1 and 0 wouldn't be eligible for any adjuvant CDK6 inhibitor,
T1.
whereas T1 and 1 would be. So it will be very difficult really to decide.
Excellent point. Thank you so much. I think this is a debatable area as well. Thank you, Dr. Said. We'll move on to the next medical oncology question for Dr. Basil. With Destiny-05 data now established, and which specific high-risk HER2-positive breast cancer patient with residual disease would you consider TDM1 versus TDXT, or TDXT completely replace it as a new standard?
Good morning. Thank you. Great question. I mean, I think we are going to start the answer by looking at the neoadjuvant setting. There was a very nice editorial actually just published by Paolo Trentino about the de-escalation of carboplatin in the neoadjuvant setting. And I think the whole idea is that the biology will supersede anatomy. And I think with understanding the disease, even in the pre-surgical time will make us maybe able to escalate or de-escalate the treatment appropriately until the surgical point. For adjuvant setting, I think once we reach, the reason I'm saying that now that we have Destiny 11, and then maybe we are having less patients with node positive disease, then maybe there will be less needs for need for, let's say, TDXC in the adjuvant setting. But if we reach the point of a node positive disease, it's YPN plus, okay, in this after surgery, then those are very high risk cases of recurrence, and then that's where I would definitely implement TDXT versus TDM1. I mean, still a TDM1 is a very less toxic, more practical, more tolerable treatment, as we are all aware, with less concern of treatment-related side effects, as we know with the pneumonitis related to TDXT and so forth. And hair loss and all this, we want our patients to go back as much as possible to track and feel like normal again. And so I wouldn't definitely include it to all patients or be jumping into it in all kinds of patients. But for the YPN plus, regardless if it was N0 or N plus to start with, those patients who I would switch.
Thank you. I totally agree. Careful consideration should be given. I mean, as I said during my talk, the DB11 lacked carboplatin. And if we look back at the Trifaena study results, we have seen that the majority of the patients in all three arms, they achieve like 60% CR rates, 67% with DB11. So ideally, I would like to see in the comparator arm having carboplatin, docetaxel, and fesco, trastuzumab, pertuzumab. So, and if this gives us better results, why not? But not for everyone. 4 cycles gives me a bit reassurance in terms of the ILD, but adapting TDXT on the adjuvant setting instead of TDM1, I would certainly keep that for my really high-risk breast cancer patients, because this is for 14 cycles. And I hate, sleeping every night thinking about what is going to happen with the ILD. ILD 4 cycles, yes, manageable. ILD 14 cycles with TDXT, it will give me huge anxiety, but I would still use it for patients which are heavy nodal positive and with a lot of residual post-neoadjuvant chemotherapy.
Excellent. Thank you so much. I think we'll move on to the radiation therapy. Dr. Ibrahim, if a patient achieves a PCR in the breast and axilla after neoadjuvant chemotherapy, can we safely omit nodal radiation in those who were initially clinical N1? That's very relevant.
So this is your B51 results. So the answer is yes. There's B51 is a solid. It's been reviewed, criticized, and but yet the evidence is there to stay. So those patients with node positive, and just keep in mind this is a study of omitting regional lymph node radiation, not breast radiation post breast conserving surgery. So just as that's important. But in the setting of mastectomy, with those patients who meet the B51 trial, I think this study is gold. Cannot refute it. Thank you.
Thank you, Dr. Ibrahim. I think for the sake of time, we'll have to close the session. There was an amazing discussions presentation. Thank you so much.
Okay, we have now satellite symposium. I would invite Dr. Basil Jalnath, consultant medical oncologist in Cleveland Clinic, breaking new grounds in ER positive, HER2 negative breast cancer.
All right, good morning, everybody. Thank you for the intro. So we'll move on. I will be sharing the updates in the treatment of, giving new grounds in the HR positive, HER2 negative early breast cancer, zooming in the updates for the trial of Natalie trial for using ribociclib in this setting. I think we've covered a lot of great information about this indication, so I will be quick for the sake of time. So this has been presented by Dr. Crown at the ESMO ESMO event in 2025, showing the 5-year updates for use of ribociclib in the adjuvant settings. Just to a quick reminder, this is the trial that we're aware in the patients who are node positive or node negative with some criteria being high risk patients who are randomized between getting or not getting ribociclib plus the standard not standard plus aromatase inhibitor in this setting, and with the primary endpoint IDFS and with secondary endpoints that we are all aware of usually for the adjuvant settings. So its beauty of this drug is that it is being indicated for an extended high-risk cases, including N0s and along with the N1s. And this is important because it gives us more opportunities for escalating treatment when needed for those patients. Also, the beauty of the trial that able to allow to include this treatment even within a year of the treatment started on ET. So for example, for patients who's been on olaparib, then they can be started on ribociclib after. Then another thing is, of course, as we mentioned, inclusion of the N0 disease. The other one is, sorry, the screen is going out. All right, here we go. And patients had a lesser dose of ribociclib of 400 milligram compared to the advanced breast cancer setting where we give 3 tablets or 600 milligram. This allowed for lesser toxicity, including LFTs, neutropenias, or arrhythmias. The 3-year treatment, which some patients do ask for it, they are well-educated, patients are worried if they are high risk to get less treatment than more, but I mean, I'm not comparing 2 to 3, but if the patient wants more, this is a 3-year treatment. The ovarian function suppression was more strict and mandatory for the premenopausal patient, and the use of the expected escalated treatment for the endocrine arm, which is with aromatase inhibitor versus tamoxifen. But I mean, with a drawback is that some patients who cannot tolerate or cannot use aromatase inhibitor for a reason or another, then we need to do maybe with abemaciclib. So this is the 5-year update as we've seen it before and before. Again, it is a statistically significant 28% reduction in the risk of developing an IDFS event, and with a delta of 4.5. So there is a clear carryover effect after 3 years of treatment. And clearly also it improves distant or reduces distant recurrence. So this is a true improvement in IDFS, which is a reduction in recurrence in all different types of organ involvement, lung, liver, bone. So it's not specific for a certain in this matter. What matters here more even is that the N0 became statistically significant IDFS reduction, which is important. Not that I doubted it, I thought it is a matter of time to show that based on the early signals that we had seen in the 4-year, but now it is statistically significant at the 5-year, and all the pre-specified also random factors are also have been benefited or statistically significant. Also, okay. All right, let's go back. All right, so to be more specific, so in the N plus or N zeros, we've seen significant reduction, even probably a bit more clear in the N0 disease. And that tells you not just like, okay, let's use it for N0, it's the high risk N0s that behaves like stage 3s, true stage 3s, not high risk that would benefit from the treatment. And still clear that there is a 15% reduction, 15% recurrence in the aromatase inhibitor alone within 5 years, showing you that this disease is a high risk for recurrence. And also to be, putting things into perspective, this is the 4-year versus 5-year data showing more and more carryover effect in the reuse of ribociclib in this matter. This is more details that wasn't maybe present in ESMO, but it's worth sharing, which is also benefit regardless of the menopausal status, premenopausal versus postmenopausal, also for stage 2s versus stage 3s when I use this. Also, I believe DDFS and DRFS are very important outcomes that we need to look into, maybe even closer to the overall survival than IDFS. So and shows also a statistically significant 29% reduction in the risk of developing an DDFS with a delta of 4.3 gap in the curves, and tells us that we are closer and closer to reach maybe the overall survival with the use of the ribociclib. And this is where it is at now. So you see the hazard ratio of 0.8 with a delta of 1.6, numerically almost the same as what we see in the monarchy, with the hazard ratio with confidence interval of almost there 1.003. So I think by now maybe it's a matter of months, okay, where if we take any new cutoff that that could be an overall survival benefit. Until then, it is numerically close to what we see maybe with the monarchy data, but it is not statistically significant. And so we can see that over, with time, comparing which cutoff you use between the 3-year, 4-year, and 5-year, we see more and more shift toward improvement in the survival status. And so those are all the numbers that I have just shared with you, the differences in the hazard ratio and IDFS, which was the primary endpoint, versus other endpoints that we are coming closer to showing OS, which is still just numerically significant. So in conclusion, ribociclib plus aromatase, non-steroidal aromatase inhibitor demonstrated durable IDFS benefit versus hormone therapy alone, with a 28% relative reduction in the risk of recurrence of death after a median of 2-year post-RIB. And so this is the carryover effect that we will always like to see. Now it's about 4.5% delta for 5-year rate. There is a sustained IDFS benefit with ribo plus non-steroidal AI was observed across subgroups, including those with high risk and zeros. At the 5-year analysis, ribociclib plus non-steroidal AI demonstrated a clinically meaningful reduction in the risk of distant recurrence or death, so of about 30%. And ribo non-steroidal AI showed a continued numerical trend for improved overall survival. Data is continue to mature, continue to become closer and closer to this becoming significant. There's no safety data signal that was different than what we are aware of. With that, I think I would conclude my presentation.
Thank you, Dr. Basser, for the very nice symposium and talk. And I present myself. I think you know me. I hope so. So I'm Dina Hamza, Medical Oncology, Dubai Hospital. Thank you for coming, and thank you for making this happen. This is our first conference by the Dubai Health Team and Dubai Hospital Multidisciplinary Oncology Board members. So I'm honored to talk about CDK4/6 inhibitors in early breast cancer, specifically about Verzenio and the data coming from the ESMO 2025, which is the OS data and this breakthrough in early breast cancer treatment.
Welcome and thank you for dedicating your time to attend this meeting. At Lilly, we are committed to following the letter and the spirit of laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label approved in our country. Any questions related to unapproved drugs or indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and we wish you a good meeting.
So this talk is sponsored by Lilly, but there are no other conflicts to be disclosed. So we all know all quite well and presented by my previous colleagues and our beautiful international speakers who talk about the early breast cancer, Dr. Raja and Dr. Olga. And we have talked about the importance of maintaining the survival in specifically in early breast cancer. And I believe that's why even the monarchy was designed. The screen is not working. So this was presented earlier by Dr. Raja. She has very nicely show us the data for the importance and how the hormonal therapy had improved survival. So for example, tamoxifen, since the 1980, we have the data, and it was the early and the only trial which had showed OS data, but this OS benefit came after decades. So we waited more like 15 to 20 years in order to have like an OS benefit with a hazard ratio of 0.8. Followed by that, we have the aromatase inhibitors, and these did not improve an OS, but they have improved the risk of recurrence. Even the 5-year extended hormonal therapy, this improved in specific group of patients, and so is the OFS. So the question is not whether the hormonal therapy works or no. We know quite well that it works, but how can we improve that specifically in patients? We know quite well that these patients are being curative intent and not palliative intent. That's why specifically the monarchy trial was designed. And as we all know quite well, this has been designed looking at, as mentioned by Dr. Raja, an ultra high risk population whom we usually worry about them in the clinic. And we know quite well that there is a biology of the tumor which is quite aggressive, although it's hormonal positive and a high burden of the tumor. Talking specifically about cohort 1, more than 5,000 patients were randomized to either the standard of care, 1-to-1, or abemaciclib and the standard of care, more than 4 positive lymph nodes, or 1 to 3 with grade 3 and tumor size more than 5. We know quite well that this trial is positive. We have been using it for years, and because it met the primary endpoint, which was the invasive disease-free survival. In 2025, we have presented the key secondary endpoint, which is the OS date. So let me tell you that this OS, we have seen the tamoxifen, they waited 15 years in order to get an OS data with a hazard ratio of 0.8. Here, we have a follow-up of 6 years, which means that these patients were 4 years after the completion of the abemaciclib for 2 years, whether we're going to see an OS data or no. So this trial was positive in the intention to treat, and we can see clearly that we have an OS benefit of 0.84, which means that the risk of death was reduced by 15.8% compared to the endocrine therapy alone. This benefit was across all the pre-specified groups of the patients population. All of them had benefited from the addition of abemaciclib. So someone would ask the question, how important is this 15.8%? And let me answer you. Don't forget that these patients had the optimum treatment. These patients have done surgery. These patients have lymph nodes positive. They have received the radiotherapy. This patient had the maximum of the endocrine therapy. So in order to take on top of that 15.8%, this is quite clinically meaningful and significant. And this is being reflected. If you look at the patients who are living, we find out that 30% fewer patients in the abemaciclib were living with metastatic disease in comparison to the patients who had only hormonal therapy in such high group of patients. And this is a reflection of the primary endpoint, which was the invasive disease-free survival, which we have seen that it increased, and the delta have been increasing year after year. And as you can see, at 6 years, the delta was 6.5% with a hazard ratio of 0.734, which again was consistent invasive disease-free survival across the pre-specified subgroups. And as we know quite well, that these invasive disease-free survival events were mainly distant metastatic disease. So it means that the abemaciclib addition had reduced the number of patients of metastasis in comparison to the normal endocrine therapy, reflected in distant recurrent-free survival benefit in the intention to treat population, which was reduced by almost 25% in comparison to the hormonal therapy. What about the systemic anti-cancer therapy later on? So what we can see that the difference between the CDK4/6 inhibitors and the chemotherapy used between the arms, it was seen either in the early recurrence or the late recurrence. So we have a less pronounced difference in later recurrence. So it does not only reduces, but it also shapes the further treatment for the patients. What about the treatment-related adverse events? We know quite well how we managing abemaciclib in our clinic, and there were no treatment-related adverse events, surprisingly, in comparison to what we have seen and what we have known. So in order to see this, I'm going to present one of the very interesting cases. And actually this case, since this is the PMOC, which is a multidisciplinary, our breast team here, all of them were involved in this patient. So this patient is a typical patient. So she's a 53 years old. She's an Egyptian. She is a wife of a colleague, and she a nice and healthy and a beautiful lady. She has like a very comorbidity, which is quite controllable, familial Mediterranean fever, and she has been dealing with this for 20 years. So she's the wife of a physician. She's doing screening mammography every year. So in November 2022, her screening mammography in one of the PhD's clinic had shown a right breast lesion on 1 centimeter, and the left breast lesion was even less than a centimeter. So we took her and we did a biopsy, and we can see that the TrueCut biopsy had revealed from the right side invasive ductal carcinoma, hormonal positive, and the HER2 was clearly 0, and the left side came back as left carcinoma in situ. We did scans, there were no metastatic disease. Her ultrasound showed a small lymph node, and we went for a biopsy, and the biopsy was clearly negative for any malignancy. We took the patient to the MDT, again, a wife of a physician, so they understand well. So she's a hormonal positive, screen detected. We know that these patients are low risk. We have clearly no positive lymph nodes. So we said, let's go for upfront surgery. And we talk about the carcinoma inside on the left side. And the lady, it was her decision that after discussion, they want bilateral mastectomy, they don't want further radiotherapy, and aiming and to do, she's postmenopausal and oncotype DX, and maybe she will need only hormonal therapy and no further treatment. I respect their decision. It was quite, a pragmatic decision. I understand that. So we went in January 2023, thanks to our colleagues, and they did bilateral mastectomy, and they did an SLMB, and SLMB came back as positive. So as LMB came back as positive, the decision was to go for axillary lymph node dissection. The right breast came back as multifocal lobular and ductal carcinoma. The tumor size was 3.8 centimeter, the maximum one, and 6 out of 12 lymph nodes were positive. So she was pathologically T2, N2, M0. The left side is lobular carcinoma inside. So we're totally talking about a different whole story. As we can see that with a negative on ultrasound, the likelihood of having a positive, likelihood of having a nodal disease is usually ranging between 0 to 12%. With a suspicious, which the patient was one of them, the rate of a heavy nodal disease is from 8 to 30%. She was one of these. Totally different story and totally different discussion we have to have. So again, our multidisciplinary, thanks for joining us this very early morning. Yes, surgical oncology, they did their best. They have to go to axillary lymph node dissection, radiation, the patient would be going to radiation, but the treatment with the medical oncology is totally different. Now there is no role of oncotype. Now we have to go through chemotherapy, and we have to go intensification of hormonal therapy. And we have the data from previous trial, our expounder trial, for the presence of positive axillary lymph nodes, but this patient is 6, she's not 1 out of 3. Monarch E, we have the data coming from the Monarch E trial. So we gave her chemotherapy. Again, she's familial Mediterranean fever, so 4 cycles of AC, and we suffered throughout the Taxol, the weekly Taxol, due to her neutropenia. The point is not, we cannot have, a perfect patient, but we have a real patient, and we have to go through the adjuvant therapy. So we gave her adjuvant radiation therapy, and we start her on hormonal, and I was not able to start her CDK4/6 immediately. Honestly, we have to delay it a little bit until her neutropenia could gather up. We started at ABEMA, standard of care, that we should not go for a lower dose upfront. So we went for ABEMA 150. I was 100% sure we're not going to continue like that. We stayed for a month, which I consider it as an achievement, reduced in March 2024 to 100 milligram BD. As you can see, this was almost her baseline WBC. It was between 2,000. We did not hit even 3,000. And her ANC in March, I shifted her to 100 milligram. It was in the range between 1.3, 0.9, and stayed like this. So at 1, we were continuing her treatment. So yes, we had a neutropenia, but honestly, this was low ANC levels, but we did not postpone the therapy when we shifted her to 100 milligram. She did have any, for example, infection or complications related to this. And finally, in October 25, we completed her treatment. I just seen her a few weeks ago, a couple of weeks ago, and we did scans because she was traveling to attend her daughter's wedding. So she have nothing and she's doing great. So the aim is not to have a perfect patient. The aim is to be able to treat the patient as per the guidelines in a proper way in order to reduce the incidence of recurrence and to have a meaningful improvement in the OS. And I can see with the data coming from the CDK4/6, with the data coming from the abemaciclib, we have a statistically significant and clinically meaningful improvement in the OS. This was seen in the whole population. We have a follow-up up to 6.3 years, and we have a risk of death by almost 16% in comparison to the standard of care. We're going to see further data for that at the 7-year landmark analysis. We should not forget that this is the first CDK4/6 to have a statistically significant improvement in the OS for such patients which are considered high risk nodal positive patients. Thank you so much.
Bismillah ar-Rahman ar-Rahim. Your Excellency, Sheikha Fatima Bint Hashid bin Dalmouk Al Maktoum, distinguished VIPs, esteemed speakers, honored delegates, ladies and gentlemen, good morning. Welcome to the opening ceremony of PMOC 2026. It is a profound honor to welcome you today as we embark on 2 remarkable days of collaboration, innovation, and knowledge sharing, united by our shared commitment to advancing oncology and improving the lives of patients across the region. Let us begin this important day with unity, pride, and respect. Please rise for the national anthem of the United Arab Emirates. Ladies and gentlemen, please join me in warmly welcoming to the stage Dr. Mohammad Farooq Latif, Chairman of PMOC 2026, as he opens our conference and sets his inspiring vision. Dr. Farooq.
Assalamu alaikum, distinguished guests, respected colleagues, honored speakers, partners, and friends. Good morning and assalamu alaikum wa rahmatullah. On behalf of the organizing committee, it's my great honor and pleasure to welcome you to the Pan-Regional Multidisciplinary Oncology Conference here in Dubai, a city that has become a global crossroads for innovation, collaboration, and medical excellence. We are really delighted to have you with us today. It is with particular honor and deep respect that I extend a heartfelt welcome to our chief guest, Her Excellency Sheikha Fatima Bint bin Dalmouk Al Maktoum. Your presence with us today is a source of great pride and inspiration. We are truly honored by your support for this conference and our shared mission of cancer care in the United Arab Emirates. Cancer remains one of the most pressing challenges of our time. As healthcare professionals, we are not only advancing science and treatment, but also supporting patients and families through life-changing journeys. This conference brings us together to share knowledge, foster collaboration, and translate innovation into better outcome for our patients through precision medicine and multidisciplinary care. As our region continues to grow in healthcare capability and research excellence, this meeting reaffirms our commitment to the regional leadership with global standards. I'm confident that this conference is more than a scientific event. Each one of us here today plays a significant role in shaping the future of oncology, whether through research, clinical practice, education, or policy. I would like to sincerely thank our esteemed faculty for sharing their expertise, our sponsors and partners for their invaluable support, and our organizing committee for their dedication in making this conference possible. I wish you a productive and inspiring conference, and I look forward to the meaningful collaboration that will emerge, inshallah. Thank you all, and welcome to the conference.
Thank you, Dr. Latif, for your visionary words. Now, as we move from the science to the very heart of why we are here today, I would like to invite my dear colleague and friend, Dr. Dina Hamza, to please join me on the stage.
Thank you, Dr. Hamad, for this introduction and invitation.
So today, we are not just opening a conference. We are opening a space for courage, resilience, and very real human stories.
Yeah, actually, we have not only stories today for survivors, we have stories for courage, for inspiration, for resilience, and for hope.
So let's welcome our patients one by one. May I request Fatima Khalpan Al-Noemi to join us on the stage.
My journey taught me to grow closer to Allah and to place my trust in Him as the true source of strength, and then in science and the people behind it. Behind every scan and every protocol is dedication, calm, and belief. That trust gave me strength. Today, I stand as proof that progress is personal and no patient ever walks alone. Thank you.
Thank you so much, Ms. Fatima. And next, I would like to invite Mr. Wilfredo Rivera.
I'm still Wilfredo Rivera from Philippines. I've been diagnosed last September of 2022. Now, if you see, I feel like a normal human being now. Thank you for Dubai, the healthcare system. Thank you to my doctor, to all my nurse in Dubai hospital. Now, I feel okay, everything. Thank you, Lord. Cancer taught me the strength ensured when I felt weak, others become strong for me, family, friends, and caregiver. The journey show me that healing is never a solo act. It's a bit of compassion, support, and humanity. The powers of others is healing happen when we allow others to carry hope with us. Thank you.
Let's welcome Ms. Amina Barwas.
السلام عليكم ورحمة الله وبركاته. أنا حابة أول شيء أشكر الداعم الرئيسي في علاجي هي عائلتي وبعدها الدكتور حماد. I would like to thank my family and after that دكتور حماد. سوري أنا شوي متوترة. حبيت أقول هالكلمة إن السرطان غير حياتي ووتيرة حياتي وأولوياتي ونظرتي للأمور. اليوم يعني لا أقيس العام بما فات بل بما انكشف لي الامتنان والمعنى والغاية. مشكورين والحمد لله على الحياة اللي نعيشها الحين. شكرا.
شكرا جزيلا. Thank you so much, Ms. Anna. And next, I would like to call Mr. Ali Ghanem Al-Falasi.
السلام عليكم ورحمة الله وبركاته. أقف قدامكم اليوم كمريض متشافي من السرطان، والحمد لله نحن في دولة شيوخنا ما قصروا وعملوا اللازم من مستشفيات وحضروا لنا دكاترة وكذلك متابعة، وأهم من هذا كله إن عندهم الانشورنس وأصروا على الانشورنس، وهذا ما نفع عدة مرضى قدروا يعالجون نفسهم من خلال هذا الوضع. الحمد لله والشكر دولتنا ما قصرت وعملت اللازم ونحن اليوم تعافينا، ونحاول بقدر المستطاع أن نستمر في التحول الثاني والمتابعة حتى نشفى شفاء كامل. أشكركم لاستماعكم به.
Ladies and gentlemen, it is now a great honor to invite Her Excellency Sheikha Fatima Bint Hashim bin Dalmouk Al Maktoum to kindly join us on the stage, please. Thank you very much. I would also like to invite Dr. Muhammad Farooq Latif to come to the stage, please. Today, we joyfully celebrate 4 remarkable journeys that remind us why hope matters. Let me request Fatma Khalfan and Noemi. Mr. Wilfredo Rivera. Ms. Amina Barwas. Mr. Ali Ghalib Farasi. We are honored now to recognize Her Excellency and sincerely thank her for gracing her with her presence, which inspires hope and uplifts everybody here today. Thank you very much. Let's take a moment to capture this powerful memory. I would like to invite PMOC Organizing Committee and Scientific Committee to please join me on the stage. And I will also request the Emerson College Society members to kindly join us on the stage for the group photo. Thank you very much.
This was a very precious moment, very precious and very proud moment. And I would like to express my gratitude to Her Excellency Sheikha Fatima Bint Hashir Al Maktoum for having this moment with us and with our patients, whom we are privileged. We are the one privileged to have part in the journey. It was actually very touching, and I would love to thank them again and again. To keep forward going, we are dedicating the next 20 minutes in order to understand the power of screening, and I'm delighted to present our next speaker, Dr. Olga Okonimudu, who is a clinical senior lecturer in breast cancer medicine and consultant medical oncology, University of Edinburgh. Dr. Olga, we're pleased to have you.
Thank you very much. I'm hugely honored to give the opening talk. I would like to congratulate the organizers, but also the patients for their courage to appear on the stage and share their own story. So I was asked to present the power of screening, to give a talk on the power of screening, so of breast screening, obviously. And when Dr. Farouk asked me to give that talk, I thought, that's interesting. I was really positively surprised because as oncologists, we spend so much time dealing with the development of new drugs and to improve, obviously, the cure rates in breast cancer, but sometimes we actually don't know what is happening in the whole world. And in terms of the numbers and the incidence of breast cancer, and based on my experience, when I started working as an academic oncologist 12 years ago, and I work in a big university hospital, I used to review about 70, 80 cases per week at our multidisciplinary oncology meeting. And now we have about 140 cases per week, which is a really, really large number. So, and the reasons behind this increase is obviously multifactorial, but let's see some data and let's do a deep dive in the numbers and the facts. Screen is off again. So how common is breast cancer in the UK? And I'm not going to focus in UK only, but breast cancer is the most common cancer in women in UK, with 1 in 3 new cancers diagnosed in women. And this will be breast cancer. So a woman is diagnosed with breast cancer every 9 minutes and a man every day. And this takes us to 50,000 cases of women and 400 men each year, with a further 7,000 patients that will be diagnosed with precancerous DCIS each year. So if nothing is done to change this, by 2040, a woman will be diagnosed every 8 minutes, and by 2038 to 2040, nearly 70,000 women will be diagnosed with breast cancer. So how common is metastatic breast cancer in the UK? And when we say metastatic, we use either the word advanced or metastatic or secondary. So when the breast cancer has metastasized to other parts of the body. So it's really difficult to get the exact numbers of metastatic patients, and we are really working hard to get to the bottom of it by doing national audits. In January 2025, an audit funded by the Cancer Funds, the Cancer Focus Northern Ireland, published estimates on the numbers of people living with metastatic cancer in Northern Ireland. And in Scotland, where I'm based, we committed to improve the data collection on metastatic breast cancer as part of the Cancer Action Plan. Now, in terms of the survival rates, women that they are diagnosed with a very early breast cancer, stage 1, they have about 98% of these women in England will survive for 5 or more years. Women that they are diagnosed with metastatic breast cancer, though, only 27% of them will survive for 5 years or more, despite the big advances in the treatment of breast cancers. Looking at the global view now, around 2.3 million new cases were diagnosed in women in 2022. That's 4 women every minute. And this figure is rising, with the number of cases estimated to rise to 43% between 2022 and 2050 to over 3.3 million new annual cases. So in terms of the breast cancer mortality around the world, 1 woman died every minute in 2022, having 666,000 women died of breast cancer in 2022. And all these years I've been coming to the GCC region, presenting on breast cancer. I had the chance of discussing cases with a lot of the colleagues from this region. And I was really surprised when they said that the numbers actually of breast cancers in the GCC region are much higher than what we see in the Western. and in the rest of the world, with actually more patients diagnosed in a really advanced stage. So I had the chance to do a bit of a literature review, and this is a paper from Professor Al-Samsi, which was published only last year, and this shows the numbers of the diagnosis as per countries in the GCC region collectively, and then in Saudi, Bahrain, Kuwait, Oman, Qatar, and UAE. And you will see that the 8 standardized incidence and mortality rates are really high in UAE, followed by Kuwait, and then followed by Bahrain. Looking now at the characteristics of the breast cancer in the GCC region to the Western population, there is a diverse clinical, pathological, and molecular features with much earlier onset, with higher tumor grade, with more triple-negative breast cancer, more HER2-positive breast cancers. 46% to 54% of the breast cancer patients are diagnosed at an advanced disease stage, with about 82% being IDCC and about 25% expressing the HER2, overexpressing the HER2, about 20% being triple-negative breast cancers. Now, breast checking, asking women whether they actually check their breasts regularly, it looks like only 50% of the patients, they do that regularly. 46% check their breasts regularly in 2025. 10% of women in 2025 reported that they have never actually checked their breasts. It is estimated that routine screening prevents around 1,300 deaths from breast cancer each year in the UK. So we have an established NHS screening program which aims to early detection and the mortality reduction. Structured screening pathway involves inviting the patients to attend for a mammogram, imaging, interpretation of the mammogram follow-up to ensure accurate diagnosis and patient care, leading to quality assurance and equity across the country, the clear communication about the benefits, the overdiagnosis, and false positive supports informed patient decisions and trust. Now, the breast cancer prevalence, as I said earlier, is the breast cancer is the most common cancer among UK women, accounting for 15% of new cancer cases annually. The mortality trends rates declined due to the treatment advances and organized screening programs over the last 30 years. Of course, the breast cancer is multifactorial. There are risk factors and disparities. The risk factors include age, genetics, lifestyle, like smoking, drinking alcohol, and disparities exist by age, ethnicity, and socioeconomic status. The importance of screening is that it detects early cancers, reduces mortality, and also requires targeted efforts to improve equity and adherence. The program launched in 1988, targeting women between the age of 50 to 64, and now expanded to ages between 50 and 70. We invite women every 3 years through centralized systems, and there are mobile units that they increase the access in rural areas. Now, I put a question mark next to the every 3 years, because this has been really debatable about how often we need to screen patients. Recently, Switzerland decided to actually stop the national screening, which obviously raises concerns. There is, of course, a financial impact behind the screening, but there is a huge and much bigger financial impact from cancer treatment. The national guidelines ensure quality, tailored pathway support women with disabilities and genetic risks. And the uptake, of course, varies by regions. The only reason I'm showing you these graphs, which shows actually the screening uptake by nation, is because I would like you to focus at the period of early 2020, 2021, when you can see a significant drop in the screening. And this was during the times of pandemic. And actually it took a really long time to pick up and reach the targets for each of the nations in UK, with, of course, us in Scotland doing better than the rest of the nations. Now, from invitation diagnosis, what this process involves, patients are invited for a screening with a 2-view mammography, which is performed by 2 trained radiographers. The mammograms are read on a dedicated high-resolution monitors by 2 certified readers. And when there is a disagreement, there is a third radiologist that is asked to comment. The assessment, if there is an abnormal finding, includes clinical examination, additional imaging, and of course, tissue sampling via biopsy or fine needle aspiration. The cases should always be discussed at the MDT, the multidisciplinary team, and then clear communications and monitoring reduce the anxiety and improve patients' quality of life. The mammography technology uses X-rays with two standard views to detect early breast cancer. The digital mammography improves the image quality, storage, and enables the 3D imaging with digital breast tomosynthesis. Of course, there are limitations. Of course, there are risks. The mammography sensitivity varies by breast density. And then you can see on the right-hand side, we have a really dense breast tissue, which makes the mammography more difficult compared to the other side, which is a very loosened mammogram. So there are false positives, which they might increase anxiety. AI, artificial intelligence, will improve and will definitely reduce the false positives. So this is the future development, the AI-assisted interpretation and the risk-based screening, which aims to bring more early diagnosis. Now, women that they have a high risk, and these are women that they have a genetic predisposition, should be tested based on these following rules, which means that they should have a mammograph, an MRI between the age of 25 to 40, MRI and mammography for 40 to 51, mammography plus or minus MRI from the age of 51 to 71. Women that have a likely pathogenic or pathogenic variant in another high-risk gene other than the BRCA1, BRCA2, and PALB2, I get again an MRI, mammography plus or minus MRI based on the rules that are applied in each country, which I'm sure they are pretty common across the world. And again, the same for the ones that they have a mutation, JEC2, ATM, and RAD51. The recall rates, of course, increase anxiety. These are ranging between 3 and 5%, balancing the sensitivity and specificity to reduce the anxiety. The cancer detection averages 8 per 1,000 women screened, with higher detection in older age groups. Interval cancers diagnosed in between the screenings measure the program sensitivity and prompt quality improvements. There is an impact on screening programs, performance data, guide the policy in each country, the resource allocation, and promote transparency to maintain public trust. There is a risk of overdiagnosis, as I already mentioned, which increases, as I said, the anxiety. There is the anxiety from the patient's perspective about the radiation exposure. There are false positives which cause recalls and biopsies, while false negatives delay the diagnosis, affecting the patient's trust and outcomes. Mitigating screening harms, improve screening intervals, risk-based approaches, and technologies like the artificial intelligence will enhance accuracy and reduce the harms. The treatment assessment, the multidisciplinary approach, as I said, includes radiologists, pathologists, surgeons, oncologists, breast care nurses, which are extremely important in the MDT meetings, and to the patient's care, ensure patient-centered management plans. As I said, the artificial intelligence support with AI algorithms will assist radiologists by enhancing the image interpretation accuracy and workflow efficiency. This is a study that was published last year and shows early indicators of the impact of using AI in mammography screening for breast cancer. This is a Danish study that included 60,000 women, and these are the evaluation findings as they were published. So before AI implementation, the recall rate was 3.09%, with a cancer detection rate at 7 out of 1,000, with false positives being 2.39%. After AI implementation in 58,000 women, the recall rate was lower with 2.46%. The cancer detection was higher with 8.2 in 1,000. The false positives, and therefore the anxiety, was less with 1.63 versus 2.39%. And interestingly, and very importantly, the reading workload was reduced by 33.5%. So in a population-based mammography screening program, using AI reduced the overall workload of breast radiologists while improving the screening performance. Now, we had the press release last year in UK about a world-leading AI trial to try and tackle the breast cancer, and we plan to screen 700,000 women across the country to this world-leading trial to test how AI tools can be used to catch breast cancer cases earlier. This is a slide that shows that there have been major advances in the field of breast cancer the last 7, 8 years, not only in terms of the systemic treatment of the new drugs, targeted agents, antibody drug conjugates, immunotherapy, but also radiotherapy, stereotactic radiotherapy, which have all definitely improved the survival of the patients. However, there is a huge impact of the breast cancer on people's lives in terms of their mental well-being, the anxiety, not just to the patients, but also to their family and to their carers. The diagnosis of breast cancer is a devastating diagnosis. It comes with a lot of impact on the work, on the financial well-being, on the more personal aspects of women's lives. In young women, fertility, ovarian function suppression, premature menopause, all these are causing major issues. There is an economic cost to the patient due to not being able to work, economic cost to the country due to the treatments, which are very costly now, and things have changed massively compared to 20 years ago when we had single-agent chemotherapies or simple endocrine treatments. It is estimated that the cost in the UK will be between 3.2 to 3.5 billion in the years to come. So side effects, they affect significantly the quality of life of patients. None of these side effects are negligible. As I said, not just the premature suppression, the reducing the chances of having family in the future, the side effects of chemotherapy and all these high-end drugs with a huge efficacy, however, with huge toxicities to deal with. So the power of screening, the mammography screen is extremely important because it increases early diagnosis. Increasing early diagnosis improves the cure rates, improves quality of life, and brings us one more step closer to eliminate breast cancer. And with that, I will finish by honoring my Greek roots and using a Hippocrates quote, "Prevention is better than cure." Thank you for your attention.
Thank you very much, Dr. Olga, for your insights. Once again, our deepest gratitude to Her Excellency, our VIPs, speakers, patients, and delegates. May PMOC 2026 be a platform for collaboration, innovation, and progress. Thank you all for being part of this opening ceremony. We now invite you to proceed to the exhibition area for the ribbon cutting and opening tour. Thank you very much.
ಅಕ್ಲೆ ಎಟ್ಟ ಲೆಕ್ಕ ಇಂಚ ಉಂಟು ಎರ್ದು ಯಾರ
Thank you so much. I think we had a nice break. Ladies and gentlemen, colleagues and friends, I'm honored to share the next session with my very close friend, Dr. Hussam al-Marashi, who is a consultant medical oncology at Tawam Hospital. And this session is specially dedicated for metastatic breast cancer. We have very interesting talks and very comprehensive discussions and very nice panelists. So to start with, I would like to introduce and invite Dr. Peter Fasching, who is an associate professor of gynecology and obstetric medicine at the University Hospital and Comprehensive Cancer Center in Germany. He's going to talk about the metastatic hormonal positive HER2 negative breast cancer with a very interesting talk, changing the treatment paradigm after progression on CDK4/6 inhibitors. Dr. Fasching, we are welcomed you to stage.
Thank you very much. Good day. It's very nice to be back here in Dubai. Always enjoy to be here. Specifically, if I'm asked to talk about hormone receptor positive, HER2 negative breast cancer. Trying to get the slides up. Well, when I went to the United States in 2007, for the first time, I was heavily involved in helping to develop medications, at that time specifically the CDK4/6 inhibitors. And of course, the whole community at that time was making big progresses to learn about endocrine resistance and to learn about how and what mechanisms drive endocrine resistance. And now we're looking back over 20, 30 years, and many things have been learned, but only a few of them have specifically been applied into the clinics or developed into programs that now the patients can benefit from. Seems to be frozen, so I'm just going to continue from my, oh, there it is, but not yet on the screen. So tamoxifen was introduced about in 1975. Still not working. Next one, there we go. So that's the whole scope, you know, what we've been done over half century. Tamoxifen was introduced 1977. In the middle, you're seeing the aromatase inhibitors being introduced in the metastatic setting, in the early breast cancer setting. And then here on the left side, and I'm not going into detail, we have novel chemotherapy antibody conjugates, ADCs, and we have substances that overcome endocrine resistance. And molecular physiologists and biochemists will go through every single pathway, and they're set. We know all the genes, we know all the pathways, but for us clinicians, this one here is the most important one to look at. The everolimus was the first one to overcome endocrine resistance. And we might be friends or not so much friends with the medication because of the side effects, but what you can see here is, this is endocrine monotherapy with exemestane in endocrine-resistant patients. In 3 months, 50% of the patients progress. You put the patient on the treatment, 3 months later, half of them already progressed. That's endocrine resistance. Adding the everolimus, you can see that in the majority of the patients, you can stop that early progression. Not forever, but at least adding another substance, you can overcome endocrine resistance. And this is what it is about. The most prominent example are the CDK4/6 inhibitors. They overcome endocrine resistance as a different mechanism. To some extent, they also extend survival, overall survival, less deaths over time. And that led to a very, very rapid and almost complete implementation in the first-line metastatic setting. What you can see here is real-world data, and the green curves or the green bars in the middle, these are the CDK4/6 inhibitors from approval. Now 80 to 90% of patients in the first-line setting are treated with the CDK4/6 inhibitors, and that's the standard. A few patients get chemo, a few patients get endocrine monotherapy for reasons that fit the patient's life situation. But having a standard so completely implemented in the first-line setting, of course, it's very important what comes after the CDK4/6 inhibitor. And there's something that has to be acknowledged that's not in the guidelines, and that might not be as good as we think we are. It's that chemotherapy is a quite often used regime after the CDK4/6 inhibitors. And that's data from real-world registries. We've seen that in Germany, we've seen that in Netherlands, we've seen that in Italy. There's some data from the United States, but chemotherapy still is a heavily used medication after the CDK4/6 inhibitors. Is that good or is that not so good? So the data is out there. We get about 5 months median progression-free survival in the real-world registries. 5 months with the capecitabine, 5 months with other chemotherapies. It's always about 5 months chemotherapy after the CDK4/6 inhibitors. And we have to keep that in mind. If you think about the endocrine monotherapies, it's about 3 months. And we know that. It's trivial. We see the patients progress very rapidly. And then we get the feeling with the chemotherapy, you might be getting a little bit more. So compared to endocrine monotherapy, like exemestane or fulvestrant in the second-line setting, 3 months, the chemotherapy is better. So there might be some understanding for ourselves and our colleagues that give the chemotherapy after the CDK4/6 inhibitor. But that was a few years ago. Now we are better than fulvestrant or exemestane as endocrine monotherapies. And one of the stories that is important in that context is the ESR1 story and the endocrine resistance to tamoxifen and aromatase inhibitors, and to some extent fulvestrant, triggered by a mutation in the tumor in ESR1, namely making the estrogen receptor constitutively active. It wouldn't need the estrogen anymore to do all the alterations to the genome that lead to proliferation and transformation and metastasis. So there's several therapies, and I'm not going into detail here, that have established the SERDs versus fulvestrant or exemestane or aromatase inhibitor in the second-line setting where we have an endocrine-resistant population. The first one was the Emerald study. You can see very nicely on the left side, that's a progression-free survival with an ESR1 mutation. On the right side, that's a progression-free survival without an ESR1 mutation. Then we have the vepdegestrant, the VERITAC-2 study, very similar study design. And again, there is a separation of the curves with the ESR1 mutation. There's no separation of the curves without the ESR1 mutation. Very similar study. And then the EMBER-3 study, the imlunestrant just got approved in the European Union on January 9, based on the EMBER-3 study. Again, in the ESR1 mutated population, there is a benefit. And all of these studies have a median progression-free survival now with the endocrine monotherapy of about 5 months. And the majority of the patients in those studies also have been treated with the CDK4/6 inhibitor before that trial. So now we're not talking about the 3 months anymore, or even less than 3 months that we've seen before these next generation treatments. And now, maybe, and that's why there's a reminder here on the slide, we will learn what we've done in the first line setting with the CDK4/6 inhibitors. Finally, we trust the endocrine treatment, that we don't give chemotherapy in the first line anymore. Maybe we can learn there's similarly effective treatments that have better quality of life than chemotherapy, that have similar progression-free survival times like chemotherapy. So I want to predict, or I hope so, that we will treat less and less patients in the second line setting with chemotherapy. But we're even better than these 5 months, because now we've learned over the last 20 years about endocrine resistance mechanisms. And one that I was allowed to accompany for the last almost 30 years is the PI3 kinase mutations. Let's go back about 13 years when we entered this post-genomic era where the human genome was published in 2001, completely published 2004. The genotyping costs came down, and for the first time in 2011, you could systematically look at all the mutations in any tumor. And the breast cohort was one of these cohorts, the Cancer Genome Atlas. And then we found out, not me personally, but like the research community, what are the top mutations from a healthy cell to a cancer cell, which are the mutations that drive a healthy cell to become a cancer cell. And that's what you can see here. That's the top genes in that effort of the Cancer Genome Atlas. And you can see here, the top one, of course, is P53, which is almost impossible to harvest for cancer therapy. But the second one in line is the subunit of the PI3 kinase. Almost 50% mutated in luminal A, 30% mutated luminal B, not so much in basal-likes, but also almost 40% in HER2 positives. PI3 kinase is a very, very prominent driver of pathogenesis of breast cancer. Not much time after the publication of the human genome, the PI3 kinase was already in the focus with regard to breast cancer to look for prognosis in hormone receptor positive, HER2 negative advanced breast cancer patients. And what you see here is the overall survival in patients with a mutation versus the ones without a mutation. And there was a huge effort in the year 2004, 5, and 6 to have almost 400 patients genotyped for a gene, and then having the prognostic data ready to make that association that a mutation is actually associated with a deteriorated prognosis. And that fit quite well if you look at preclinical data, and usually I'm not showing much preclinical data in my presentations, but that's actually very, very, very striking data that was produced at the time point when the PI3 kinase pathway was explored. Down here, these are breast cancer cell lines without a mutation. And then there's several PI3 kinase mutations here, like different ones. And you can see here the colonies that are growing much faster if there's a mutation in these breast cancer cell lines. So it's really an activating mutation. And around at the same time, around 2004 to 2007, the first inhibitors were available that would specifically block that pathway. So after the HER2 story, the PI3 kinase story at that time seemed to be the most interesting one and the most promising one to maybe establish the next targeted therapy after the anti-HER2 treatments that were implemented. So these are the studies as an overview that were conducted in that context that were major phase 3 studies. On the left side, you see the buparlisib, which was a drug that could not be developed into clinical practice because of the side effects, not only the hyperglycemia, but also psychiatric side effects. And you see down here, the endocrine monotherapy versus the addition of buparlisib in the non-mutated population, no difference. But then you see a clear difference in the mutated population. Very similar with the alpelisib. Alpelisib, as for the side effect profile, some countries, was in India, they describe it as a catastrophic side effect profile. It's complicated with the hyperglycemia, and we might have had some bad experience with it, but nevertheless, you see the same thing, non-mutated versus mutated. And now we focus on the capivasertib in this presentation because here also not altered pathway. Now we're adding some other genes of the PI3 kinase ACT pathway, PIK3CA, ACT1, and PTEN, not altered versus altered. You can see a difference that the promise of precision medicine is kept. And even if some of you say that might be a little bit more prominent, we want to have it more drastic, there's nothing better. That's precision medicine par excellence that we can provide in the year 2026. That's already 2026. All right. So let's look and focus a little bit more on the Capitella-291 study because that's the most recent addition into that story. And it's a very similar study like the SOLAR-1 study from the study population, but now we're conducting this trial in the context of having CDK4/6 inhibitors available. All of the other trials, CDK4/6 inhibitors were not available yet. So we would expect a majority of patients in the Capitella-291 study to be pre-treated with the CDK4/6 inhibitor, asking the question, once the patients become resistant and progress after an endocrine treatment, and they have a PI3 kinase ACT1 or PTEN alteration, is the capivasertib able to overcome endocrine resistance in that patient population? And you can see here that, as a matter of fact, previous CDK4/6 inhibitor treatment was about 70% of the patients got a previous CDK4/6 inhibitor treatment. And this is the primary endpoint. That's the progression-free survival in the PI3 kinase ACT-PTEN altered pathway. You see what we have learned, endocrine-resistant population with fulvestrant, 3 months, that is known. We don't want to see that. We want to overcome endocrine resistance, and the capivasertib does that. When we look at the Kaplan-Meier curve, this is exactly the percentage of patients where at the first assessment time point, endocrine resistance is overcome. And we see a hazard ratio of 0.5, 3.1 months can be extended to 7.3 months median progression-free survival time. And this is the Kaplan-Meier curves that concerned with the question, is this an effect that's seen also in the non-mutated patients who were also included in the trial, or is it only restricted to the non-altered pathway population? It's a little bit more complicated, the story, because the assessment methods, the mutation genotyping methods changed a little bit over time. So this Kaplan-Meier curves up here are the ones that resemble the best a non-altered pathway population. And even if the hazard ratio here is about 0.8, and you might get the feeling the Kaplan-Meier curves somehow separate, if you're stepping one step back and consider the hazard ratio of 0.5 in the altered population, the authorities did not think that this data is convincing enough to get the drug approved in that population that is not altered, and there seems to be a clear difference, hazard ratio 0.5, hazard ratio 0.8. And again, my reminder slide. So we get about 5 months with the chemotherapy. If we want to give ESR1 mutated patients a third, we get about a very similar progression-free survival time. Now, in the very aggressive PI3 kinase mutated population, we're getting even more. So we're like now up to about 7 months. And that's not only true for the overall population. There's been extensive research been done in the subgroups. So liver metastasis, prior use of CDK4/6 inhibitor, that doesn't seem to have an effect on efficacy. There's some data even from the first-line setting. The capivasertib also is explored in other trials in the first-line setting. There's even a progression-free survival that we might expect in this very aggressive population of about 15 months, very similar to the INAVO 120 data. And then there's data concerning with the ESR1 PI3 kinase co-mutations. They're that frequent that I'm sure many of you have seen results from your own patients where you see there's a PI3 kinase mutation, there's an ESR1 mutation. There's data that has been published by others. We have looked into that. So we just had a poster in San Antonio. It's about 15% of patients that have a co-mutation of ESR1 and PI3 kinase. So what do we do there? Of course, these patients have a very, very aggressive driver mutation with the PI3 kinase, and combining it with the fulvestrant, I personally feel very comfortable in covering that with the fulvestrant and the capivasertib, because at least, for this patient population, you're covering the driving PI3 kinase mutation. And there's data out there. The Capitella 291 study was analyzed in that context. And let's have a look at the CDK4/6 pretreated population. The co-mutation you can see here, you achieve a median progression-free survival of about 7 months, which is very similar to the overall population, a hazard ratio 0.45. So there is data that supports that these patients, we don't have to hesitate that this is a treatment that we could be giving, and in combination with the fulvestrant, we do know from PADA-1 trial that this is more efficient than the aromatase inhibitor, because at least to some extent, maybe not as good as the oral SERDs, but to some extent also covers the problem with the estrogen receptor pathway resistance to other endocrine treatments. The side effects also, now we are very concerned with the alpelisib, seeing all grade hyperglycemias of about 60%. The inavolizib also has about 60%, has less grade 3, 4 hyperglycemias compared to alpelisib, but still all grade hyperglycemias of about 60%. And you can see here that the capivasertib is in a very similar range like the everolimus and the gedatolisib, the IV mTOR PI3 kinase inhibitor. So there seems to be 2 different classes of PI3 kinase ACT mTOR inhibition pathways, and the capivasertib is in the same range as the everolimus and the gedatolisib, and the alpelisib and the inavolisib are maybe in a different category in that context. There's also, now the drug is approved for quite some time, real-world data that concerns with all the different situations. Especially I like you guys here in the region because you always come up with a case that you haven't thought about. You know, what about this case? What about that case? Because that's not represented in the trial. That's not represented in the trial. What do we do here? What do we do there? And that's why real-world data. Can we go back a few slides? I don't know how to, oh, I can do that myself, I guess. So now you can see here a population where the previous treatment is fulvestrant as a previous treatment, chemotherapy as a previous treatment, alpelisib as a previous treatment, so antibody drug conjugates as a previous treatment. And there you have now real-world data of almost 400 patients, most of them second line and third line, but also almost a third of them 5 lines and later. And you can see here that you achieve in the second line in the real world very similar median progression-free survival times of about 7 months, and even in the third line of about 7 months. So the data that we've seen in the trials is supported by the real world data that we see out there. So finally, the world has gotten complicated in the hormone receptor positive HER2 negative. So that's my last slide. If you think about the first line setting with the CDK4/6 inhibitors, now there's new very specific CDK4 inhibitors that might be more efficacious, CDK2 inhibitors. There's combinations coming up with PI3 kinase inhibition. We have the new SERTs. Then we have new PI3 kinase inhibitors coming up. We have other pathways like KAT6 inhibitors, completely new ways how to overcome endocrine resistance on the epigenetic level. Let's not forget about the ADCs. What about harvesting homologous recombination deficiencies in hormone receptor positives? So it's very important that we learn about the therapy sequences. It's very important that we collect all this data in real-world registries. It's very important to learn what drives the progression after the first line, what drives the progression after the second line, and what prompts the best molecular profile for making the next therapy, you know, as successful as it can possibly be. So I think there's a large obligation for us to, now these drugs are available, we have this variety of treatments that now from the real world in a large scale data is collected, not only clinical data, but also molecular data to inform us about the best possible therapy sequence. Thanks a lot.
Thank you so much, Dr. Fasching. I think that Sankey diagram is very clear. We should keep it in every presentation you put on. Let me thank and congratulate the PMOC organizing group for putting things together. I'm so thankful for bringing patients really to the podium. I think far better than putting lights or dancers as other meetings are. Well done. It is my pleasure to ask Dr. Farad Raja to come back to the podium and tell us more about the other side of the Sankey diagram. And we're glad that she's joining us from the University College London and tell us about what happens after the endocrine treatment, the ADC story. Thank you.
Thank you very much. So thank you for that long introduction, Professor Fasching. And I'll take on where Professor Fasching had left off. So we're talking now beyond endocrine therapy in metastatic ER-positive breast cancer. So no matter what we try and do, no matter how we try and overcome endocrine resistance, I think we all agree that at some point we exhaust all of our endocrine treatments and we do reach endocrine resistance where we need to move on to other treatments. And up to now, what we have done is we have used chemotherapy. And this is broadly what we have been doing. We've got our first line treatments, our second line treatments, and then our third line treatments as well. And our second line treatments are expanding hugely. As you can see, we've gone through our PIK3 inhibitors in combination. We've got a number of other positive trials that have been presented and will undoubtedly become approved and add to the number of treatments that we have in our second line. But at some point, as we know, we will move on to third line, and that's where I'm going to focus on. So the real world data has been explored already by Professor Fashing, and we know that chemotherapy in sequential lines really gives us a poor progression-free survival and overall survival, and we certainly need better treatments. And those better treatments came in the form of the ADCs. These are drugs that we've been using for a long time in the HER2 positive treatments, the first generation being TDM1. And a bit like children should always be better than their parents, the next generation of our ADCs are better than that original ADC for TDM1. And we've got these highly potent treatments. So what do we need with an ADC? There are three things. We need an antigen, and that should be overexpressed or preferentially expressed on our tumors compared to the normal tissue. We need a linker. The linker needs to be stable within the bloodstream so that the off-target toxicity is not too bad. We need a payload which should be potent, and a payload which can get into the tumor cells, initiate cell kill, but then it can also diffuse out and affect other cells which may not have that antigen or that target, and therefore we increase the potency of our treatments. And we have three that are already approved in ER-positive breast cancer. We have TDXD, we have sacituzumab govitecan, and Dato-DX as well. And you'll see here that we've got different targets. We've got HER2 as a target, and then we've got TROP2, which is very highly expressed in tumor cells and not so highly expressed in tissue cells, so a very good target to have. And then we have payloads, which are all topoisomerase inhibitors, DXD, intrastuzumab deruxtecan, and Dato-DX, and a different topoisomerase inhibitor. So what we have had to do is really change the way that we are having our pathology reports. We need better communication with our pathologists, and we have this new category, and of course it's not been new in breast cancer, but it's new for us, where we have HER2 low and HER2 ultra low. And it's really important that we can recognize these patients so that we can treat them appropriately. And the HER2 ultra low are those patients, of course, who have less than 10% of cells, even with a faint amount of membrane staining. And if we can detect that, we can offer these patients something more. And HER2 status is not static, it's heterogeneous, it changes over time. The concordance between early breast cancer tissue samples and that of the metastatic setting can be very different. There's a 40% discordance rate in this situation, and therefore it is important that we are rebiopsying our patients and really identifying the correct biology so that we can treat the patients as well as we can. And this has all really been driven by the Destiny Breast04 study in the first instance. And this was a landmark trial for us in early breast cancer, ER positive. It got a standing ovation and a very long applause and a lot of excitement when it was presented. I can't believe it was only 3 years ago. It feels like a lifetime ago that we started seeing this data, but it was heavily pretreated patients. They had had endocrine refractory disease and 1 to 2 prior lines of chemotherapy in the metastatic setting. They were randomized on a 2-to-1 basis to TDXD or physician's choice, being capecitabine, eribulin, gemcitabine, paclitaxel, or Abraxane. And these are the results that we saw, which really were very impressive, with a doubling of the progression-free survival in the ER-positive patients, from 5.4 months to 10 months, and a hazard ratio of 0.51. So really strong results. We also saw a benefit in survival, with a median overall survival of nearly 24 months in the TDXD arm and 17 months in the physician's choice arm. Again, a hazard ratio of 0.64, so strong hazard ratio, really good result. And this did change practice around the world. And it then took us to the next stage of the Destiny 06, and there were 2 differences here. So the first was to bring this treatment forward into the chemo-naive population, and the second was to introduce this concept of ultra-low. So those patients who had very faint staining or hardly any staining between HER2 0 and HER2 1. And these patients had had endocrine treatment but no chemotherapy, and they were randomized between TDXD and capecitabine or a taxane. So 60% with capecitabine and 40% taxane. And what we saw again was this significant improvement in overall survival, hazard ratio of 0.62. So really robust findings here, a median progression-free survival of 13 months and a difference of 5 months. So very impressive results, and certainly better than what we are achieving with single-agent chemotherapies, as we saw earlier, both in my talk and Professor Fashing's talk as well. We didn't see an improvement in overall survival, but there was crossover allowed in this study, and 20% of the patients in the control arm did go on to have a TDXD as well, so it's not likely that that could be seen. Looking at the ultra low, these patients also derived a benefit, as we can see here, of nearly 5 months. The hazard ratio not quite as good, but really, again, an improvement that is worth seeing. The toxicity we've all learnt with TDXD, we've learnt in the HER2 positive patients, we know there is more nausea and vomiting, and these patients do require at least a 3-drug regimen to manage this. We've seen the pneumonitis, this is consistent across the trials. We are seeing it around 10 to 12%. There are deaths in a lot of the trials, so we do need to manage these carefully and be aware of it. And then, of course, with the HER2 being the target, we also can see cardiac toxicity. So coming to the next, sacituzumab govitecan, the TROPICS-02 study, which was a phase 3 study in very heavily pretreated patients. Median number of lines of treatment was 3 of chemotherapy, endocrine refractory patients, randomized to sacituzumab or physician's choice, which could be capecitabine, vinorelbine, gemcitabine, or eribulin. What we saw was, again, a statistically significant improvement with the use of sacituzumab. The actual figures were modest. We saw an improvement of 1.5 months, but I think seeing any difference in this really heavily pretreated population is significant. So the final analysis confirmed that improvement, and we also saw this improvement in overall survival. What we found with the translational work from this study was that sacituzumab improved efficacy regardless of the TROP2 expression. So when we looked at the low risk and the high risk, the low expression and the high expression of TROP2, there was still a benefit regardless of that. And because we have HER2 low, HER2 ultra low, they also looked at those patients, and again, there was benefit seen irrespective of the HER2 expression. So then the next point was to see whether should we bring sacituzumab forward in the ASCENT-07 study in these patients. Is that going to improve the progression-free survival further? And unfortunately, the answer was no. That was not something that happened. And really, sacituzumab remains in the setting where it was approved, currently in patients who've had chemotherapy and have gone through endocrine treatment. So we're not bringing that forward. Then to the final ADC that's been approved, Dato-DXd, and that was approved on the basis of the TROPION-Breast01 study. This was, again, a study done in those patients who are heavily pretreated, who'd had 1 to 2 prior lines of treatment and were endocrine refractory. They were randomized to Dato-DXd versus investigator's choice. And these were the primary results, with progression-free survival being significantly improved by 2 months. Again, a good hazard ratio of 0.63. So another ADC which has been approved earlier last year in ER-positive breast cancer. It also showed a significant improvement in response rate. There were also some small numbers of complete responses, which, given the extent of pre-treatment, I think that is impressive to see. The overall survival data are not mature yet, but there is a trend that we are seeing in overall survival. Now, Dato-DXd seems to have a slightly different safety profile to some of the other ADCs. There is more mucositis, there's stomatitis, which is really unpleasant. There are some centers which are using iced chips for patients to have to try and minimize the mucositis, and it does seem to have some benefit. There are also dry eyes, which is very unpleasant, so these patients should be given eye drops at the time of having this treatment. And then conversely, there are lower rates of pneumonitis with this. Interestingly, despite these toxicities, which would appear significant, there are actually fewer dose reductions and discontinuations compared to the chemotherapy arm. So it certainly seems that the toxicity was manageable. So with all of these drugs, what do we do? How do we sequence our ADCs? Where do we give them? What I would say is, in the sort of pragmatic real world, which we are all living in, for those patients who are endocrine refractory and they are HER2 low, TDXD has the most data, and I would certainly be starting with TDXD. Post-TDXD, I think the next option would be sacituzumab govitecan. Of course, there are other alternatives, such as clinical trials would always be preferably used, other chemotherapies, or potentially Dato-DXd. And then the second, at the second progression, I would be looking at Dato-DXd or chemotherapy, a clinical trial, or sacituzumab govitecan. Now, of course, it's all very well what the clinician says, but what are the patient's preferences? Do they want to come once every 3 weeks, or are they happy to come twice every 3 weeks? Looking at the toxicity profile, are we going to be choosing pneumonitis or diarrhea? Which one, is suiting the patient? Where is their distribution of disease? And can we integrate some molecular profiling in picking some of these treatments better? So, in summary, what I would say is that the ADCs have expanded our treatment options, our armamentarium, much further with beyond endocrine treatment. TDXD is preferred in all patients apart from HER2-0, but really, if we work with our pathologists, we will find that up to 90% of breast cancers are HER2 low or ultra low. So there is room for most patients to have this. We really need to learn how to sequence these ADCs, and real-world studies are already out there which are showing some of the sequencing, and it is clear that there are cross-resistances with ADCs. That may be because of the payload, because we have got the same payload in a number of the ADCs. It may be the target. After use, are we downgrading the target and the expression of the target is being lost? Is it a combination of the two? Is it other things as well? These are things that we do need to learn to use these treatments optimally. Until we get those data, what we have to do is use a pragmatic approach. And what my approach would be is to sandwich the ADCs between some chemotherapies and also use ADCs with different payloads rather than successive ADCs with the same payload. Having said all of this, I have to say that in the, I was going to say UK as well again, in England, we in fact don't have any of those ADCs available to us in ER-positive breast cancer. They're not approved. The funding is not there. So we are yet to use them in the endocrine positive population. And I'm sure you all have much more experience of using these. But thank you.
Thank you, Dr. Farad, for this very nice presentation. Next is going to be a hard job. So recently we have a plethora of data for the HER2-positive disease. We have been stagnant since Destiny Breast 02 and Destiny Breast 03, and then suddenly we have 5 and 9 and 11. And in order to have this wrap up in the next 15 minutes, we have to have a very strong presenter who's Dr. Anwar Nouri, consultant medical oncologist from Cancer Kuwait Control Center. And Dr. Anwar, we're looking forward for this presentation.
Thank you for the nice introduction, and thank you for the invitation. You mentioned something important that, initially or in the past, when you were given the task to talk about HER2 positive metastatic breast cancer, it was an easy job. Up to 2020, maybe the guidelines were very clear. Even in the clinic, the decision was quite clear. First line, second line, and then it's, I guess, free for all what to do in the third line. Now it's getting a little bit more complicated as specifically TDXD moves up the ladder and up the ladder in metastatic and early breast cancer, which was happening, as you showed us earlier, in the early breast cancer, and because what to do after TDXD always remains the question. So as we know, HER2 positive breast cancer represents around 15 to 20% of all cancers. In Kuwait Cancer Control Center, we have a publication that shows that it's around 20%. 10% are ER positive and 10% are ER negative. And overall survival in patients with HER2 positive breast cancer has, by diagnosis, has not changed a lot from 2008. You can see up to 2016, but these are all data now. We definitely have better, with better treatments, we have better median overall survivals for those patients. This is good for the patients. Targeted therapies for HER2 positive breast cancer, we have different targets, extracellular or intracellular, with the monoclonal antibodies, tyrosine kinase inhibitors, and then of course we have the ADCs targeting different areas in the cell, whether it is on the surface of the cell or intracellular. So the treatment paradigm prior to 2020, and if we look at the, as I was saying earlier, it was much simpler. Looking at the first line based on Cleopatra, and then you do the maintenance dual anti-HER2 therapy until progression, then TDM1, and then once they progress after TDM1, the third line, there are multiple options, either with a lapatinib capecitabine, which was the second line at some point, or trastuzumab with chemotherapy, and then efficacy even beyond third line, with the PFS is around 5 months with objective response rate 20% only. And so they didn't really fare well. And now with these newer agents, we're seeing that those patients in the metastatic setting, they're actually even living longer than ER positive. And if you look at the guidelines in 2019, the NCCN guideline, it was fairly simple. You can see the box for the HER2 positive breast cancer. So Cleopatra was clearly the category 1, the preferred. And if you look at other recommendations, then they had all of them listed one after the other with no real preference, but TDM1. And these data came from Cleopatra, which clearly shows the overall survival with pertuzumab, trastuzumab, docetaxel as the first line, PFS and OS. And then, of course, with the Emilia trial, when it was compared TDM1 with the standard of care, I would say at that time, lapatinib, capecitabine, and again, showing a preference for TDM1, which was the first antibody drug conjugate in breast cancer that has been approved, showing superiority in PFS and OS. So the guidelines has, since 2014, has remained quite stable until end of the 2018-19, more newer drugs, and then from 2020 to 25, you can see there's a big shift in the way the guidelines. So they have a whole page, by the way, for the HER2 rather than putting it in a small box on the corner. And then you can see first line didn't really change much, but second line and third line, there has been some new entries with TDXD, trastuzumab deruxtecan, and then also with tucatinib. And these are based on 2 important trials. So it was only natural second generation TDXD would come up into the game. And these the TDXD, when comparing it to TDM1, has some different characteristics in terms of they're both targeting the HER2 ADC, but differences in the linker and differences in the payload. So Destiny Breast 03. Prior to that, Destiny Breast 02 in third line and beyond shows improvement superiority of TDXD, so it was only natural that it was compared to the standard of care, which was TDM1. This was not in the second line, this was specifically against TDM1 in different lines of the treatment. Primary endpoint was looking at PFS, and secondary endpoints were looking at OS. So these patients were randomized to receive TDXD or TDM1. And as I said, this was after progression on the trastuzumab taxane treatment. So just to keep in mind that around half the patients were receiving it in the second line, around a quarter of the patients were in the third line, and 13% around in the fourth line, and so on. And we also, this, I don't know if we're going to see such thing again in breast cancer, but we saw this improvement in PFS. So was 4 times more longer with the TDXD favoring TDXD over the TDM1. With a hazard ratio, again, of 0.33, and this was statistically significant. And if you look at the overall survival, again, improvement in the overall survival, favoring the TDXD with the, and if you look at the anti-cancer therapy that they received after, so the patients who were on TDXD, around a third of them received TDM1 after, and the patients who were on TDM1, around 17% received the other antibody drug conjugate. In terms of safety, major side effects were, or the common side effects, GI, so nausea, vomiting, and of course we all know about the pneumonitis, which was around 10% of the patients who had pneumonitis. Another trial, which was the HER2 CLIMB, which was looking at tucatinib, so this presented in the end of the 2019, tucatinib and trastuzumab plus capecitabine in previously treated HER2 positive breast cancer. This is a phase 2 trial, large number of patients, 612 patients, who were progressed after trastuzumab, pertuzumab, and TDM1, and then they were randomized to receive capecitabine, trastuzumab with placebo or with tucatinib. Primary endpoint was PFS, and we all saw the results of this. And what was specific about this trial, that they included brain metastasis patients with active brain metastasis. So PFS was favoring the tucatinib group, and also if you look at the OS, again favoring the tucatinib group versus the placebo group. And in terms of overall safety profile, major side effects are diarrhea with the tucatinib. So you can see around 80 plus patients, 80% of the patients had some sort of grades, different grades of diarrhea. Then we have the HER2 CLIMB, which was presented in San Antonio breast conference in 2023, which is the HER2 CLIMB 2. Basically, it's tucatinib with TDM1 in previously treated HER2 positive breast cancer. So again, this is a phase 3 trial, and then they randomized the patients to receive either TDM1 with placebo or TDM1 with tucatinib. They allowed patients with brain metastasis in this trial, and this was progression after first-line treatment. Okay, and PFS was the primary endpoint, and you can see here that there was an improvement in PFS in patients with all the population, and also the patients with the brain metastasis. All the improvement was not that great, the difference. In terms of safety profile, the major side effect was the ALTs in both groups of the patients here. And now the question remains, after the breast 03, Destiny breast 03, it was it was a standard of care. The guidelines were updated as TDXD to be the second line treatment. But the question remained is what to do after that. We didn't really have much data to say what to do after that. So we have some real-world retrospective studies. This is one abstract published by Dr. Tarantino in the San Antonio Breast Conference, and looking at the after TDXD in the HER2 positive group. And you can see that different treatments, capecitabine with trastuzumab, tucatinib, a median of 4.7, endocrine treatment, chemotherapy with anti-HER2 antibodies, and so on and so on. And they all show similar PFSs, with the exception here you see the ADC, the sacituzumab govitecan, much less, which tells you probably there's a cross resistance between the ADCs with the similar topoisomerase. And if you look at the real-world data also here, and looking at the behavior of tucatinib treatment, so they looked at the patients with HER2 positive metastatic breast cancer, 300 from the electronic health system, and 3,000 plus patients were identified. 216 out of those received tucatinib. And if you look at the real-world time to discontinuation or real-world time to next therapy or overall survival, they were similar to what was seen in the study. However, out of those 216 patients, there were actually 35 patients who received tucatinib after TDXD, and they showed that these numbers were a little bit less, but it still shows that they do have activity after the TDXD. And other therapies that were explored also at that time, and you can see them also as I showed in the guidelines. So pan-HER2 kinase inhibitors such as neratinib, pyrotinib, and these two have approvals, and also mirvetuximab. In our center, Kuwait Control Center, we don't have any of those drugs. I don't know if this is available in the UAE, any of the neratinib, marvidina. No, not. Okay. So then you can see until the end of this year, this is how the guidelines looked. And so the treatment paradigm beyond 2025, and we're not even a month after 2025, we're still in the beginning of 26, and they already updated the guidelines in the NCCN. We all know or have seen this trial, which is the Destiny Breast 09 that was presented in ASCO last June, June 2nd, so 2 days before my birthday. I was born June 4th. And basically this was looking at sending the TDXD even up the ladder and trying to challenge the first line treatment, which has been this first line for over 10 years. And so the Destiny Breast 09, again, directly compared the TDXD either with placebo or the pertuzumab versus the THP, which was the standard of care or is the standard of care. And the primary endpoint was looking at PFS and OS. And you can see that there is stratification factor, which is de novo and versus recurrent, HR positive, HR negative, or the PIK3CA mutation either detected or not. And these stratification, because of the either we know certain de novo would fare better than recurrent, HR positive better, and then the PIK3CA mutation, again, it's the pathway for resistance. And we also the results of a PFS clearly favoring the TDXD, so statistically significant and clinically meaningful PFS with the TDXD versus pertuzumab. And I just want to point out that this trial only showed that arm results. It did not show the placebo yet. And then if you look at the PFS and the subgroup analysis, especially the stratified, the pre-specified stratification, again, PFS benefit was seen in the TDXD plus pertuzumab versus the THP was consistently observed across all the pre-specified subgroups, including the de novo versus recurrent or HR positive or negative, or PIK3CA is available or not detected. Overall survival is still early data, but they suggest a positive trend favoring the TDXD and pertuzumab. And we have an update, which was presented also in Berlin this 2 months ago or 3 months ago, in those specifically stratified groups, pre-specified groups. So the PFS by prior treatment status, again, TDXD plus pertuzumab favored in terms of the de novo or recurrent, regardless, favoring that group versus the standard of care THP. If you look at the objective response rate and duration of response, similar results, and you can see more CR in both groups favoring TDXD and pertuzumab. And then if you look at the PFS by hormone status, positive or negative, again, superiority for the TDXD plus pertuzumab, and then similar results with the objective response rate and duration of response, and again, similar for the CR. And then for the PIK3CA mutation, whether they had the mutation or not, you can see similar results, and similar for the objective response rate and duration of response. So you can see moving from the ladder, third line, second line, and now it is challenging the Cleopatra and the first line. Now we have 2 maintenance trials, the HER2 CLIMB-05, which is using tucatinib as a maintenance. So once they have the treatment with THP 4 to 8 cycles, and they go on the maintenance dual anti-HER2 therapy, so addition of tucatinib versus a placebo. And then again, if you look at the results, which was showing that this was last month, Investigator assessed PFS favoring the addition of tucatinib versus placebo, as you can see here in the graph. So the median PFS was significantly longer in patients receiving tucatinib. And then if you look at the PFS by subgroups, again, in all the subgroups, they were similar, with the exception, if you look at here, by hormone receptor, you can see the hazard ratio in the hormone positive was 0.7, and it was better in the hormone negative. I want to just suggest or keep note that the the positive, only 50% or even less received hormone therapy. So maybe the blocking of this pathway affected. And if you look at the CNS PFS also on the bottom right side here, you see that favoring the median months, 8.5 compared to 4.3 with the CNS. Safety, nothing that we don't know about any of the two drugs. Basically diarrhea, ALT increase, and so on. Just for the sake of the time, I want to also talk about patina, looking at palbociclib as an addition of palbociclib as an also maintenance in the HER2 positive, ER positive patients, addition to the endocrine therapy. So in the past, Cleopatra stopped the chemotherapy, add endocrine. So here they're adding palbociclib. And primary PFS favoring the palbociclib group, so as a maintenance, as you can see here, compared to the placebo, the endocrine by itself. And then the safety, there was nothing that we were not familiar with in terms of using these drugs in the past. So reshaping the guidelines, since I'm late by 1 minute now, this is how the 2026 guidelines, they already, based on the information that I already showed you. So Cleopatra, trastuzumab, pertuzumab with the taxane still remains as a category 1 with maintenance of pertuzumab, trastuzumab after 4 to 8 cycles. If HR positive, then they do say here that you add an endocrine therapy plus minus palbociclib. In the first line also, you do have, if you see if HR positive, an aromatase inhibitor plus palbociclib. So TDXD also is as an option. In the second line, capecitabine, tucatinib, trastuzumab based on the HER2 climb. TDXD is also as a second line category 1 based on the Destiny Breast 03. TDM1 is still an option. And then you have the fourth line and beyond. There's no preference, but all the different anti-HER2 medication that we have, and based on your availability and I guess toxicity of the patients, you will make a choice there. I come to the end of my slides, and thank you so much.
Many thanks, Anwar. I think he disclosed a lot of information. We know his date of birth, and we know he likes giraffes. That's for sure. For the next session, again, thinking that it's straightforward triple-negative disease, unfortunately, is the most difficult aspect of our clinical work. And Dr. He's ready to come and tell us about the new updates. So Dr. Rafi is a good colleague and friends trained in the UK, but he's been, I think, very vocal about how we treat triple-negative disease, and he was going to share his views about it for the next 15 minutes. Unfortunately, we're running late, so we'll ask him to take the time. Thank you.
Thank you so much, everybody. Good afternoon to you, and I'll try to be as quick as possible. So what have we learned so far about metastatic triple-negative breast cancer? We have learned that obviously triple-negative breast cancer patients, they have more TILs, they express more PD-L1, and they have more mutations. And therefore, people were interested. They looked at see whether immunotherapies, they work in triple-negative breast cancer. And what we learned, actually, they had a modest activity. And in fact, these modest activity more specified in first-line setting rather than later line setting. If you also look at the TMB, you see that probably we have a little bit better response with immunotherapy in high TLB. So this is basically, it showed us that patients who receive immunotherapy, they probably are more likely to respond to treatment if we use it in the first-line setting, higher TILs and more PD-L1 expression. So based on that, we had Keynote 355 designed, and that was a combination of chemotherapy and immunotherapy with pembrolizumab, and that showed actually that it improved PFS and overall survival, mainly in PD-L1 positive patients. So we moved on to see whether it actually works in with other immunotherapies, and it did not show actually that, we know that atezolizumab in both in patient 130 and patient 131, they were negative. But we tried to actually learn to see whether a patient with early relapse may actually do better, if they are having a little bit more earlier relapse. And, in patient 132 did not confirm that. So, patients actually who receive immunotherapy, if they had a relapse less than 12 months, did not benefit from addition of immunotherapy to chemotherapy. So we learned that, if we give immunotherapy in combination chemotherapy, mainly in PD-L1 positive patient, earlier line of setting, and possibly not in early relapse. How about targeting other stuff in the triple negative breast cancer? Of course, we learned that PARP inhibitors, they work better. Olympiad showed better PFS and probably not so much in difference in the overall survival. We also learned from Embraca that we have almost exactly the same improvement in the PFS, not so much in the overall survival. But the benefit of the PARP inhibitor was not also limited to germline BRCA mutant only. Patients with PALB2, probably they benefit even better than BRCA mutation. As you can see down there, 82% response to treatment as well. How about if we try AKT inhibitors? Because, we have definitely some abnormalities in the PI3 kinase pathway. In fact, the first one is down there in opportunity did not show addition of AKT inhibitor ipatasertib from Roche to paclitaxel improved the PFS or overall survival. AstraZeneca thought that they had better AKT inhibitor, and then therefore they combined it with taxane again. Unfortunately, it came back with the same result, no improvement in PFS or overall survival. What do we do with the CDK4/6 inhibitor? Because we know that some of these, the CDK4/6 pathways, they are aberrant in triple negative breast cancer. We did not show actually any improvement addition of with abemaciclib or trilaciclib, as you can see on the other side of this slide. So, so far we have not been actually doing very well. We know that a proportion of these patients, they have androgen receptor pathway aberrations as well. And we have tried actually quite a bit of these things as well, biclutamide, enzalutamide, abiraterone, etc. And you can see there is a little bit of modest activity, not so much that you can write home about, so, but around maybe 20–30% of the patients. So if you are running out of option, and if your patient, you probably can give it a try. I have actually tried a few patients with enzalutamide before. It doesn't work in my own opinion. So we know that again, PARP inhibitors are a little bit beneficial. AR inhibition has a little bit of modest activity. AKT inhibitors probably they do not work. How about the ADCs then? So of course, as Dr. Raja reviewed it very nicely, ADCs is new types of treatments, and ASCENT 04 clinical trials basically it randomized patient as receiving SG plus pembrolizumab in PD-L1 overexpressed patient compared with chemotherapy and pembrolizumab. Two things about this one. One is that it only allowed patients who had relapse after 6 months from the previous treatment. So no patient had relapse before 6 months were allowed into the clinical trial, and quite a lot of these patients also had around 80% of these patients, and they cross over to receive sacituzumab govitecan. Like I said, around 18% of the patients, they were only between 6 to 12 months, very, very small number of patients. Majority of patients, they actually have either de novo metastatic disease or they have a recurrence after 12 months from the neoadjuvant or adjuvant chemotherapy. So we can see certainly it did improve progression-free survival. Overall survival is not mature, but it is unlikely to be positive, given that around 80% of these patients, they crossed over to receive sacituzumab govitecan. It's actually not an easy drug to take either. It gives you a lot of neutropenia. Majority of these neutropenia, around 43% of your patients, they ended up admitting in the hospital with grade 3 neutropenia. It gives quite a bit of fatigue and diarrhea, etc. So it's not an easy drug to give. Nonetheless, we wanted to know whether actually it does work in low PD-L1 expressors as well. So ASCENT study, ASCENT-03 study was presented in this ESMO a few months ago. And again, it did recruit patients who have relapsed after 6 months. It did not allow any patient between 0 to 6 months after their neoadjuvant adjuvant therapy. Patients should have either had a negative PD-L1 expression, or if they had a previous PD-L1 expression, it should have been really a long time ago. So like you see that only around 20% of patients, they had 6 to 12 months from their time of relapse. Majority of these patients, they have either de novo metastatic disease or had a recurrence after 12 months. And 99% of these patients, they were PD-L1 negative. It is actually a positive trial showing that improvement in the PFS, and also we are waiting to see if overall survival. Again, quite a lot of these patients, they have had a crossover, so we have to wait and see. In fact, it was published 2 days ago at New England Journal of Medicine. Again, this is the safety as we discussed. We have other ADCs, and we are likely to see a lot of these ADCs in the next few years. We have Dato-DXd, that they are inherently different as well. They have different target, different payloads as well. And the Tropion-Breast02, actually, it is similar design. There was no minimum disease-free survival. So actually, patients immediately, if they had a recurrence of disease after the neoadjuvant or adjuvant therapy and had a relapse, they could go into this clinical trial. Around actually 16% of these patients, they were like this. So actually, it recruited patients who are more difficult to treat as well. So you can see that the PFS was improved, highly statistically significant. Overall survival, definitely there is a good trend towards it. It is not yet mature. And there is a definitely better overall or objective response rate with Dato-DXd compared with the other chemotherapy. Certainly, all subgroups, as you can see, they do benefit from Dato-DXd, or again, for the overall survival as well. As Dr. Raja mentioned, this ADC comes with some also other side effects as well. Eye toxicity, stomatitis, they are difficult. Some clinical trials being done to see, whether we can improve on that. But it also comes with some neutropenias and anemias and bone marrow suppression as well. Trastuzumab deruxtecan, as Dr. Anwar mentioned, it has overhauled HER2-positive disease. How about the triple-negative disease? Certainly in DESTINY-Breast04, a proportion of patients, they had HER2 low, and also they were hormone receptor negative. And as you can see, in fact, T-DXd did improve the PFS and overall survival in that group of patients. It has recently been published in Nature Medicine as well. So it is very encouraging, and you see that it's almost around 17 months OS benefit, OS with T-DXd, around 11 months OS improvement. But the question is that how do we actually, now we have a few of these things, how do we sequence them? We do not have a lot of data. We have very, very small amount of data. Recent publication in 2025, you can see that, you can start patient with SG, then give T-DXd, or T-DXd, then SG. You probably can ignore the bottom part because it's only 3 patients. But, if you look at the top part, which we have around 25 patients, you can see it's still sequencing one after the other is probably not a good idea. If you start with the ADC1, it gives you PFS of around 7.5 months. Then PFS after the second ADC is probably going to be around 2 months only. The same is true for the overall survival, which is significantly reduced with the second ADC. So in fact, there is a clinical trial ongoing, TRADE-DDXD. We're trying to learn to see how to sequence these medicines as well. So on the horizon, we have a few other things coming up. We have sacituzumab trimetican. It's actually a very interesting and very promising ADC as well. We'll see how it goes. But you can see that it actually works with or without PD-L1 expression, giving you around 72% response rate and certainly improvement in PFS as well. So we just have a look at that. There is a clinical trial combining it with pembrolizumab. So we have to wait for Trophuse 11 to see whether that is going to improve anything compared with the sacituzumab trimetican or as well or not. Then we have Dato-DXd combining with PD-L1 inhibitor. So, and this is actually, the Begonia trial is of interest of Professor Schmidt. And in fact, we saw a very good response, both in addition or without addition of durvalumab. You can see that the response rate is around almost 80% in both groups. So really, we look forward to just hear about more of this Begonia trial. We will learn more how to actually follow these patients up, and then as you can see that clearance of the ctDNA is going to be an important thing to follow your patient, and then in terms of the prognostication, so we will learn a little bit more about the ctDNA dynamics in metastatic triple-negative breast cancer. And then the more difficult one is, of course, what to do with the second-line therapy after we have treated patients with all of these ADCs and everything in the first line. That will be difficult. Currently, we are using sacituzumab govitecan in the second line as well. That is, and then this is what the guidelines are telling us to do in terms of the second line therapy in patients with germline mutations and without any germline mutations. We have SAC-TMT, of course. We discussed that. This is coming in patient again in second line setting, and this is really quite promising data coming from SAC-TMT. So we just look forward to have more mature data on that one. The response rate is certainly very good for second line setting after the patient have progressed on the first line setting as well. We have a Chinese medicine coming again in the second line setting, and hopefully that is going to mature as well. Quite a lot of other things. Hossam is telling me to be more quick. Ivanatinib is a bispecific treatment that's been actually very promising in lung cancer if you are treating patient with lung cancer. So we are trying to learn out whether it is going to do the same in triple negative breast cancer. So I have 1 minute 7 seconds remaining, Hossam. So hopefully I have done it well. Thank you.
So I'll take advantage of your 1 minute. I'm going to steal it from you. And I need to invite all of our speakers, please, and our panelists. We have to invite Dr. Dima Abdel-Jabbar and Dr. Maroon Khouri. Dr. Maroon Khouri is the Chief of Medical Oncology at the American Hospital. Dr. Dima, is she around? Peter, please. Saeed, Dr. Hussam. Dr. Anwar, of course. To start with, I want to thank very much our speakers. Very nice presentations, and I think this will open the discussion for lots of questions. And I want to welcome Dr. Maroon Khouri, Chief of Medical Oncology at the American Hospital. And I think you've listened very nicely to the presentations. Very nice data. I want to start with the HER2 positive disease presented by Dr. Anwar. how can you see the new implementation of bringing the TDXD in the first-line setting? And do you think this will go for every single patient? We're going to push the Destin Breast 09 to the first-line setting?
I mean, this is very important information. I mean, bringing TDXD with pertuzumab to the first-line setting. But the problem I think we're going to face is that we were happy with Cleopatra THP in having a certain number of cycles, and then patients can be continue chemo-free. Now, how long you're going to continue the TDXD? I mean, are you going to continue until maximum response and then you put them on maintenance? Or it's just, I mean, you cannot keep going for 2-3 years, in my opinion. So I think in general, what's going to happen is that in my practice, for example, I will continue until maximum response and then move, for example, to Herceptin and pertuzumab with some endocrine therapy in ER positive, and maybe also use the patina on top of that. So, I mean, this is, I think, the main problem is going to be how long you're going to continue on the TDXD.
Can I just one comment? I think it's very important to stick to the entry criteria to that trial. So this was not for all comers. These patients has to be high risk disease. So I agree with Dr. Maroon that this is not going to be for all comers.
Metastatic. Destiny Breast 9.
Yeah, but they still included the higher risk, I believe. It was not all comers. Well, that's the other definition. How do you define? I mean, it's open, but they use the specific criteria, I think. But this is not for all comers. And I agree, the chemotherapy option being endless is not going to be practical. And that's why we have another trial that's going to give a short period of TDXD followed by something else, perhaps back to trastuzumab, pertuzumab. Maintenance. So I think that may be the future because no one is going to give TDXD till progression in real life.
Dr. Anwar, since you presented the data, which of the patients are not going to receive TDXD in the first line?
With pertuzumab.
With pertuzumab, of course, yeah.
So I think that, in my opinion, the trial answers some questions, but it raises more questions, much more questions. You know, we know that TDXD after Cleopatra works really well. It's very powerful, but giving TDXD first, what comes after, it's not very clear. I showed some data that what is used after TDXD, we don't have many data to show that there is a very effective treatment. So yes, Cleopatra TDXD, we have evidence for that, but the opposite, we don't know yet. Is it for all patients? Definitely not. I say definitely not. Patients maybe with visceral crisis, yes. Patients with high burden disease, brain metastasis, yes. If you want to look at the subgroup analysis, maybe with although that didn't show differences, but PIK3CA mutation, since they have a resistance downstream that pathway, so to anti-HER2 therapy, so maybe those patients, does that mean now we have to do NGS for all those patients too? And probably also toxicity profile. So looking at the patients with certain lung disease, so you want to avoid TDXD probably. So yeah, but definitely not all patients.
Thank you so much. I have to move to the most complicated part. And Dr. Fashing tried in his presentation to avoid the combination. So for the last ESMO, ASCO, San Antonio, seem to be lots of combination coming in the ER positive after the first line. So where we are going, how are you gonna help us to choose what combination in the future? Because the research coming from every point.
I am not going to help you. You have to make up your own mind. I mean, we've learned, I mean, there's some observations I think that are worth pointing out. I think what I showed in the presentation that, you know, we have worked on the side effect profiles of the PI3 kinase inhibition. So that seems something that's now much more feasible in clinical practice. So let's put a check on that. On top of that, we're just learning about the combination with the SERDs and the CDK4/6 inhibitors. That's for sure something that needs some attention in the future. the EMBER-3 study was not able to get the registration for the combination of abemaciclib and imlunestrant for now in the United States. It's approved as a monotherapy, but for sure, everybody's very interested in that combination. And then adding a PI3 kinase inhibitor on top of that is something that's explored in clinical trials. I mentioned the KAT6 inhibition. Now there's an epigenetic pathway that is a target of a new trial that's out there. The KAT6 study is already up and running. It's including patients. There's some interesting side effects with that treatment. But mainly, we're in the endocrine resistant, overcoming with the SERDs, overcoming with the PI3 kinase inhibitors, and then possibly now with the KAT6. So no, there's 3 different approaches at the time point right now. And then we have to figure out the testing. I know that here in the region, you guys are far ahead with the accessibility to genomic testing. That's not the same everywhere in the world. So that's something you have to concern with. But SERENA-6 will be a challenge, having a testing every 3 months. That's quite intensive, but it's doable. So I'm not going to help you. I'm going to throw more data at you in the next few years. So you have to make up your own mind.
So that's not helpful at all, really. So I have to push the microphone to Dr. Farhat and said, well, Dr. Fashion seemed to give us more and more option. But generally, how are the guidelines? How are we going to present the NCCN or the ESMO guidelines on a screen in the next year? What's your prediction?
I think rather than have these sorts of sequential 1, 2, 3, I think we're going to have lots of circles where there's going to be arrows going in every direction. And I think it's probably going to be a situation where we dominate our choices based on toxicities. And that's quite right, because up to now we talk a lot about toxicities, but we actually then ignore it. And we had very limited options. So regardless of whether the treatments were tolerated or not, we just had to stick to them. Now that we will have a whole array of treatments, I think toxicities really can come into the center, and we choose what we give our patients based on toxicities. I think cost is now going to become more and more of an issue. As I said previously, in the in England, we don't have any of the ADCs approved in ER-positive breast cancer. So I think funding and financial toxicity is a real concern as well. And I think it's those combinations which are really going to help us or force us to do certain sequences. It'll be what is available.
I think that's super important, and it's like we were joking a little bit, but we have to realize almost every single metastatic breast cancer patient will still die of that disease. Even if you're having overall survival benefits in some of the studies, there's a tiny minority that will die of something else. So now having more and more therapy options, we are much more able to manage and to plan this last time of their lifespan of our patients together with them. And that's mainly driven by quality of life. That's mainly driven by the side effect profile of the respective therapies. And now we have more endocrine treatment options with the respective side effects. Later on with the ADCs, we have very effective treatments that also come along with a little bit more of side effects. And then I remain with my statement. We have to make up our own minds together with the patients, which sequences and which therapy options in the respective life situation of our patients makes the most sense.
One question to Dr. I'll have this question, then we can take yours. Dr. Saeed, you've presented the data of the triple negative, and again, we have an evolution bringing the ADC to the frontline setting, and we have 2 trials, which were positive than PFS. We have the Day-2 trial, and we have the sacituzumab govitecan, both of them in the first line. What other biomarkers, we're not talking about the PD-L1 positive, we're talking about PD-L1 negative. What other biomarkers can help us, for example, decide between both trials, decide between both molecules, which one we're going to go for, the triple negative and first line setting?
I don't think we have much at the moment, and I think we are currently probably using SG in a lot of our patients in the one that PD-L1 positive before. Now we can use it in, hopefully once it is approved, in the PD-L1 negative patient as well. But I think, as Dr. Raja mentioned, as the kids are getting better than their parents, we will have better and better ADCs. And I think, so far, ADCs not only been really transformative in hormone receptor positive and HER2 positive, but also really in triple negative quite a lot. And I think we have quite a lot of room to grow as well. We'll see a lot of biospecifics. We have CAR T therapies, by the way, they are being tried in triple negative breast cancer. So we'll see a lot, but as it stands, unfortunately, we do not have much biomarker to select between these.
Thank you, Dr. Said. Question
Thank you.
from the audience? Yeah.
Thank you. We know that HER2 positive metastatic breast cancer and also triple negative metastatic breast cancer are at high risk to develop brain metastases. My question, are you doing brain screening for this category of patient, or it's still symptom-guided imaging?
Personally, I do for all HER2 positive disease. That is for triple negative, it is not my routine practice to do, but for HER2 positive, I'll do it for all my patients. I don't know what.
So we use a lot of PET scans where we work, and although PET scans are not perfect in any way for screening of the brain, in fact, what we are seeing more and more is when there is disease, it is picked up on a PET scan. So in effect, we are routinely screening by accident, if you like, but we're not doing MRI brains or anything like that.
American Hospital, who would love to have the answer?
I typically don't screen unless they're symptomatic, but I make sure to tell the patient that the PET scan does not cover the brain. Because if somebody one day they will have brain metastasis, they'll tell you, oh, I thought the PET scan was negative. And so you have to explain to them that it doesn't cover.
Dr. Shahrayar, you have a question? Last question from Dr. Shahrayar.
Yes, I have one question on the metastatic triple negative breast cancer. So maybe for Dr. Said. And it has to do with the updated NCCN guidelines that we just saw. So in the PD-L1 negative category first line, we have the SG, which was given the preferred category 1 status, but the Dato-DXd didn't have that status. So it seemed like SG is being preferred. But if you look at the data, the TROPION-Breast02 is actually showing overall survival benefit, and in even other efficacy indices, it seems to be doing a little better. So why do you think the NCCN guidelines are preferred SG over Dato-DXd? Are there any other areas where there might be a preference for SG versus Dato-DXd? So just your thoughts.
Thank you, Hassan. I'm also very much baffled as well with that kind of decision, because to be honest, we have better data and possibly better tolerability of the trial. Exactly like you say, we have overall survival benefit for this one that is shown. And I cannot think of the reason why they have decided to give that preferred kind of a status to SG. Whether one of the reasons could be that we have more data in different lines of setting. This is why maybe whereas we have Dato-DXd, this is the first time. I cannot think of that one. But in my opinion, if Dato-DXd is available in this country, I'm hearing from our colleagues that it will be, I tend to use that one for my patients.
Thank you. More wider for the data, that's why it could be a reason. I don't know, but it could be.
But Dr. Shahrayar, we have really to respect the NCCN group. I think they did a great job. It's impossible to come in real life now looking at a weaker comparator that what looks at the Tropion-2 and ignore the fact that all the patients in the SG trial have crossed over. Finally, we have a panel that's able to say, by the way, guys, we should have a trials that have access to all treatment. Because hazard ratio comes out in Dato, and how many patients did not have ADC later lines? That's what we don't do this in life. ADC is coming to every life. So that hazard ratio is in a way exaggerated. I'm glad in a way we have NCCN panel look at this and said, by the way, guys, you need to design your trials in a better way. And I hope that applies to so many, not just to triple negative breast cancer, but I'm sure they looked into this and they looked at the overall survival into taking consideration. But I'm so glad, we were all in the meeting and we know how many people actually congratulated the research group for allowing the crossover. And that's not me, that's the whole, what we call the whole at the time.
I am full of respect to for Gilead for deciding to provide this medicine upon progression. But you know, one thing is that as a scientific community, just look at from the science perspective, we are designing clinical trials to learn something, to see how we can move forward. And as much as really it is respectful to provide this G to all patients upon progression, it did not allow us to learn that overall survival rate from. That's my opinion.
This is a long discussion to be taken forward, and I don't think it is like a hypothesis generation because the trials were not made to be compared to each other, but definitely there is a change in the population, inclusion criteria, and further treatment which affect the OS data between this trial and that trial. So 4 seconds. So I would love to thank our panelists and presenters, and we're concluding this session, but we have 2 further satellite symposiums, and I would like to introduce again Dr. Peter Fasching. He's going to take the further talk. Yeah? Yes? Yes? Right? I'm correct? Yeah? Optimizing treatment strategies for HER2-low. No, again, we'd love to hear you.
This is a very short. Those are very short-term requests for me to do this. So apologies if I will look at one or the other slide. But we've learned a lot about breast cancer histology and the new treatments. And when I joined Dennis Sleiman's lab in 2006, 2007, and had the honor to meet Michael Press, who did a great job about 25 years ago establishing in situ hybridization and immunochemistry of HER2. So I learned a lot about that at that time, and we have to remind ourselves, if we're talking about HER2 as a diagnostic marker, we have to understand that this pathway was initially introduced as an amplification, not as immunochemistry. And the immunochemistry was later introduced to have a cost-effective way to identify patients in whom the pathway is activated. And that was 3+. That's what we see here on the left side. And that was about, in metastatic cases, about 25% of the cases, and in early breast cancer cases, about 15% of the cases. But then in breast cancer, not only in breast cancers, also in lung cancer and in some other cancers, there's a discrete expression of HER2 also in some of the patients. It's actually the minority where in breast cancer, there's no staining seen on the breast cancer cells. So as therapies evolved, and it's not only the ADCs, because the ADCs with the next generation, you can imagine if an antibody finds the HER2 signal here and the chemotherapy is released in the surrounding area by the bystander effect, we learned now with the DESTINY-Breast04 and DESTINY-Breast06, and this is what I'm going to talk about here in this symposium, it makes sense to also treat these patients. It's not only the ADCs. We've learned that from the cellular therapies with the CAR T cells, some CAR NK cell therapies, and maybe in the future also radioligands can take advantage of a protein being present at the cell surface, not necessarily driving the progression of this cancer, is just by the presence of the target on the cell surface. And that's the 2+, and that's the 1+. HER2 positive is a slang for HER2 pathway activated in the past. And we have to separate that from expression is present for possible new therapies in the future. So now the universe is changing. HER2, and I want to call it pathway activated, we learned with the DESTINY-Breast09, DESTINY-Breast03, ADCs that target anti-HER2 like trastuzumab deruxtecan are super effective. Hazard ratio is also 0.3, never seen before. But now we also have patients where the HER2 expression is present, the pathway is not activated, and that's DESTINY-Breast04 and that's DESTINY-Breast06. And the DESTINY-Breast06 is a study that I waited for quite some time because different from DESTINY-Breast04, it takes away the necessity to give a chemotherapy before turning to a super effective chemotherapy containing regime bound to an antibody drug conjugate. So the DESTINY-Breast06 study mainly addresses exactly this patient population, endocrine therapy in the first-line setting, endocrine therapy after that setting. Endocrine treatment is exhausted in most of the patients, and then not turning to chemotherapy or testing that question in a randomized fashion. Is the ADC, is the antibody drug conjugate better than the chemotherapy after 2 endocrine treatments? And that makes sense because now we can follow the guidelines and say, let's give endocrine treatment as long as we can. Endocrine treatment, endocrine treatment. And then the question in the DESTINY-Breast06 study mainly is the ADC better than the chemotherapy? What's the evidence so far to this point? In the first-line setting, the CDK4/6 inhibitors give us about 2 years of median progression-free survival. Then in the second line, the endocrine treatments, we've learned it's about 5 months with the SERDs, the ESR1 mutated population, PI3 kinase mutated population, about 7 months with the capivasertib. So we have very effective treatments already in the second line, so we can sequence endocrine treatment and endocrine treatment. If you would give chemotherapy, we know from the DESTINY-Breast04, we get a little bit less than 10 months in median progression-free survival. Again, just as a reminder, the spectrum has changed. If you're talking about HER2 positives or HER2 lows, we have the ones that are 1+ and the ones that are 2+. But there's also something that pathologists have not done up to this point, which is called ultra low. What is that? I'm not a pathologist, but our pathologist always says, Peter, if I look in the microscope and I see absolutely nothing, that's easy. You can do that. That's 0. And we have the criteria for 1+, we have the criteria for 2+, but there's a reasonable amount of patients, 20 to 25%, that are not 0. I see a little bit of stuff, but I don't see the criteria that I need, the faint incomplete membrane staining in more than 10% of the tumor cells being 1+. In between, there is a proportion of patients where you see some kind of expression, but it's not 0. And that's called ultra low. So the DESTINY-Breast06 study did not only address the question, is the T-DXd better than the chemotherapy after 2 endocrine treatments? That's the majority of the population. But there's also a subgroup in there that addresses this new population, ultra low. Does the treatment also work in that population? And that's where we have the study design. Treatment of physician's choice chemotherapy versus T-DXd. Is T-DXd better than chemotherapy? Mainly after 2 lines of endocrine treatment for metastatic breast cancer, maximizing the quality of life with this endocrine treatment. It was a large study. 866 patients were randomized. And as you can see here, you can see primary endocrine resistance, about 1/3 of the patient, de novo disease diagnosed, about 1/3 of the patients, and the majority of the patients had visceral disease at the time point of randomizations. The majority of the patients had 2 previous therapy lines as required by the inclusion criteria, 2 or more endocrine treatments at the time point of study inclusion. The data is known, it's not a new study. You know that the hazard ratio 0.62 led to an extension of the median progression-free survival time of about 5 months, and that's very in line with the real-world data that I showed you in my previous presentation, now extending of 8 months, now extending by another 5 months to 13 months. So now we are coming from DESTINY-Breast04, we have a little bit less than 10 months. Now we're going a little bit earlier in the setting, not giving the chemotherapy, now benefiting from a chemotherapy-containing regime in the form of an ADC to get the median progression-free survival time up to 13 months, hazard ratio 0.62. And that was the primary endpoint in the HER2 low population, which did not contain the HER2 ultra low. If you get all the patients together in one graph, it doesn't change a lot because the HER2 ultra low was only a subset, but you can already surmise that the results in the ultra low seems to be quite efficient too, but I'm having these data a few slides later. The overall survival at the time point where this study was presented was not mature yet. There was 40% maturity, hazard ratio 0.83 in the HER2 low population, and in the total population 0.81. So it goes into the right direction. But the benefit is a little bit more discrete compared to the DESTINY-Breast04 study, a little bit later therapy line, different patient population with a worse prognosis. And we might not see an overall survival benefit there, but at least we see it goes into the right direction, and we have a very prominent effect on the progression-free survival. Now for the question of the new population was a subset, about 150 patients randomized as being ultra low, not 1+, not 0. Median progression-free survival was again extended by about 5 months, very similar to the HER2 low, 1+ and 2+ without an amplification. And with regard to the overall survival, small patient population, but the benefit seemed to be numerically a little bit more prominent than in the HER2 low. Of course, the subgroups are always of interest to see, is there a population of patients that we don't want to treat, or where we have the idea that might be a population that benefits the most? And the answer to the question is actually not really. Specifically, in the discussion among clinicians, at least in Germany, is always, what about the chemotherapies? Many of us want to give the capecitabine because it's an oral treatment. Nab-paclitaxel was allowed, paclitaxel was allowed. You can see here there was no difference in the efficacy and the superiority of T-DXd with regard to the kind of chemotherapy. The question with the visceral disease is always a prominent one. There was no difference. All of these forest plots with the antibody drug conjugates looks actually quite boring because the therapy effect is actually really pretty consistent among all of the subgroups seen. In clinical practice, of course, overall response rate is something very important. That's something that we learned when we started to treat with the ADCs, that there's more and more conversations with the patients after 3 months, where you actually can have that conversation that the tumor got smaller, that there was a response. And you can see that here in this graph, in the HER2 low DESTINY-Breast06 population, a little bit less than 60% response in the HER2 low population, over 60% in the HER2 ultra low population, compared to the about 30% with the chemotherapy as the comparator. That's a huge change, and that has a huge impact on the patient conversations that we actually do have in clinical practice. I'm sure at this time point there's extensive experience here in the audience with the use of T-DXd. It comes at a cost. It comes with the respective side effects that we have to deal with the nausea and vomiting, the alopecia, and the fatigue that the patients report either after infusion or after a few months of the treatment, where fatigue, therapy-related fatigue might accumulate, and you want to think about some treatment holidays. But all in all, it has been established in clinical practice. It has been feasible, established in clinical practice with the respective side effects compared to chemotherapy, nausea, fatigue, alopecia, and of course, the interstitial lung disease is something, even if it's only 0.7%, and that's pretty consistent across all of the DESTINY trials, somewhere around 1%, a little bit less than 1% ILDs. From the real world setting, we see that data as well. It's a side effect we have to be aware of. It's a side effect we have to take serious, because if these cases happen at a high grade and these patients end up in the intensive care unit, they're very work intensive and actually lead eventually to a fatal outcome, as we can see here, with the very few patients in the DESTINY-Breast06 study 3, which is 0.7%. It always has to be pointed out, something we have to be aware of. If you're looking at the additional data that's been generated over time, of course, we're interested in looking at these patients in a way that we look at them in the context of therapy sequences. And there we want to know, how do patients behave or perform in the DESTINY-Breast06 study in a patient population that's quite resistant to endocrine therapy, so a fast progression under the endocrine treatment, less than 6 months, 6 to 12 months, and more than 12 months. And these are the populations, or these are the parameters we sometimes also base our therapy decisions for the oral SERT monotherapy on. And yet, as you can see here, there's a very prominent effect with a hazard ratio of 0.38 in the endocrine resistant or very endocrine resistant population, where the patients progress very rapidly in the first line endocrine treatment, and the hazard ratio 0.69, 0.67 in the 6 to 12 months and over 12 months. So you could get the impression relatively it's very efficacious in this population, but also you can see that the progression-free survival times and the time on the treatment is all quite impressive under the TDXD. As you can see here, the overall response rates and also the duration of response, as you can see here. So progression-free survival 2, some of us like this parameter, some of us don't. It's a parameter that was introduced by the authorities as a surrogate of whether the treatment effect maintains in the subsequent therapy or might be a surrogate for overall survival. This Kaplan-Meier curves are separating quite clearly with a hazard ratio of 0.62. And also, sometimes in clinical practice, there is a question about the disease burden when you have patients that have a very extensive disease, like here separated by 3 or more metastatic sites versus less than 3 metastatic sites. There's no huge difference in efficacy seen when you look at those Kaplan-Meier curves. So here is what we have already seen in the forest plot. That's the comparison with regard to the capecitabine on the left side versus on the right side versus taxane. That would be nab-paclitaxel or paclitaxel. Hazard ratios are very similar, and you get very similar improvement of median progression-free survival. Capecitabine, about 5 months improvement with a taxane comparison, about 6 months in the comparisons of very similar efficacy regardless of which chemotherapy we would compare this therapy to. The same is seen for progression-free survival 2, where you can see here hazard ratio of 0.62, on the right side hazard ratio 0.61, very consistent effects. It almost gets boring with all of these ADC stories because any message we see when we look at subgroup analysis, the message almost always is it works independent of whatever subgroup we're looking at. With regard to safety, the safety profile, if you're looking at these subgroups, seems to be very consistent to the overall population, so there's no difference with regard to that. Now, most importantly, what we've learned in the panel, quality of life and side effect profile is very important. We do know that the patients exhibit more toxicity with nausea and vomiting and fatigue, hematological side effects with regard to the TDXD. So looking at quality of life is very important. In the main analysis, looking at the EORTC QLQC30 score, there were not much differences in quality of life concerning the chemotherapy versus the TDXD, despite a more prominent toxicity profile, but some side effects that are mainly driven by disease progression might be even controlled better with the TDXD compared to the standard chemotherapy, as you can see here in the subscore of the QLQC30 pain subscore, where you can clearly see that the disease control by the more efficacious treatment leads to a later deterioration of quality of life with regards to pain. So the future, as we've learned through Destiny Breast 06, coming from Destiny Breast 03, everybody remembers the standing ovations Javier Cortez got at ESMO when that data was presented. Then in the next step with Destiny Breast 04 and Destiny Breast 06, the HER2-low population was addressed, adding a larger patient population to the pie chart. Now in Destiny Breast 06, also the ultra-low population is added, and we've seen there's not much difference in efficacy between these two subgroups. At the moment, more studies are running. We've already learned about HER2 not expressing population, HER2 completely zero. A new study is right now up and running, Destiny Breast 15, which also has a subgroup in there that has no HER2 expression at all. So I'm very curious to learn, do we even need at all a HER2 expression in patients treated with TDXD? We've learned about the guidelines, they're changing, but I think it's worth mentioning that the Destiny Breast 06 was implemented, as you can see here, In the second line, the TDXD is mentioned here as the preferred choice, and the other choices are if they're not a candidate for TDXD. And in the ESMO guidelines, there's a very similar statement as we've seen after exhaustion of endocrine treatments. That's what you see here in the upper part. You can see here at progressive disease, the TDXD is mentioned here, and even up here, if the patients don't get the endocrine treatment after the chemotherapy, if the patients have immune organ failure, it's already up here, the TDXD. So it's implemented in all of the guidelines in the respective situation, following the respective guidelines. I saved us 1 minute and 17 seconds. I think this should become the standard to mention that at the end of the presentation. I think you learned extensively today about the ADCs. Not sure I added a lot to the excellent presentation of the previous speaker here, but I think these treatments are, you know, the ones that concern us in clinical practice, because on the one hand, you have a super efficacious new treatments that also come with additional side effects. And now having endocrine treatment, then now the option to have this very efficacious treatment, I think has to be seen in this context and not only as a standalone thing. Thank you very much for your attention.
Thank you, Dr. Peter. Next is Dr. Ahmed, Chief of Medical Oncology, Tamam Hospital, who's going to talk to us about Selena 6.
Assalamu alaikum. Thanks, Dr. Dina, for the lovely introduction, and congratulations for Dubai Health for arranging the first PMOC conference. I know I'm the only barrier between you and the lunch, so I'm not keeping you late. I know the glucose level is low currently. So redefining the progression and the Selena 6 for ESR1 guided switch in ER positive HER2 negative. So as unmet needs in this part of ER positive HER2 negative advanced breast cancer, what we know that CDK4/6 inhibitor is the standard of care in the first line, and it did prolong the progression by 2.5 years. But unfortunately, once the patient progresses, the outcome is very modest. If you give endocrine therapy monotherapy, talking about 2 to 3 months PFS, even with the combination of target therapy, you talk about 5.5 months. So not only the shorter duration of progression, but also it has an impact on the quality of life. So once the patient progresses, there is a high burden of the disease, which has a negative impact on the quality of life. What we know from the real-world data that most of the patients discontinue CDK4/6 inhibitor because of the disease progression. And unfortunately, from real-world data, whether retrospective or prospective data from French or German data, that around 15 to 20% of the patient will never receive second line. So I believe that if you want to improve, we should improve in the first line. Oral SERT has been a standard of care and been approved in the second line and beyond. We have data from the Emerald, EMPER-3, and Vertex-2 showing that when you give the oral SERT, there is a risk of 40% of your patients, they will progress upon the first assessment. So we need to improve the outcome for those group of patients. So how to improve this? We have the data for ESR1 mutations. So ESR1 mutation, one of the most common acquired resistance in this field of the disease. And what we know that the prevalence of mutation, it's increased with the exposure to the endocrine therapy, mainly aromatase inhibitors. We have data also regarding the exposure to CDK4/6 inhibitor. The longer the exposure, the more the CDK4/6, the ESR1 mutation will be prevalent. So upon the diagnosis, 5% of the patient will have ESR1 mutation, but with the longer exposure to a treatment, it might reach to up to 40% of treatment. Those group of patients, they have a poor prognosis. The data from SOPHIA trial looking for the ESR mutation, positive patient, they have a shorter progression-free survival. So how camizestrant, the next generation oral third, can improve the outcome for this group of patients? So camizestrant is completely antagonist for the estrogen receptors. It degrades both mutation and non-mutation estrogen receptors. And if you're looking for the data from the BADA1 and SERENA-2, what we learned, what we know that the patients with the ESR mutation, when you switch from the aromatase inhibitors to fulvestrant, we succeed to improve the progression-free survival for those group of patients. And what we know also, the prevalence of ESR mutation more with the patient with the longer exposure to aromatase inhibitors, patients with bone metastasis and older age. The same data from the SERENA-2 looking for how the camizestrant can clear the ESR mutation from the circulation, and you can see clearly that camizestrant it succeeds to significantly reduce the detection of ESR1 mutation up to down to the level of the undetectable or near detectable compared to fulvestrant. It's not only how it's potent to clear the ESR1 mutation, but also how fast to clear the ESR1 mutation in almost in first 2 cycles. So that was the rationale behind the SERENA-6, and it's a phase 3 double-blind CT-guided trial looking for the combination of camizestrant and CDK4/6 inhibitor, or to continue the same CDK4/6 inhibitor and aromatase inhibitors for patients with emergent ESR1 mutation. So they screened more than 3,300 patients, and 3,250 patients was being tested. Almost 550 patients came positive, but it's almost like 2,000 patients still ongoing on the first line, and after the closure of the screening, around 315 patients was randomized in this trial. So basically, they include patients with the ER positive HER2 negative and on CDK4/6 inhibitors with aromatase inhibitor, those develop ESR1 mutation without any clinical or radiological disease progression, one-to-one to randomization fashion. So patient continue aromatase inhibitor and CDK4/6 inhibitor with placebo camizestrant, or to switch to camizestrant plus CDK4/6 inhibitor and placebo aromatase inhibitor, looking for a primary endpoint of progression-free survival. Progression-free survival 2, overall survival, and safety are a secondary endpoint. And here the baseline patient characteristic will balance it between the 2 treatment groups. When it comes to the site of metastasis, almost 40% of the patient with the visceral metastasis, even the time to detection of ESR mutation, whether less than 1 year or 1.5 years or more than 1.5 years, or the type of CDK4/6 inhibitors, it was well balanced between the 2 treatment groups. And here the primary endpoint, you can see there is significant improvement in progression-free survival. We succeed to extend progression-free survival from 9 months to 16 months with delta of 7 months. It's not only that, if you're looking for the curve, so you can see how early separated, and it was consistent improvement in progression-free survival, longer duration. And at 2 years of follow-up, we have almost 30% of the patients are progression-free compared to only 5%. Here the subgroup analysis, the benefit was consistent across all the subgroup patients, regardless of the site of metastasis, regardless the type of the CDK4/6 inhibitor backbone, regardless of the time of detection of ESR1 inhibitor, ESR1 mutations. The secondary endpoint, which is the time to deterioration of the quality of life, you can see that adding camizestrant, it's increased the time to deterioration by almost 4-fold, from 6 months to up to 23 months. And this is actually very important and quite significant. We're also looking for the subsequent treatment options upon progression. So we have more patients in the aromatase inhibitors arm, 52% compared to 36%. But there is some comparable when it comes to cytotoxic therapy, combining chemotherapy and ADCs in both group of patients. Safety profile, there is a very rare discontinuation in the camizestrant arm, and it seems it's very well tolerated drug. And this is a tornado chart when it comes to the toxicity. It was very comparable to the aromatase inhibitors, probably the ocular toxicity, which is something new for us. So camizestrant causing what we call photopsia or peripheral light flashes. This is mainly grade 1 or sometimes grade 2, and it's not impacting the patient daily activity. With the longer follow-up and adjusting the exposure, the incidence between the both arms are very comparable. So the conclusion from the Serena 6, it did extend the progression-free survival and also delay the duration of quality of life. So we have another update in the last ESMO, and it is looking for the patient-reported outcome. And if you can see that the frequency of measurement of patient-reported outcome was even more frequent than the assessment in the radiological scanning. And what we found that the camizestrant, it did improve the patient-reported outcome when it comes to the physical function or the symptoms of the patient, mainly talking about the pain, fatigue, and shortened breathing. This because of you delayed the progression of the disease and you prevented the patient suffering from disease progression. The same for the physical functioning. So patient ability to perform daily activities are also improved in favor of camizestrant, as well as the anxiety, depression, and irritability was in favor of camizestrant. The conclusion of this update in the ESMO that patient-reported outcome results was in favor of camizestrant compared to aromatase inhibitor. Another update from the last San Antonio. So the looking for the what we call the progression-free survival, it was really significantly longer in favor of camizestrant. And also looking for the delay of initiation of chemotherapy, it was also significantly longer by adding another 6 months before initiation of the cytotoxic chemotherapy. And the most important, why we are using camizestrant to decrease the development of ESR mutation. And you can see by using camizestrant in the first couple of cycles, you almost eradicate or clear the ESR1 mutation, while the patient in the control arm, the ESR mutation increased up to 500 times. Longer follow-up showing that there is no any new safety signals from using camizestrant. And the conclusion from this, the latest update is switching in the first line from aromatase inhibitor to camizestrant in patients those develop ESR mutation. It was associated with a longer progression-free survival, longer delay in the duration of quality of life, and I think it should be a standard of care. So how we see this in the front line, I believe that in the first line, we have been testing for the PIK3 kinase because of inovolasib, and now patient in first line, I think we should test for ESR mutation periodically, and once the patient develop ESR mutation, camizestrant should be added to CDK4/6 inhibitor to delay the progression and as a maintenance in first line, and upon progression, if patient is still eligible for endocrine therapy, so probably we go to endocrine therapy before switching to ADC or chemotherapy. With that, I will thank you for listening. I saved 8 minutes, which is a record.
Thank you, Dr. Ahmed, for the nice presentation and the nicer timing. Thank you so much. So we finished our morning session so far, and we're going to steal this 8 minutes from Dr. Ahmed, and I need to invite you to go for lunch. The lunch will be served at kitchen 6, is going to be in floor 1. We'll be back here at 2020, so please be on time. Looking forward for continuation of our sessions for the rest of the day. 2:20. Huh? 2 p.m. 14:20. English timing 14:20. Thank you. Thank you so much.
afternoon. I think we better start. I know people are still having their lunches. Kitchen 6 is really good. So this is the second part of the day today. So we're starting with GI cancer. We'll start with upper GI cancers first. And with me will be joining Dr. Ali Khamaz, consultant GI surgeon, working at Rashid Hospital, an important part of our MDT. So without any further delay, let me introduce our first speaker, Professor Lorenzen. She's a consultant hematology oncology and head of the early clinical trials unit at the Technical University from Munich, Germany. Her research focuses on medical oncology, GI cancers, and also phase 1 clinical trials. She served as PI and sub-PI in many clinical studies and makes a part of the gastric cancer task force in the region as well. And she has been part of the steering committee in the Bavarian Ethics Commission and contributes to the guidelines development as well. Let's welcome Professor Lorenzen.
Yeah, thank you very much for this kind introduction. It's a real honor and pleasure to be here in Dubai. It's my first time. And I must say, I really appreciate it because of your great hospitality. Everything works properly, like in old Germany. And also your outstanding food. It's really delicious. So I really appreciate it that I can be here for only one day. And yes, as mentioned before, my focus is upper GI cancer and basically gastroesophageal cancer and in this case, locally advanced disease. So that's what we're going to talk about in the next 15 minutes. Here are my conflicts of interest. And when the patient first comes to you, the problem is they all want to know how long can they survive with a new treatment. And this is most important when we talk about locally advanced disease and what we have achieved in the last 20 years. So of course we have treatment goals like alleviating symptoms and improving quality of life. Most important, extending overall survival and increasing the rate of cure. And this what we achieve by exposing tumor cells to as many killing mechanisms as possible. And of course we can learn from every patient. So going into detail with regard to perioperative treatment here on the slide, I made an overview of all positive trials you see in blue, and the gray ones, these are trials which didn't change standard of care. And for me, the most important trial up to 24 was the FLOT trial, not only because it was developed in Germany by Salah Albatran, but because it is established the standard of care worldwide for locally advanced disease. Why is this FLOT compared the old MAGIC standard versus the triplet with taxane-based therapy? And the results showed an improvement in our resection rates as well as downstaging to more smaller tumors, T1 tumors, as well as nodal negative tumors. And of course, most important, an improvement in overall survival of nearly 10%, as well as an increase in the 3-year survival rate and the median overall survival up to 15 months. However, still 50% of patients die, and we know that we are at our limit with regard to adverse events and toxicity, and therefore we have to treat patients smarter and not harder. So my talk will focus on 4 burning questions. First, the role of neoadjuvant radiochemotherapy, then the role of postoperative immunotherapy. The focus will be, of course, on the role of perioperative immunotherapy, and latest, the role of immunotherapy in the subtype of MSI-high cancers. Since more than a decade, there was a strong battle between the Netherlands and Germany. What is the best perioperative approach for G-junction tumors? And as you know, G-junction tumors are on the rise, and we see a 40%, 400% increase within 1 generation. And this is, of course, because of the Western lifestyle habits with increasing rates of obesity and reflux. So the German surgeon Jens Höppner did the first phase 3 trial comparing preoperative radiochemotherapy according to Cross versus the German standard perioperative FLOT followed by resection, and the primary endpoint was overall survival. Jens Höppner presented this at ASCO late-breaking abstract in the plenary session in 2024, and the reason for this was that this was a positive trial in terms of improvement of median overall survival as well as 3-year overall survival, and this was clearly significant. And he also showed in ASCO 2025 why was this, and this was because of the more systemic effect of FLOT with a reduction in distant metastasis by 16% and the same control of local disease. So with FLOT perioperative, we have a more systemic effect compared to neoadjuvant radiochemotherapy and a clear reduction in distant metastasis, which finally leads to an improvement in overall survival. And with these results, the ESMO guidelines were adapted so that also for G-junction tumors, FLOT in the perioperative setting is the standard of care, and only patients who can't handle FLOT regimen due to side effects or age, whatever, are candidates for neoadjuvant radiochemotherapy. And this brings us to my second burning question, the role of postoperative immunotherapy. In patients who receive neoadjuvant radiochemotherapy followed by an incomplete resection, the CheckMate 577 trial established nivolumab as standard of care by an improvement or doubling in disease-free survival with 1 year of nivolumab. We all waited a long time if this improvement in event-free survival will finally translate in a prolongation of overall survival. And these results were presented by Ronan Kelly last year at ASCO, showing that there was a trend with an improvement by 16 months. However, this was not statistically significant. And if you can remember, in this trial, there were 70% of adenocarcinoma patients and about 30% of squamous cell patients. And we always doubted the effect of immunotherapy in adenocarcinomas. And the subgroup analysis of this overall survival data showed that we are quite right in our feeling that adenocarcinomas do not benefit in the same way as squamous cell cancers. And if you look at the hazard ratios for adenocarcinomas and G-junction tumors, you see that these patients do not derive any clinical benefit from the addition of nivolumab. So although BMS never showed the Kaplan-Meier curves for G-junction adenocarcinomas versus squamous cell esophageal cancer, I think the radiochemotherapy followed by nivolumab doesn't have any role anymore, since we know the positive results of ISOPEC and Matterhorn for perioperative FLOT or DFLOT. So no longer relevant radiochemotherapy followed by nivolumab, only in exceptional cases. However, for squamous cell carcinoma, I think this is the most appropriate regimen we have available at the moment. So in terms of perioperative immunotherapy, immunotherapy was first tested in the adjuvant setting. And of course, there is a question, why shouldn't we give it up front? There were some positive trials from Asia, also from Europe, showing that immunotherapy might play a role. However, why shouldn't we bring it up front, where more patients are able to tolerate chemo and immunotherapy? And therefore, there were several phase 2 and 3 trials looking for the addition of immunotherapy. The first trial was our own Dante trial, where we looked at the addition of atezolizumab to perioperative FLOT, showing a significant increase in path response rates, and this was more in patients with a higher PD-L1 expression. So PD-L1 expression enriches for response. However, it was only a phase 2 trial. The phase 3 Dante trial just finished recruitment and is in follow-up, and we're waiting for the results. The first phase 3 trial was the Keynote 585 trial, looking at the addition of pembrolizumab to either a doublet regimen of cisplatin 5-FU, and then it was amended to FLOT regimen. So it was quite a confusing trial with different statistical endpoints, also showing an improvement of path response rates by about 10%. However, this trial was a negative trial in terms of event-free and overall survival. There was almost 20 months improvement in event-free survival. However, this was not statistically significant, and overall survival was completely similar. So everybody looked, of course, for the straightforward Matterhorn trial, which used the triplet FLOT regimen as a perioperative trial with the addition of durva versus placebo, and the primary endpoint was event-free survival. These data were first presented in 23, also showing an improvement in path response rate by about 10%, so it was in line with what we knew already from Dante and Keynote trial. And then finally, Jelena Janjigian last year presented the primary endpoint event-free survival, which was clearly in favor for the addition of durvalumab. And there was also a trend in overall survival, but this was not yet statistically significant. Looking at the subgroup analysis, and this is important because we know that around 10% of patients did not have a PD-L1 expressing tumors versus 80% were TAP positive. We were all quite worried if this is now an all-comer new regimen, or is it just for biomarker selected patients. And you see here, of course, patients with a PD-L1 expression, a TAP positive score, had a hazard ratio of 0.70 compared to 0.77. And also looking deeper into the subgroups, it seems that patients with an intestinally differentiated tumor do better than diffuse type of cancers, and also female patients and nodal negative patients do not have the same benefit. However, looking at the overall population, there is a benefit over all subgroups. I had the honor to discuss the overall survival at last year's ESMO in Berlin, and this is one slide of my discussion. And as you can see here, with more events and a longer follow-up and a higher maturity of results, overall survival became significant with a p-value of 0.021, hazard ratio 0.78 for improvement also in overall survival. And if we, excuse me, and if you look what we have achieved in the last 20 years, starting from the British MAGIC trial with ECF, ECX, showing that with surgery first in stage 3, we have only a 2-year survival rate of 41%. Now with the DFLOT regimen, we're reaching up to 75%, so an increment of 35%. I think this is clearly relevant for all our patients with locally advanced disease. And as Sam Klempner, who discussed these results at ESMO, said, I fully agree that DFLOT is now the new perioperative standard, independent of PD-L1 expression. And this was already implemented in the latest NCCN guidelines. However, there was a very conflictive discussion between the expert, and now the recommendation is just for PD-L1 positives. However, the FDA approved already durvalumab in November, independent of PD-L1 expression, and EMA approval is still pending, although we already implemented DFLOT in our national guidelines. In summary, remaining clinical questions should be solved by clinical trials, and there are some questions which are still open from Matterhorn trial. One is with regard to the subgroup analysis, looking especially at diffuse type of cancer, which is increasing, at least in the Western Hemisphere, and also node negative disease, which is about 50% of all our patients, because it seems that these patients do not have the same benefit compared to patients with an intestinally differentiated tumor and nodal positive tumor. However, these are small subgroups, and I would not draw any conclusion out of the subgroup analysis, but we have to think of this and look at maybe nodal negative patients in future trials do not need such an intense treatment, which is after surgery, another 4 cycles of FLOT, and 10 more cycles of durvalumab. Of course, this is the question which I'm getting most often asked, what is about adjuvant treatment? We know that only a majority of our patients can handle another 4 cycles of adjuvant FLOT durvalumab. Only 70% in the Matterhorn trial started with DFLOT, and only 50%, every second patient, could finish. And of course, we sometimes ask, do nodal negative patients with a better prognosis, or patients depending on the pathological regression grade, or patients who do not fully respond clinically in the CT staging and histopathology, really need this intense treatment. And of course, there have been some retrospective analysis, and they are all quite conflicting. I just want to highlight this retrospective analysis from the UK by Sugiyama, just recently published in Gastric Cancer. And I can really highlight this publication. It's really interesting to read. And this analysis shows that patients need to continue the FLOT regimen in the adjuvant setting because it clearly improves their prognosis. And he also could show that specifically nodal positive patients, from which we know that they have really a bad prognosis, do benefit from the continuation of FLOT treatment, as well as patients with a bad regression grade of TRG 5 or 4. So it is important to continue FLOT in the adjuvant setting. And latest, of course, what about our MSI tumors? I think MSI is the most important predictive and prognostic biomarker, and every patient, independent of stage, should be tested with a GI tumor. So does MSI high patients really need chemotherapy? And we learned from the metastatic setting that these patients have the highest chance to get cured with just immunotherapy, either with single checkpoint or also in combination with CTLA-4 therapy. And looking at the subgroup analysis from KEYNOTE-585 and Matterhorn, where the proportion of MSI high patients seemed a bit higher compared to metastatic disease, you can see that these patients really derive the highest benefit from immunotherapy. And there have been 2 small phase 2 trials from the French and the Italian colleagues showing that with an induction therapy of 3 months, nivo-ipi or durva-tremi, we can achieve path response rates by about 60%. And although this is not comparable to colorectal cancer, I think this is a huge advantage for these patients. However, there's no trial telling it that we can skip chemotherapy so far. This data published by my Italian friends and colleagues around Filippo Pietrantonio in the JCO last year shows that in this retrospective analysis, all patients who receive checkpoint with an MSI high tumor achieve around 60% of path response and have a clearly better prognosis compared to FLOT alone. So answering the questions, and I'm out of time already, the role of neoadjuvant radiochemotherapy is only dominant in squamous cell carcinoma and is no more standard of care for adenocarcinomas. With regard to postoperative immunotherapy, it's not effective in adenocarcinoma, according to my opinion. DFLOT is the new treatment standard as perioperative treatment independent of PD-L1 expression. And the role of immunotherapy in DMMR MSI high cancers, it is highly predictive, and we're waiting to get approval for immunotherapy in this special subgroup of patients because they have the highest chance to get cured. So of course, healing is a goal, and I think the better we get, it's getting increasingly realistic. And I'm skipping now all my conclusions because I'm running out of time, and thank you for your kind attention.
Thank you very much for a nice presentation. We're running late, so we try and stick to the time. My apologies. Now, it's my pleasure to invite Dr. Hassan Shayar, consultant medical oncologist, currently serving in American Hospital, Dubai. He's trained in US, he's American board certified, internal medicine, geriatric medicine, as well as medical oncology, Dr. Shariar. He'll be talking about advanced metastatic gastric cancer.
So thank you very much. I'd like to start by thanking the organizer for inviting me today, and such a pleasure to be here. So I'll be talking on the first line management of advanced gastric cancer, focusing on the biomarker approach. So starting with our collective understanding over the last 2 decades, we now understand that most of the gastric cancers are driven by some biomarker. It's almost about 80% of the tumors have some biomarker, and the remaining 20% may have some additional other biomarkers such as FGFR2 or CMET or EGFR. But the main or the clinically most relevant biomarkers that we know of today are the MMR, MSI high, as earlier alluded, HER2 amplification, PD-L1 expression, and Claudin 18.2. Luckily, most of these biomarkers can be detectable by IHC, and we have some very good data from Japan, which showed that there was a very good correlation between IHC and the whole transcriptomic sequencing. So it's reassuring to know that IHC is quite sufficient in many of these cases. There is overlap between the tyrosine kinases, but a lot of them are mutually exclusive. But in the patients who are negative for the receptor tyrosine kinase, there is a high expression of other biomarkers such as Claudin 18 and PD-L1. So in this graph here, it shows that there is some overlap of more than one biomarker in a lot of gastric cancer tumors. So we will start off with, I guess, the most consequential biomarker, which is the MMR and MSI status. It occurs in about 3 to 5% of the advanced gastric cancers, but in the localized, it can be higher, up to 6 to 10%. It tend to be more frequent in the older females and distal tumors, but not exclusively. And we usually test it by IHC. We also know that most of the MSI high tumors are driven by MLH1 promoter methylation, almost in about 90%, which leaves the remaining 10% from Lynch syndrome. And it is important we do genetic testing or molecular profiling in those tumors. So what does that lead to? So we have excellent outcome data from the immunotherapy. We have the Keynote trials, Keynote 061 and 062 in first and second line setting. And if you focus on the MSI high cohort, there was a clear separation of curves and quite an impressive benefit with pembrolizumab monotherapy. We saw similar impressive data with the nivolumab or Checkmate 649 trial, which used immunotherapy with chemotherapy compared to chemotherapy alone. And there was a clearly improvement in the overall survival with the immunotherapy plus chemo. Also, we saw that in the study, the dual IOs, Nivo and Ipi, versus chemotherapy also led to a significant improvement in response rates and overall survival. And that is a very important key data when we're considering these tumors. But there are some other, I think, still unanswered questions. Do we need chemotherapy with all the tumors with IO? I think if you look at the data from the Keynote studies and also the pooled analysis, the addition of chemotherapy to immunotherapy leads to improvement in PFS, but not necessarily improvement in overall survival. So that begs the question that there are maybe some patients in which immunotherapy alone might be sufficient, but right now we don't have the immunotherapy as a monotherapy license in the first line setting. And we also believe that patients who have a poor prognosis, like those with ascites, bone mets, or PS2, they should have chemotherapy added to the immunotherapy. So that's the current standard at the moment. How about TMB, the tumor mutation burden? So there is, I think, good data to show that a higher TMB leads to more predictive response from immunotherapy. We also have a meta-analysis which suggested that patients with a higher TMB tend to do better or respond better with immunotherapy. But at this time, it is only as a predictive tool, not as a selection tool in selecting patients for immunotherapy. What about dual IO? So as earlier, we saw that there is a higher objective response rate and overall survival with the dual IOs. But unlike the colon cancer data, we have not seen
a lot of data in the upper GI setting, and I think we like to see more data with the dual IOs in this setting as well. So next, I think important biomarker is the HER2 amplification. It runs in about 10 to 25%, especially in the Asian population, and tends to be more common in the junctional tumors, but it is equally present in the distal tumors as well. It has association with a high PD-L1 expression, and we'll talk more about that in a minute. But first, I also want to highlight the heterogeneity we see in the HER2, and it's important we understand this. We can divide the heterogeneity into spatial heterogeneity, where there's intratumoral differences and also differences between the primary and the metastatic sites, but then also a temporal heterogeneity, where you can have a loss of HER2 expression after prior exposure to anti-HER2 therapy. So that's very critical that we have adequate viable biopsy specimen. Some would argue up to 6 to 8 for the biomarker testing to be adequate. So repeat biopsy if few biopsies are available, and especially when you're re-challenging in the second line. So I wouldn't go into all the history behind the data we have for HER2 targeting, but the current standard of care at this time is the Keynote 811, which combined immunotherapy, pembrolizumab, with trastuzumab and chemotherapy compared to trastuzumab plus chemotherapy. It led to a clear improvement in the overall survival and the PFS and objective response rates. Overall survival was improved by about 4.4 months in the PD-L1 positive subgroup. And the final analysis of this was presented in 2024 ESMO, where again you saw that sustenance of the overall survival and PFS benefit. But important to note that in the PD-L1 negative population, we actually saw detriment, or the experimental arm didn't do as well as the standard of care. So currently we only restrict immunotherapy with anti-HER2 therapy in the PD-L1 positive setting. But a few weeks ago, we also saw some new and very promising data presented at the GI ASCO. So this has to do with the new bispecific anti-HER2 antibody zanidatamab. We have seen earlier phase 2 data, which was quite impressive. In terms of mechanism of action, it binds to the 2 domains on the HER2 receptor and leads to clustering of the receptor, which generates a stronger immune response. So this has then led to the phase 3 trial, which was presented, Horizon GEA-01 study. So this was a global phase 3 trial with 3 arms. It had the control arm of trastuzumab plus chemotherapy. The first experimental arm was just zanidatamab plus chemotherapy, and the third experimental arm had zanidatamab plus anti-PD-1 tislelizumab plus chemotherapy. So it was a 1-to-1 randomization. There were dual primary endpoints of PFS and overall survival, and other key secondary endpoints. All the patients in this trial, they required prophylaxis with antidiarrheal medications on the zanidatamab containing arms. So this was a patient disposition. More than 900 patients were randomized, and there was a median follow-up of more than 2 years. The primary endpoint of PFS as per BICR is shown here. So it showed a statistically significant and clinically meaningful improvement in PFS with zanidatamab plus chemo versus trastuzumab plus chemo, showing a more than 4-month prolongation in the median PFS, about 12.4 months versus 8.1 months, with a very significant hazard ratio of 0.65. Also, the PFS in the triplet arm of zanidatamab plus tislelizumab plus chemo also showed statistically significant improvement with the hazard ratio of 0.63. And the dual primary endpoint of overall survival in the zanidatamab plus chemotherapy was trending favorably towards overall survival, although not yet reached a significance at this interim analysis. A median OS of about 24.4 months versus 19.2 months. But when you look at the triplet arm of zanidatamab plus tislelizumab plus chemotherapy, you actually saw clinical and statistical significance in the overall survival benefit. So 26.4 months versus 19.2 months, translating to about more than 7-month improvement in the median OS. This type of improvement in OS has not been seen before, so it's quite impressive results and would likely present a new standard of care. In the pre-specified subgroup analysis, so just a cursory look will tell you that all the subgroups seem to be benefiting with the zanidatamab plus tislelizumab containing arm, irrespective of the PD-L1 status and HER2 3+ or 2+-ish positive. So it's also important to look at the toxicity profile. So there were some important toxicities noted with the zanidatamab containing arm. So most importantly being the diarrhea, which was the most common treatment-related adverse event occurring in about 82% of the patients, with the grade 3 or 4 shown here in the graph. And the rest of the toxicities were as shown here in this bar chart. So just to summarize the Horizon data, so there are several strands. This is a large global randomized study. It has a dual primary endpoint of overall survival, which was met for the triplet, and benefit was seen across all PD-L1 subgroups. However, there are important limitations. There was no direct comparison with the standard of care, which is the Keynote 811 regimen, and the study was not stratified by the PD-L1 status. And we are still waiting for the overall survival is still trending at the interim analysis in the Zani plus chemo arm. Our next target after a patient has negative for MMR and HER2 is Claudin 18.2. So it's a tight junction protein expressed in the normal and malignant cells, and it becomes more exposed as the cells go malignant transformation. So we have two pivotal phase 3 trials which have shown efficacy of zolbetuximab, which is a monoclonal antibody against Claudin 18.2 in advanced gastric cancer. Just quickly to talk about the prevalence and the cut point. So we define Claudin positivity based on 75% or higher staining. So that accounts for about 40% of the patient population. And the other thing important about Claudin 18 is there is a lot of overlap with other biomarkers, which also raises the question of co-inhibition strategies in the clinical trial. So for example, there is about 15% HER2 co-positivity with Claudin 18.2, and also about 17% CPS of 5 or higher PD-L1 in Claudin 18.2 positive tumors. And there are trials which are evaluating dual co-inhibition strategies. So just in summary, these are the two pivotal trials, Spotlight and Glow. Both trials are done very similarly, with the exception that the chemotherapy backbone was FOLFOX in the Spotlight, and it was CAPOX in the Glow. Both led to the improvement in the PFS, which was the primary endpoint, and the OS, which was a secondary endpoint. However, I would add that the magnitude of benefit was relatively modest. OS improvement was about 2 to 3 months, and PFS improvement was about 2 months. And the objective response rates were actually quite comparable with the placebo or chemotherapy containing arm. This was a pooled analysis published in the NEJM, which showed that the long-term overall survival data, so at about 4 years, you have about 15% overall survival, which actually is quite comparable with what we saw in the Checkmate 649 at 4-year OS. So some of the toxicities are also quite important to note for zolbetuximab. The principal ones are nausea and vomiting, and the infusion reactions as well. So especially in the first few cycles, first 2 or 3 cycles, we see a lot of patients developing nausea and vomiting. Thus, it is critical to use a maximum nausea vomiting prophylaxis with triple or quadruplet containing antiemetics, and maybe slowing down the infusion rate. I also want to just quickly talk about the phase 2 data of Illustro trial, which was presented earlier in the GI ASCO. So this is the trial which combines immunotherapy with zolbetuximab with chemotherapy backbone. So this was the natural, I think, progression of our treatment strategy. So looking at combining, targeting 2 biomarkers together. So this is the response rates that you can see. So The curves in the blue, sorry, the bars in the blue are the ones who had a high Claudin 18 expression defined by more than 75% and CPS more than 1. So these are the group of patients who seem to be benefiting the most. But if you look at this CPS positive group and high Claudin, the PFS was around 23.61, which is quite impressive. So there's a lot in coming. We have other combinations as well with pembrolizumab coming. We have ADCs and CAR-T therapies coming soon. So this is my last slide here. So I think this is sort of a summary of the treatment algorithm. I think the MMR high and the HER2 positive tumors are relatively straightforward in their pathway, but I think complexity comes when we have CPS positive and Claudin 18 positive. So I think in this diagram, it nicely shows that if you have a CPS negative or a low CPS, meaning 1 to 5, then we tend to use zolbetuximab with chemotherapy. But if you have a CPS of 5 or higher, then we go with immunotherapy plus chemotherapy as a frontline strategies. And I think some of these new trials will hopefully resolve some of these controversies soon. So I want to just thank you very much. And I also want to share this moment to invite everyone to another GI oncology conference happening here on the 25th of April with some of the experts joining us. So please do come. Thank you very much.
Thank you, Doctor. It's my pleasure now to invite Dr. Hussam Marashi, a consultant oncologist in Tuam Hospital, trained in UK, worked there and then moved to the UAE with more than 15 years of experience in the field with special interest in breast and GI oncology. Dr. Hussam will give us a case presentation and talk about advanced gastric and gastroesophageal junction tumors.
Thank you so much, Mr. Chairman. I'm going to do it in a different way. My disclosure will be, I don't have new data. I think my two colleagues present a beautiful deal of data so far. And I need your opinion with this case, because I think, you'll see what I mean. So, as I said, I'm based in the UAE now for 3 years now. So moving from the UK, I have a busy GI practice at the time, mostly breast, but I have a GI. And I thought things done differently. These are my disclosures, and it's not affecting what I'm going to present today. So we have beautiful data put together, presented with the early and metastatic. So I'll put something in between. This lady is 55. She's a very pleasant lady. She presented just, I'd say, 10 months ago with symptoms, looks like nausea, some vomiting, and lost some weight. But in general, she looks well. She's got hypertension. Nothing else is remarkable. In terms of investigation, a little bit of anemia, and she does the upper GI endoscopy. And of course, that's not, I'm afraid this is not the patient view, but she had a lesion sitting between 39 to 44 centimeters. So far, so good. Her, in terms of molecular biology, what comes from the biopsy at the time is that we're dealing with mismatch repair proficient. HER2 is negative on FISH, P53 is mutant, and PDL1, what they describe as around 3%. So you can think about that. And there's pylori on the top of that and the rest of the stomach. So the CT scan is what unremarkable. I'm not trained to do PET scan on stomach cancer. I don't put much weight on them because I know 20% will not even detect the cancer. Having said that, there's only update, as you can see, just very subtle, but it seemed to be in the cardia area, that's all. So what we do next, usually routinely, we refer them for laparoscopy. That's from what's been done. And from laparoscopy is that, I don't know if this projects well or not, but the surgeon reports white nodules sitting in the peritoneum. We used to have more, I would say, comprehensive system in assessing the peritoneal nodules, but they say they're 4 in total, they're small, they're tiny-ish, and they give 4 different areas. And the washing, thankfully, is negative. So at that point, I will need, with the permission of the chairman, just by the raise of hands. Now, we're talking about the MDT, so We got peritoneal carcinoma index is not, I cannot calculate it for this patient, but we talk about T3 and low burden peritoneal, just raised by hand. In your MDT, who think this is, who we push for surgery and treat as the early pathway, and who will push for the metastatic? So we'll start with who think this is genuinely metastatic disease and surgery do not have a role. I only have one hand from Dr. Shiblak at the back. Metastatic, 1, 2, 3. So the rest, do you think we have action for surgery here or not? Just to see where I'm going to push in terms of to deflot and the new adjuvant. Who think there is? So so unfortunately in UAE, I'm not able to push our surgeon to go full PCI, but that's, they look down and there's only 4 nodules. So let's say I give it the score of 4, it's not 39. So not metastatic, and he's chosen the early pathway. Okay, so, okay, good. So just we know, I think kindly, and you presented, these patients were not included in the Matterhorn, my understanding, and they were not included in the FLOT, the first FLOT 4, they're not included. So let's see what happened to this patient, and I need opinion from all of us, and I'm aware of the timing, so I'm not going to overtime the timing. So that's what happened in terms of the MDT. They said, of course, we always be vague in this patient. I've got mix of opinion already. Some people said, push for systemic treatment and refer back to the MDT. For me, you see, that was just before Matterhorn, really, we were able to access it. To me, I said, well, fair enough. I will push with the FLOTs. That's the best I have. And I'll give this patient 4 cycles of FLOTs. And that signal in terms of this localized area seemed to be switched off. So in terms of radiological assessment, seemed to be better. And the treatment was tolerated well. Having said that, the patient had 1 admission with nausea and vomiting. And the surgery, so the surgeon met after the initial, and they said they're happy to take the surgery and they will do exploratory into the peritoneum and they will go for cytoreductive surgery. HIPEC was not chosen here. And then she have R0, YPT2, YPN1, 1 out of 19, small just area, and there's a lot of fibrosis with peritoneal nodules. Now, the patient just recovering from surgery, her opted not to have more chemotherapy despite my significant attempt to say you are a high risk and you need the treatment, you need stuff. So that's where I'm going to take myself, spend a few minutes on the background of peritoneum. If we think about all the gastric cancer, I think this is our nightmare, peritoneum, because in no time, this is the patient's not going to do that well. I'm thinking about maybe more the advanced cases. They come with ascites, they need maybe repeated drainage. You will have maybe think about permanent ports, I don't know, to clear the fluid. And unfortunately, the data we have, they say that they do much worse. It's just a miserable way of dying, unfortunately. They will need NG tube, they need NGI maybe tube, they maybe need, the nutrition is bad. And there's no way you can tell someone not doing well. You have to keep the line for nutrition for a long time. So nutrition is a very challenge. And I don't have time to talk about that. Biology is different as well. So what data do we have particularly about the peritoneal group of gastric cancer? This has taken, the number of slides taken from the ESMO preceptorship that just done recently, ESMO programs, and I can see that the Dutch has published a long-term cohort from the 1999 to 2017. You can say a lot has changed over that time, but that's what we have. And unfortunately, you can see on the data, the PFS, all the overall survivor is abysmal based on old data we have. And the pathophysiology, I think that's explained easily by the nature of this peritoneal nodules. I just showed you the white nodule, because they're not blood-borne metastases. They're simply just cells shredding into the peritoneal tumor and causing all the trouble. And I know maybe that's more a drama, that's more significant peritoneum lesions sitting in that area. But that's what we have really. If this is how important to do this. And I can understand, you know, I don't know what's the really, how accurate is the peritoneal washing, how specific or how sensitive they are. But usually if it's positive, it's a poor prognostic feature. And of course, with that, made us move away from traditional. That's the PCI you just talked about. And it's a good scoring system. Unfortunately, I don't have it in my center. I don't know who routinely does it in their center. I know there's only one search, but anyone see this in the MDT? I have one, yes, yeah? No? I've got no? So all the dedicated surgeons seem to be, and Dr. Ghazal, of course, you will okay. So what I'm trying to say is that we don't study that well, and it's not fully, I don't know if that in Germany is fully now taken on about how serious we take small lung nodules. I'm not going to spend a long time on things, but what we have, whether we have systemic treatment here to deal with it, and that's Dr. Shahriyar presentation, he spent 20 minutes nicely about it, or we have attempts from our surgical colleague to try to say, no, I will take it as early and I will take it full on. But if I want to, because of course the surgeon will say, well, this is the historical data and it's not that impressive in terms of these peritoneal disease, because if let it go with systemic treatment, the overall survival is not that good. So that will justify doing a lot of things. So what are these lot of things surgically that our surgical colleagues try to convince us? You've got the cytoreductive surgery and intraperitoneal, all type of different aspects in terms of HIPEC and cytoreductive surgery, which means the surgeon will open up after deflot, remove these nodules, assess properly, and then if they have the HIPEC machine, they'll switch it on and treat with a HIPEC. So what's the data? Well, unfortunately, we don't have level A data to prove it. Small attempts. So no one better than the German group. They came along and said, we will do it in a randomized trial, in this trial, the gastric PEC. And the first year data analysis, unfortunately, didn't work. And they said there's not enough patients to be included to justify it. So they said, we will follow it for 3 years. We'll follow, and it seemed to be there is a trend that some patients will do better. Of course, some patients will do better because they already selected who did well at the first step. But that's not enough to move into move it. And they will say, we'll move into more data into this study, that periscope, that will be maybe we'll do a little bit better. Unfortunately, this study doing HIPEC, cytoreductive surgery for my patient, I'm just going to go short. Here, there was some futile activities. So unfortunately, this is not a small, easy surgery. There was some mortality. I'm trying to build the case around biology. So that's what I'm trying to build on. That's not the only thing that our surgeon will do. We can do catheter, we can put a drain here, and we can put intraperitoneal chemotherapy. We'll choose paclitaxel because not absorbed. It doesn't cause adhesions, so maybe paclitaxel is better. And despite having an early good results and early small, against very small cohorts, seem to be, again, there's not enough to push into the guidelines. The Chinese did more numbers, of course, and seem to be a little bit some signal here. And you can see if you look at it, the overall survival 19 months versus 14, statistically not significant. So that was enough to be presented orally in ASCO GI last year. And that's not the only technology. We have the pressurized intraperitoneal chemotherapy, and seem to be there's more logic behind it because they can put the pressure higher, and we are learning, So what I'm trying to say is that we have, for this patient now, I'm still trying to look into the surgical data. I'm not sure which one I'm going to choose because I don't think the cytoreductive surgery alone, what we've done to this patient, is going to determine if her survival is going to do a lot of things and she have to recover from surgery. So I went back to see what our current data, the 649, Dr. Shahriyar, I think quite convincing for all group, for ITT. I couldn't, there are some patients have peritoneal be reported and be included in 649. Unfortunately, in the forest plots, they didn't specify what happened to these patients' peritoneal disease because I'm sure they will have done worse. And I said, well, if Nivo is not there, sure will be something on the Keynote 859 and the same story. There is no detailed analysis to it. There's little bits now on I think that just in ESMO Asia. Unfortunately, I didn't go to ESMO Asia or ASCO GI, but that's the only group possibly focused on peritoneal thing. And I know I do apologize. There's a lot of data on this in this line, but at least now some people give us more data about the peritoneal, and this came in a poster, seemed to be is the only biological aspect that targeting and showing still the activity is still there. And I would say, what I'm going to say, I think to try put things together for this lady is from the start, are we able to better target anatomy or are we better to target biology? So the game for this lady is still not over, and we need the help from a lot of research, and still there's no dedicated sessions for I would say from the GI group, but we need something like targeting biology really well. From what Dr. Shahrar has put is that this is the lustro and it's only phase 2, it's not licensed, not approved, and not marketed, but we need combination of targeting with immunocheckpoints to come, because that's the first time I think for all groups to come to say PFS. I think that the most impressive to me, I didn't go to ASCO GI, but I think Professor Hamed put it and in his summary, and I think that the highlight to me from ASCO GI is that finally PFS in metastatic gastric coming of 23 point something months. Well, the story for that lady unfortunately is not that great, and she had now abdominal distension in December, just a month ago, and the peritoneal disease has moved on. And on that, I hope I'll just generate a lot of questions. I've got 27 seconds, so I did well with timing, I hope. Thank you so much.
Thank you, Dr. Hussam. Thank you very much. It's a pleasure now to present, I was going to say our guy, Dr. Mohammed Umara, senior staff oncologist at Dubai Hospital, assistant professor of oncology at MBRU. And he will be talking about cholangiocarcinoma management updates and a case presentation.
Thank you so much, sir. Thanks, Dr. Ali, for the nice introduction, and thanks for all the attendees for your valuable presence. This makes a success for our first PMOC conference, and I'm pleased and honored to be part of this meeting today. We are still in the context of the GI cancers, and my role is to talk about the biliary tract carcinoma, so we'll move to a different part of the GI, focusing on the first line management of advanced metastatic biliary tract carcinoma. I was asked to try to shorten my time, so I will try to move fast in the presentation. So in general, the biliary tract carcinoma represent around 3% of all the GI cancers, and in USA in 2023, more than 20,000 cases were newly diagnosed with biliary tract carcinoma, and more than 10,000 deaths related to biliary tract carcinoma in that year. We are all aware about the classification of the biliary tract tumors, including gallbladder cancer or intrahepatic cholangiocarcinoma, which arise from the intrahepatic biliary radicals, or extrahepatic biliary radical tumors, which could be peripheral, arising from the hepatic duct confluence, or distal extrahepatic biliary radicals arising from the distal common bile duct. The most common type of biliary tract cancer is the peripheral extrahepatic cholangiocarcinoma, 50 to 60%, and followed by the distal extrahepatic cholangiocarcinoma, 20 to 30%, and intrahepatic cholangiocarcinoma represent around 10 to 20%. This is again the types of cholangiocarcinoma. The intrahepatic cholangiocarcinoma, as mentioned, arise from the intrahepatic biliary radicals, and the usual presentation is as liver mass. This is the area where you have lots of actionable mutation and targeted therapies approved. The most common key molecular alterations are the IDH1 and 2, FGFR2 mutation, as well as other non-actionable mutation, BAP1 and ARID1A. The peripheral extrahepatic cholangiocarcinoma, as mentioned, arise from the hepatic duct confluence and usually present as obstructive jaundice. The key molecular alteration, KRAS and TP53. The distal extrahepatic cholangiocarcinoma arise from the distal common bile duct and again present with obstructive jaundice. The key molecular alteration are KRAS, TP53, and SMAD4. And finally, the gallbladder cancer, which arises from the gallbladder fundus, body or neck. Usually it is incidental finding, and it is characterized by high amplification of HER2. Percentage of that is around 10 to 20% of cases, and other key molecular alterations are the TP53 and the PIK3 kinase. So briefly, this is an overview. Most of the patients present in advanced stage and they don't have the chance to get the curative treatment. The pathogenesis is always multifactorial, including the gallstones, which present around 70 to 90% of cases. However, the mechanisms that lead to the biliary tract carcinoma related to the gallstones is still not well understood. Other risk factors include the gallbladder polyps, primary sclerosing cholangitis, chronic infections like H. pylori, salmonella, congenital biliary cysts, and other factors like hormonal replacement therapy in postmenopausal women, smoking, alcoholism, and obesity. We are all aware about the poor prognosis of hepatobiliary carcinoma, and this is a 5-year survival rate for biliary tract carcinoma. As you can see, the 5-year survival overall is around 10%. When we look at the localized stage gallbladder, so when we look at the localized stage gallbladder cancer, the 5-year survival is 66%, while it is 24% for intrahepatic cholangiocarcinoma, 17% for extrahepatic cholangiocarcinoma. If there is regional involvement, this 5-year survival dropped to 28% for gallbladder cancer, 16% for extrahepatic cholangiocarcinoma, and 9% for intrahepatic cholangiocarcinoma. And unfortunately, as we can see, once the patient is having advanced or metastatic biliary tract carcinoma, this 5-year survival dramatically dropped to 2%, regardless the origin or the site of the biliary tract cancer. Surgical resection remains the main treatment option for localized biliary tract carcinoma to have a real chance for cure if the patient is having localized stage, followed by adjuvant capecitabine chemotherapy or concurrent chemoradiotherapy in some selected cases like R1 or lymph node positive disease. And once the patient is having metastatic biliary tract cancers, options include chemoimmunotherapy, and second-line options including immunotherapy and targeted therapy. We are going to see this in details in the coming few slides. This slide is important and is showing us the evolvement of data in the biliary tract cancer management since the last 15 years, starting from 2010. When the gemcitabine was established as a standard of care management in biliary tract carcinoma. And after 7 years, pembrolizumab came in the scene, but only for the second-line options for MSI high tumors in the basket trials. 2019 in Japan only, they added the S1, which is like 5-fluorouracil, to the gemcitabine, and of course with significant toxicity. In 2020, another second-line option came, which is bemigatinib for FGFR2 mutant cholangiocarcinoma. In 2021, other options again for the second-line management for biliary tract carcinoma, including infigratinib for FGFR2 mutation and ivosidenib for IDH1 mutant cholangiocarcinoma. And FOLFOX was established as a second-line treatment option for patients with biliary tract carcinoma and anti-HER2 medications for HER2-positive biliary tract cancers. Finally, in 2022, and after 12 years from the standard of care of gemcitabine, immunotherapy was added to the gemcitabine. In the TOPAZ-1 trial, durvalumab was approved to be added to gemcitabine, and in the same year, another options like fotopatinib for FGFR2 mutant cholangiocarcinoma and dabrafenib tramatinib for BRAF V600E mutant biliary tract tumors. One more year, in 2023, pembrolizumab was approved again in addition to gemcitabine after the approval of the Keynote 966 trial. So our focus during the coming slides will be mainly focusing on the first-line management options. The previous landscape and evolvement of data shaped our treatment algorithm for patients with biliary tract cancer. This is the ESMO guidelines. And again, as mentioned, for early stage disease, main treatment is surgery followed by adjuvant chemotherapy. For advanced or metastatic disease, concurrent chemoimmunotherapy, gemcitabine with durvalumab or with pembrolizumab, and if regional involvement and patient responded, he can go for surgery. Otherwise, if a patient progressed, we can go for standard second-line options, including chemotherapy for all comers, or actionable or targeted therapy according to the actionable mutation, including IDH1, FGFR2, HER2, or MSI, and so on. This is the NCCN guidelines, and again, it is the same like the ESMO guidelines, and the preferred options are the combination chemoimmunotherapy, pembrolizumab plus gemcitabine, and the durvalumab plus gemcitabine. And again, second line options include targeted therapy for if there is any actionable mutation, or chemotherapy if there is nothing. So we'll start focusing on the first approved trial for combination of chemoimmunotherapy, the TOPAZ-1 trial. TOPAZ-1 trial is a double-blinded, multi-center global phase 3 study. Recruited patients with locally advanced or metastatic biliary tract carcinoma, no previous treatment in this setting, or have recurrent disease after 6 months from the curative surgery, with reasonable performance status COG 0 to 1. The trial recruited 685 patients who were equally randomized between both arms. The first arm to receive durvalumab 1500 milligram every 3 weeks, in addition to gemcitabine day 1, day 8 for 8 cycles, followed by maintenance durvalumab, and the control arm was placebo plus gemcitabine, followed by maintenance placebo. The primary endpoint was overall survival and multiple secondary endpoints, including progression-free survival, objective response rate, duration of response, and safety. These were the baseline characteristics of the TOPAZ-1 trial, and as you can see, it was well balanced between both arms, including age, sex, ethnic origin, and the most important, the origin of the biliary tract cancer, intrahepatic cholangiocarcinoma, majority around 56% in both arms, extrahepatic cholangiocarcinoma around 20%, gallbladder cancer 24-25%, and patient had metastatic disease majority and localized disease around 11% in both arms. The most important as well was PD-L1 expression. So around 60% of patients were having PD-L1 1% or more in both arms, and PD-L1 was negative in around 30% in both arms. This is overall survival data for the TOPAZ-1 trial. This is actually the updated data at 3 years cut-off time, and we can see that the median overall survival was
Dr.
improved.
Mara, 5 minutes.
Okay. Okay. So median overall survival improved from 11 to 12.9 months with hazard ratio 7.4. Actually, when we look at the next slide, we can see here again the overall survival data, which was improved in 12 months, 24 months. However, at that time, the data cut off, the hazard ratio was 0.8, but when the extended data after 3 years, the hazard ratio improved to 0.74. This is the subgroup analysis, and all the subgroups have benefited from adding durvalumab to chemotherapy. This is one of the secondary endpoints, the progression-free survival, and there was improvement of the progression-free survival, median progression-free survival improved from 5.7 to 7.2 months. And this is the objective response rate, which again improved from 18.7% to 26.7%. Adverse events were similar between both arms. However, the addition of immune therapy had immune-related adverse events. But it is important to say that most of the adverse events were grade 1 to 2, grade 3 to 4 adverse events were very minimal, around 2.4%. The second trial is the Keynote 966 trial, and again, very similar inclusion criteria. The trial recruited 1,069 patients, which were randomized equally between both arms. The first arm to receive pembrolizumab every 3 weeks plus gemcitabine. The control arm here, this is a difference actually. The trial, after maximum 8 cycles of gemcitabine, to continue maintenance with pembrolizumab plus gemcitabine for maximum 35 cycles of pembrolizumab and unlimited cycles of gemcitabine. And this was a control arm, but placebo instead of the pembrolizumab. Again, the primary endpoint was the progression-free survival. The baseline characteristics were well balanced between the both arms. And this is the overall survival data. And as you can see, there is statistically significant improvement of the overall survival with hazard ratio 0.83 at 2 years time data cutoff. The overall survival benefit was seen across all the subgroups regarding age, sex, ethnic origin, site of primary disease, or PD-L1 expression. Actually, progression-free survival showed some numerical improvement, but it was not statistically significant. This was one of the secondary endpoints, as well as the objective response rate was similar between both arms. But please remember that in this trial, the Keynote 966, the control arm patients were receiving chemotherapy. The case presentation just to get short of the time. I will just present one case quickly. This is a 59 years old Chinese national female patient diagnosed in July 25 with metastatic gallbladder cholangiocarcinoma with liver and peritoneal and lymph node mets. Presented to private hospital and did MRI was showing gallbladder mass likely malignant and multiple liver deposits, peritoneal nodules as well. So she went to Rashid Hospital to continue further management. Biopsy was taken and confirmed cholangiocarcinoma with focal hepatoid differentiation. Her CA 19-9 baseline was 504, and this was her baseline PET scan. She was having hilar lymphadenopathy as well. So this patient was started on the Keynote 966 protocol. Actually, and received pembrolizumab plus gemcitabine cisplatin. She had fair tolerance to treatment. CA 19-9 started to drop gradually from 500 to 100 until it came 82 in November 25. This is the first response assessment scan after 4 cycles. This is the baseline, and this is after 4 cycles. We can see significant response actually, and disappearance of most of the hepatic focal lesion. Only one hepatic focal lesion was there, sorry. And even the hilar lymphadenopathy also disappeared. So the patient continued on the same treatment. She received actually 7 cycles so far, and even started 2 days back, cycle 8, day 1. And she had fair tolerance. Actually, the CA 19-9 normalized. If you remember, it was 500 something, and now it is 32. And we are planning to do response assessment, PET scan, and MRI after completion of 8 cycles. I presented this case not because we are preferring the Keynote protocol over the Topaz one, but just to open the door for discussion in presence of Dr. Ali for the possibility, as this case is a potential case for surgery. And thanks so much for your care. Thank you.
Thank you very much. I will start the panel discussion. It's my pleasure now to invite Dr. Nawal Al-Nahdi, consultant gastroenterologist and hepatologist from Rashid Hospital, Dubai Health. She's a liver transplant specialist, chair of a scientific committee of the Emirates Oncology Society and Hepatology Society. It's my pleasure also to invite Dr. Amir Mohammed Rabi, a specialist general surgeon from Rashid Hospital, Dubai Health. He's also an important member of our MDT. I'd also like to invite all our speakers to please come to the stage so that we'll start the panel discussion.
Thank you very much. I got interested in the peritoneal disease. So I'll start asking Dr. Amir, and then probably Hussam can jump in, about the role of diagnostic laparoscopy in gastric cancer. It's so routine, but can we actually omit it in some cases?
So the diagnostic laparoscopy, yes, it is a routine practice, especially in locally advanced tumor. Or what is locally advanced tumor, which is the tumor T2 and above, like T2, T3, T4. And in node positive disease, in a disease which with the unfavorable biology, and anatomically in proximal disease and GE junction. So this is actually the routine, but now we are like decreasing the indication in T2 disease which is localized, sometimes disease with favorable biology, we can omit and we can go for upfront surgery. Yes, we are decreasing nowadays, but still this is not the standard. Still we are doing enriched in most of the locally advanced disease, we are doing diagnostic laparoscopy. Why we are doing this? Because like in 25% of cases, which is diagnosed as locally advanced, after doing the diagnostic laparoscopy, it's increased or the upstage to metastatic when we find peritoneal disease or positive cytology.
If we go back to the case that Dr. Hussam presented, where we have few whitish spots, would you go back and check again with a diagnostic laparoscopy after the neoadjuvant therapy was given? Or
for such, I answered Dr. Hussam that anyway, it is still not the the standard treatment, and we have to take the treatment like tailored for each patient. For this, if this is the only disease that we have seen intraperitoneal, me as a surgeon, Dr. Ali, we like to cut. So I'll do the radical surgery or the upfront surgery if this is the only disease. But your question, to go back again, yes. If we give neoadjuvant chemotherapy for intent to cure or do curative surgery, yeah, we have to do again the diagnostic laparoscopy before going, because the disease may progress or the disease may be resistant, or you may find another surprise before doing the surgery.
Hussam wants to say something.
So thank you. Now, I put this case because genuinely we need help. I struggle with the bits that the surgeon thinks we will say, we will repeat or reassess. So my case, when I put back to the MDT, they said, rather than repeat laparoscopy, we'll just take it to theater, we will operate, and we will inspect the peritoneum and see what happened. But I said, if she have a good response, it's good to focus on the biology, continue with the treatment, because she's doing well. So that the bit I don't know what to do. For my case, unfortunately, we lost the adjuvant plots for her because she have ideas after surgery not feeling well. So she said, I don't want the systemic treatment. And I'm worried that will make her lose on the systemic options. And I put the data because the inclusion criteria, I'm very conservative, and I do understand that surgery is good. But my feeling in this patient, for all these type of patients, is that it should still be experimental from type of surgery. And we should not push this type of patient to say, push them for operation. And I think what Dr. Shariar, based on the data, is to me, seem to be, if you get the biology right, you get better outcome. But I'm open suggestion. I don't know what you do in your MDT. What you did last Monday on your MDT, how things are different in Germany and in the state, I don't know.
We are quite similar to what you do. I mean, this was a 58-year woman, so pretty young. And if there are only 4 regional lesions, I think we would go for a perioperative approach and then just explore and resect the peritoneum. I think what we more and more try and also now evaluate in clinical trials is a so-called TNT concept, meaning to put in this, especially in this systemic disease, and it is a systemic disease, more chemotherapy up front. That's what we learned from rectal cancer. So 4 cycles is not enough, especially this patient refused adjuvant treatment. I think she needs more systemic treatment. So in this case, we would try to give her 6 to 8 cycles, deflot, in the neoadjuvant, potentially neoadjuvant setting, and then achieve the maximum response and then do the resection, as long as she is not progressive clinically and in the staging. And the role of HIPEC, I really doubt.
The German group, when they put the data I put, they went for PCI less than 7, so that means low burden, and still failed to show us that targeting this patient with surgery has.
Was the Periscope that were the Netherlands,
Yes.
which has been recently presented at ESMO last year, but the German group, they had more higher PC rates, 20, 25. So these were more advanced tumors in the trial, the GastroPEC trial. What we now do is the PREVENT trial. We look at patients who are in the laparoscopy negative, and then we randomize in diffuse mixed type in resection plus minus HIPEC. But it's just experimental.
So if I understand you both, that you actually don't believe in HIPEC and gastric cancer. You don't see a role for HIPEC and gastric cancer. As
I
of
mean,
now.
of course, in this case, we would do it with HIPEC. We think 6 and less PCI index, there might be a role. But I think the prognosis of these patients is super poor. These are mostly diffuse Singer ring type cancers. They are super aggressive, mostly triple or quadruple negative in biomarkers. If you talk to the pathologist and do a rebiopsy of these peritoneal lesions, they barely have PD-L1 expression. Even if the primary has a high CPS, those peritoneal lesions, they do not have any lymph node involvement. So they are very barely PD-L1 positive. So also the systemic options are very little.
If we take this case further, not this if I say that, okay, there is no gross peritoneal disease, but there's a positive cytology only. You still don't believe in HIPEC in these cases?
We would do HIPEC, of course.
You would do HIPEC and
Yes.
positive cytology.
Yes.
Would you do that in Tawam?
No, we're just starting to do the HIPEC surgery, so it's new to us, and our surgeon understandably very excited, and we are also looking to have our own data to look into this. I know there's the conversion study going on as well, and they try to do it without the research governance. But as you said, they have no. The problem is I don't have much systemic options, so I can't say no to them because anything hopefully will make it a better outcome. But for me, as I said, I'm very conservative. This case has took a long, long time in our MDT to decide what is better, what is the best thing for her. And I don't think our ASCO GI they're not focusing on this type of group because I think this certainly worth more research. But,
just one thing I want to add. I think the management of oligometastatic disease in the upper GI tumors is not as well established as we have in colon cancer, for example, where we have much higher quality of data. So this is sort of a gray area, and I think at the end of the day, you just have to make a case-by-case decision, knowing that we don't have a high-quality evidence. With the HIPEC, I always feel that we have faith in it when we are offering curative intent treatment, but whenever we look at the data, it comes out not as appealing.
If we move on the discussion, yeah, thank you very much. I think very important comments. Can never end this discussion, I guess. Let's talk about how the perioperative therapy is changing now. So the FDA approval, NCCN guidelines, EMA, we are awaiting. So we have 2 trials showing that PD-L1 positive patients drive more benefit in this setting, but a trial that you presented, most patients are benefiting. So with the approval that we have only currently for CPS more than 1, what should we do in clinic Monday? How do you see that? Are you giving to all your patients DFLOT, or would you select it? Yeah.
Yeah, I got it. Well, I think the Matterhorn trial are really convincing. It's the largest trial. It's a prospective global trial. And I think we do it already. We asked with the FDA label, it's much easier now to get it reimbursed. So we give every patient the DFLOT regimen. Of course, I have some doubts. I have the doubt in diffuse type of cancer. I have the doubt in nodal negative patients. And of course, I also doubt the role of giving these patients for 1 additional year an immune therapy, where we don't know if patients with a low CPS or TAP score really do benefit and really do need this immunotherapy, or is this just economic toxicity. However, there will not be any trial, but what we also learned now from ASCO GI, from the Chinese Neo Summit trial, where event-free and overall survival data were presented, that with the addition of checkpoint inhibition, and this was toripalimab in this case, another confirmatory trial, also patients with no PD-L1 expression did benefit from the addition of immunotherapy. So I think it's another confirmation that PD-L1 expression is not necessarily important to give immunotherapy in these patients, and you don't need to test. So at the moment, according to the guidelines, we do not test, except for MSI, on other biomarkers in the locally advanced setting. I hope this will change in the future when there will be hopefully a global phase 3 trial with anti-HER2 directed therapies, because this is another big issue. But for the moment, I think DFLOT is the best perioperative treatment for everyone, with some question marks.
You showed us the data about how radiotherapy is now lagging behind. So, but still there are some, MDTs who still talk about radiotherapy neoadjuvant. So where do you see neoadjuvant radiotherapy in your treatment paradigm now for patient with operable junctional tumor, for example, if you said?
Sorry, the radiotherapy?
Pre-op radiotherapy, the role of pre-op radiotherapy
well,
now.
I think at the moment there is no role for radiochemotherapy. I'm sorry for all the radio-oncologists in the room. Not for the G-junction tumors, as well as for specifically gastric cancers. I think Top Gear showed us that there is no place for gastric cancer. I like the neighbors from the Netherlands a lot, and I also appreciate their effort to do the Critics 2 trial, which they presented at ASCO GI. But I think this is a very small trial, and with a lot of question marks for the addition of radiochemotherapy to neoadjuvant chemotherapy. And I don't think that this small exploratory Critics 2 trial is important enough to give radiotherapy in gastric cancer, especially not in diffuse type. So I think now in the era of immunotherapy, and this was not addressed in the Critics trial, I think there is no role for radiochemotherapy at the moment.
Thank you.
With critics.
I think we have to distinguish between G-junction and gastric cancer, and I don't see any role for radiotherapy in gastric cancer. And Top Gear, as well as Critics, were mostly gastric cancer and very little cardiac cancer. For the more proximal tumors, I think the more proximal you go, the more important radiotherapy gets, like for squamous cell. So talking about G-junction type 1, I think it could be an option. And therefore, we had the RAISE trial in Germany with radiochemotherapy plus induction chemotherapy, but unfortunately no immunotherapy. But I think there is a role, and there will come some more trials from squamous cell carcinoma with radiochemo plus immunotherapy, the Kunlun trial, for instance, the Keynote trial with Pembro, where we learn a lot from the addition of immuno to definitive and neoadjuvant radiochemotherapy. And I think there might be also a role for adenocarcinoma.
I would completely agree. I'm a clinical oncologist, my training, so I did a lot of radiotherapy to the GO junction at the time and was a big believer in cross. I think when we had disease, the T3 and 0 in the past, and you would think maybe it's T4 coming into tumor involving maybe the cross or the diaphragm, the surgeon might want something to reduce it quite quickly, and the cross was a good answer for that, followed by 577 for those who don't achieve. So I think the story was a little bit in between, go cross. When we have the new ages study that the UK and Ireland invested heavily in it, unfortunately was affected by Corona. But I think after DFLOT, I think now we have access to the immunotherapy and you have that tail and better outcomes. So no-brainer, if you have a drug and approach that better for systemic relapses with DFLOT, I think might be more superior to cross approach in a way.
Yeah, I totally agree. So I'm a clinical oncologist as well, but I'm afraid I think radiotherapy is no longer, because we see distant metastasis in these patients, not local recurrence majority of the times.
And if you have someone borderline, I don't know how you're going to say you're going to find out a patient, but if you have someone borderline fit for DFLOT and you want things to move quickly, chemoradiotherapy is very well tolerated. So it might be an alternative, but not as a standard for everyone. If you believe there is a patient will tolerate surgery without the chemo. Let's talk a little bit about cholangiocarcinoma, Dr. Nawal. Uh, how do you deal with this demand from histologists to have more and more tissue samples in your endoscopic sampling? I mean, how do you get enough for them? Is there new technologies now coming up?
So
Or it's the way you take it?
it is the way we take, but more it is the tumor nature in where we take. It is not the cholangiocarcinoma, especially in the biliary system main duct, the main bile ducts where we are actually working mostly to obtain, and the most difficult ones. It's not mucosal disease, it's more of submucosal, more deeper. So what we see always when we go, we see the normal mucosa with abnormal capillaries. And always our acquisition of the tissue will not be very deep. So to improve our techniques to obtain a tissue, because the majority of the ones we repeat, it's the one in the main CBD, the common bile duct, and the main ducts. The other ones, we have different modalities. The ones in the CBD and the main ducts, we ideally prefer to have an anatomical evaluation prior to the procedure with MRI to make more of the time concentrated on the lesion we see during the procedure. Regular ERCP would be of a benefit only when we use the cholangioscopy, which we are tending to do more as a routine in any malignant structure, to go with the cholangioscope and see the lesion directly. The mucosal changes would depend on the regular white light to see the pattern of the mucosa and the capillary distribution, which can tell us in what is the area that are very suspicious for malignancy, and we obtain a direct biopsy. Obtaining direct biopsy, we try to take more biopsies. With these techniques, we are getting better results from the histology, but the problem, we're still getting atypical tissue, atypical cells, atypical tissue. So the fresh cytology we don't depend on anymore. We depend mostly on the biopsies. We have better results, but we're still facing the histological view, which we understand it's because the tumor itself is not superficially, unless it's really advanced and it has a mass-like factor. When it is a nodule, which is not very common, the nodule is easy because we remove it as a polyp and we send the tissue itself. There is a new technologies, the probe-directed laser confocal, which can actually look at the mucosa directly, and it will give us the appearance of the cells. And by the distribution of the chromatin, we can say which cells has high level of chromatin, looks more malignant, and which one normal and maybe inflammatory rather than cancer. This one is not in the region yet, but it is coming. And it has very good positive predictive value and negative predictive value. It will improve the diagnostic yield to sensitivity of 95, specificity of 75%. So this one, it can be done through the cholangioscope, which will improve the outcome. Also the cytology, which we sent now, as in Cleveland, they got the sequencing, the advanced, the new generation sequencing for the cells. It can tell you this is cancer cells or this is just regular cell or inflammatory cell. Now it came to Cleveland. Hopefully we getting that part in our facilities nowadays. There is also a new technique, it will take time before it comes, which is EOS directed inside the duct. So still very extremely few centers, actually operators who has it, and they are still practicing on it to place EOS to see what is in the mucosa and what's in the wall of the bile duct itself, to be able to give more diagnostic feature as we do in other parts of the GI system, and to obtain better biopsy. The fine needle biopsy, it is the same, but usually you don't have a problem when you have a mass. You have a problem because of the duct localized tumor.
Thank you very much. I think we're running out of time. There's so many questions to be asked from and Dr. Hassan Ghazal, I think, is probably ready for one last question if we can take. I have a full list of questions, but I think we can't do it
Just
today.
a couple of comments. I think it's important pathology for peritoneal disease. If you have signet cell tumor, usually we don't recommend even thinking about HIPEC. The other point about PD-L1 in neoadjuvant therapy, we have learned from different tumor types that when you are giving chemotherapy plus immunotherapy, PD-L1 should not be a deciding factor. We saw it in breast cancer and we saw it in the GI now as well. It's something to do when you're giving chemotherapy. These PD-L1 are very dynamic. So what you already have on the biopsy may be different when you are giving chemotherapy. You have PD-L1 over expression, modulation of that as well. So I would definitely not depend on PD-L1 to give or not to give immunotherapy. The other question, one question I had for Dr. Shahriyar, is zanidatamab ready for prime time if you have it available? Is this going to be your standard? And would you give Pembro zanidatamab for that matter?
Can I just interrupt before he said PD-L1 is not important? We have rejection from the insurance company because they're looking to NCCN guidelines and they will not allow us to use it. So we have to go back. Pathologist said, can you push the CPS score any point? So pathologist said, oh yes, CPS is not like black and white. It's all gray. So you said it's not important, but in
I'm saying
real life
scientifically,
they want us to follow NCCN guidelines, which is specified the 1%.
So just very quickly, I personally feel zanidatamab is a superior molecule than trastuzumab. I think mechanistically speaking and the efficacy we see, it comes with a little bit of toxicity, of course, with diarrhea. But if I have it available today, I would, I think, use it. Whether I combine it with Pembro or Nivo, I don't know. I think both trials will eventually read out. But I think the field will hopefully continue to evolve and we'll see more ADCs and other agents as well. We have other two big phase 3 trials ongoing with TDXT and other things. So this space is going to get very crowded soon.
Maybe last question from Dr. Mara before we wrap up. You nicely presented the data for the first line setting. But the question is, once you have a tissue available, you have all the biomarkers available. And what do you do and how do you sequence your therapies once they progress on immunochemotherapy, cholangiocarcinomas?
Thanks so much, Dr. Hamad, for the question. As we saw in the data, the standard of care is the first line combination chemoimmunotherapy, and all the guidelines recommend even upfront NGS sequencing to be ready for the second line option. If there is actionable mutation, the golden rule here, especially in cholangiocarcinoma, to go for the targeted therapy. If there is no, then the option will be 5FU-based chemotherapy. The options for targeted mutations in biliary tract carcinoma includes IDH1 mutant, ivosibimab, and FGFR inhibitors, including fotopotinib and pemigatinib. Fotopotinib is the preferred option because it is irreversible FGFR 1, 2, 3, and 4 inhibitor, while the pemigatinib is the less preferred option, less progression-free survival. Progression-free survival is our aim here in the metastatic setting to improve. And for example, for FGFR mutations, the median PFS is 9 months, while for pemigatinib it is 7 months. So this is a preferred option. And as long as we mentioned, the actionable mutation is there, we have to use it early. Otherwise, then it will be 5FU-based chemotherapy.
There is ongoing trials, many of them here. Actually, we will know if first line can be challenged. Right now, I agree it's still chemoimmunotherapy, but we have ongoing trial in first line target therapy.
Maybe soon in the future, we can see the targeted options in the earlier lines, yes.
With this, we'll conclude our session. It was amazing. Thank you very much for all your contribution. So we'll now move on to the lower GI session.
So we can go for the lower GI session, which is, I think, is the most important session this day. The first speaker will be Dr. Hassan Ghazal. He's a well-known consultant medical oncologist and hematology with more than 30 years experience, trained in US, and he was served as a director of Kentucky Cancer Clinic. So we welcome Dr. Ghazal on stage.
Assalamu alaikum. Thank you very much for the invitation. I was told by Dr. Hamad personally that I cannot refuse to talk about rectal cancer. It's a special subject dear to my heart, as well as many of you know. So we had gone a long way in treating rectal cancer. It's too strong. Anyway. So what I thought we'll do quickly is not to forget about MSI high population, because this is really a prototype in oncology, in the science of oncology and the use of checkpoint inhibitors. And then we'll discuss in the MSS population, the long talks of short course versus long course, and what happened if we choose watchful waiting after clinical CR. The last point about ctDNA, I was told Dr. Shamsi is going to talk a special talk about that, so I may shrink that at the end, just in the interest of time. So as you all know, colorectal cancer is becoming an epidemic globally, not only in our area, but this data from our area in UAE. As you can see in men, we are now #1 in colorectal cancer. And if you look at mortality, it is the #1 in men and #2 in women in UAE. And actually, there was just a publication yesterday globally in people less than 50 years of age. The #1 killer, if you want, is now colorectal cancer. So it surpassed other cancers as the #1 cause of death in people less than 50 years of age, including lung cancer. This is the first time ever something is challenging death rate from lung cancer. So it's unfortunate statistics, but this is what we have. And that's why I think UAE is one of probably the only country that lowered the screening age to 40 years of age, which I totally agree with. And every day we talk to patients about screening for colorectal cancer. And we know many reasons why this rise is happening. We talk about lifestyle, we talk about microbiome, diet, lifestyle, etc., obesity, all these really factors culminating. It's a complex subject, but really culminating in very high rate of young age colorectal cancer. Just last week, I saw a 23-year-old from Bangladesh with rectal cancer. So this is real. We are getting younger and younger, unfortunately. We have to rewrite the books in colorectal cancer. Again, as you may know, with any other cancer, we know more about molecular biology of these tumors. We can see the KRAS still represent the largest portion of colorectal cancer mutations. Then we have a little bit of NRAS, BRAF, HER2, MSI high, etc., and TMB. So as I mentioned, in the MSI high or deficient MMR population, this is really a unique situation. We rarely see in oncology 100% complete response rate and 100% PFS rate at 3, 4, and now 5 years follow-up. This really started from many centers, but first at Memorial Sloan Kettering, Dr. Sersek, the famous data that was presented initially. Then, of course, Dr. Shalaby followed with many trials in both the rectal as well as in the colon cancer population. This is the famous June 5th, 2022 presentation where we saw 100% complete response rate, no radiation, no chemotherapy, no surgery if you are MSI high. So I think since then, the first thing we do with any rectal case is hurry up and ask for MMR staining. It's an IHC stain you can get in 24 hours, and you can tell your patient if you can just get by with immunotherapy. This is the famous New England Journal publication at the time, which really made a huge impact. And it was on CNN and other big advertisement section, sort of. Basically, dostarlimab was the drug that was used at that time, and it was given for 6 months. And if you have complete response, you really follow non-operative approach, and you follow up your patients at least for the first 5 years. However, the first 3 years are the most critical, as we will see from the pattern of recurrence. And you can see here excellent results, and you can see the swimmer's plot continuing of responses. And this is the latest update from 2025. Again, you can see that all patients who achieved complete response or near complete response continue to have or enjoy a complete response situation. Again, no surgery, no chemotherapy, no radiation. The take-home points that this is certainly ready for prime time, and we're already applying it. And there are other situations being tested, the POL-E or other mutations or hypermutation or TMB more than 50. All these populations that we know respond well, very well to immune-based therapy. And the other questions arising now: what do we do with stage 1? What do we do with the combination nivo-ipi, since we have that in metastatic setting as even better than single agent? So all these questions are still there. And then, does PCR transform to cure? So far, with the follow-up near 5 years, the answer is certainly a yes. The AZUR-1 trial, again, this is locally advanced rectal cancer, looking for treatment, again, with dostarlimab for 6 months, then assessment if you have residual disease to proceed with the standard of care, chemotherapy plus radiation plus minus surgery. And the option, if you achieve complete response, goes to, again, watchful waiting and continuation of follow-up for these patients. And if you have a complete response, again, you follow these patients, as mentioned here, every 4 months for the first 2 years, and then every 6 months till year 5. Okay, this is some of the initial pictures that were shown, again, with remarkable recovery by endoscopic, by MRI, by whatever modality you want to look at, PET scan, these remarkable case presentations and from the memorial group. So other situation is niche studies, again, by Dr. Shalabi here. Again, this is more in the rectal cancer, but more also in the colon cancer, was proof of principle that you could give a combination therapy, nivo-ipi followed by nivo and then surgery, and follow tissue and plasma-based testing for complete responses, as well with DNA analysis. So that's still ongoing. So let's talk about the MSS. So in the MSS group, which is the majority, unfortunately, 95% are not going to be MSI high, and we have to deal with what we have. So if you all recall, along the time of COVID-19, where patients will be reluctant to make visits to the hospitals, the so-called Rapido trial was presented before that time, and the short course radiation therapy really took off, what we call 5x5. You finish in 5 days, and you received afterwards chemotherapy, so what we call total neoadjuvant therapy, followed by surgery. Versus the standard arm was the chemoradiation that we normally used to do, followed by surgery, followed by adjuvant chemotherapy. One notice here about the Rapido itself, you look at the complete pathological response, you see doubling. So 14% with the standard approach versus 28% complete response if you follow the Rapido trial. And then a treatment failure or recurrence, you can see also some decreased numbers there, 24 versus 30%. This is the Rapido. On the other side, quickly, I put the Prodige 23, which gave basically induction chemotherapy with FOLFIRINOX, 3 months, 6 cycles, and then followed by chemoradiation, versus starting with chemoradiation surgery for all group, and followed by adjuvant chemotherapy. And again, we have the complete response, 27% versus 11%. If you compare that to this side, again, we have 28% on the Rapido. So pretty close numbers. Again, different patient population across trial, just looking at quickly the percent of CR. And this is just was published at the Lancet in terms of comparison of the total neoadjuvant therapy, followed again, but this time all had surgery at the time. Again, more sort of classification of these two regimens that are being used. Now, all these regimens had surgery already embedded in it, so there was no discussion about organ preservation. All these studies had surgery embedded in it, and this is from the Rapido trial in terms of CRT group versus the total neoadjuvant therapy and the disease-free interval survival. And you can see some improvement. Now, one important, and this is recently published, that why we think short course may be important still, although many of us may not be using it anymore, that it was less immunosuppressive than the long course, despite more advanced disease. And that may improve the faster lymphocyte recovery, lower NLR ratio, as we know about these sort of markers of immune reactivation. So perhaps short course had some advantage immunologically speaking. Now, excuse me. What's important about the Protege 23 was the outcome and survival, and PFS was, DFS was the primary endpoint. But when we look at survival, actually, there was a 5% difference in overall survival, 81.9 versus 76 with a p-value of 0.033, as opposed to the Rapido trial, which did not seem to show a survival advantage. Now, one criticism of, if you want, for Protege 23, that we did not have an arm of FOLFOX alone versus FOLFIRINOX. And this trial, Janice is trying to answer that question by giving the chemoradiotherapy, followed by FOLFOX versus FOLFIRINOX, again, to see the primary endpoint is the responses. Because we took for granted that irinotecan is going to add something here, although it's not in a randomized fashion, it has not been studied fully. So that's one of the criticisms, whether we're over-treating with chemotherapy. Not to forget, another strategy is, do we need radiation for everybody? So this trial prospect study was published at ASCO initially, again, trying to eliminate radiation therapy. So what they did here, they gave FOLFOX 6 cycles first as a neoadjuvant therapy. And again, the inclusion, you can see T2N plus, T3N minus, or T3N plus. And the bottom line, if you respond to, after restaging, after FOLFOX times 6, if you have more than 20%, you can see the response, you go for surgery. Less than 20%, you go for chemoradiotherapy followed by surgery. And what they showed in this subgroup, that those patients who proceeded with surgery and then just given adjuvant chemotherapy, in over 95% plus, they were able to, the very low events, by the way, but you can see 98.4, 98.2. So really, there was a huge percentage of patients, the majority of patients, avoided any radiation therapy. So when we think of de-escalation, do we think of de-escalating radiation or de-escalation of chemotherapy or of surgery, of course, the main question. This is a quick comparison of the 3 trial, Rapido, Protege in the middle, and Prospect. And what importantly, and was criticized afterwards for Rapido, is the local relapse rate. If you can see the local relapse rate, 12% versus 8% at 5 years. So that was one of the negative things that really kind of decreased the enthusiasm of short course therapy. As you can see, the rates, correspondent rate in the local relapse, 8% versus 5% with the Protege trial. Now, however, one important thing to keep in mind that if you look at the Rapido population, they have much more T4 lesions, much more locally advanced disease. So it's not a completely fair comparison across trial to say, well, this is 5, this is 12, although the 8 versus 12 does make us wonder whether there were some higher local recurrence with the short course of radiation. And you can see the survival, 81 versus 80. So certainly there was no detriment. In fact, numerically, still better 5-year overall survival. And you can see the corresponding Prodige, which had the approval now based on the survival advantage. And Prospect trial on the other side, again, the choice in Prospect trial, they excluded T4 lesions. So locally, really, truly locally advanced disease will not be a candidate for the Prospect trial. So what happened to after neoadjuvant therapy, whether you gave the short course or long course, or now you have a complete response?
Time, please.
Yeah, we're finished. So after neoadjuvant therapy, what do we do with these patients? Now, first of all, we have the OPERA trial, obviously, that looked at organ preservation. So we looked first, question optimal sequence, consolidation, chemoradiation, achieved a really superior 3-year organ preservation rate. You can see 54% were able to have organ preservation versus only 9% for induction. Safety, it is a safe approach. Watchful waiting did not have any negative outcome in terms of survival. And certainly regrowth management. People who have regrowth of their tumor, they could easily be salvaged with mesorectal excision without compromising any survival. And the 5-year follow-up confirmed that organ preservation is sustainable for half of these patients, maintaining disease-free survival equivalent to those with immediate surgery. Key points, you see different responses. Certainly, the fact you have a complete response put you in a category with a good biology. The fact you did not achieve a complete response, that also speak about the biology of the disease. And then those who did not achieve a complete response, we have beside the discussion about the biology of their disease, what we know about these tumors that they can easily be salvaged with surgical excision and did not compromise their survival outcome. This is a PI from Memorial Sloan Kettering. He is a surgeon, by the way, but he's the biggest opponent of organ preservation, Dr. Kholio. And he really believes highly if you are achieving a complete response, you should have the option of going into a watchful waiting approach without compromising any negative impact in terms of survival or distant recurrence. In fact, as I will show you, only 9% develop distant metastasis if you have complete response. In contrast, for those who went for surgery after initial induction therapy, experience 26% distant metastasis. So in fact, if you look at the distant metastasis, again, proof of principle, if you do respond to your induction treatment, you have much lower rate of distant metastasis, irrespective whether you had surgery or not. So the fact you did not have surgery and you went to WW, watchful waiting, did not increase your risk of metastasis. So, but tumor response obviously is gonna be the key factor here. Now, can we do something else if you did not achieve complete response? This is where we have still ongoing trial about more radiation therapy, introduction of more immunocheckpoint blockade in this MSS disease. We have many, already 3 or 4 trials that showing there may be benefit of adding immunotherapy in this case as well. And again, salvage surgery may not need to be always mesorectal excision. Local excision for minimal tumor can be possibly done without compromising survival. What do we do with watchful waiting? MRI every 3 months, the first 3 years, endoscopy every 3 months, the first 3 years, then every 6 months thereafter. ctDNA, if approved, if possible. I think Dr. Humaid will talk more about it. I had few slides, but in the interest of time, I will leave that for Dr. Humaid. And then not to forget CT scan or PET CT scan every 6 months for these high-risk patients for the first 3 years. And I think I will stop here and let Dr. Humaid later talk about DNA. Thank you very much.
Thank you, Dr. Hassan. Thank you.
Thank you, Dr. Ghazal. So our next speaker is Dr. Fathi Azaribi. He's a senior medical oncologist in American Hospital of Dubai. He has completed his training in UK. He has long experience of working in UK as well as in UAE. So he will talk about hepatocellular carcinoma treatment landscape from algorithm to the action.
Assalamu alaikum, good afternoon. Thanks for the organizing committee, my friends and colleagues in Dubai Hospital, US, and thanks, Chairman. So my talk will be at a different organ now, HCC, which is another fascinating area, lots of advances, and I will talk you through in the next 15 minutes. So firstly, it's an important global health burden, more than 905,000 cases estimated in 2020. Unfortunately, more than 800,000 died. So this is a very high mortality cancer. And what's alarming that the incidence is increasing in younger population, and by 2040, it's expected to increase by 54%. It's a global disease everywhere, every country, but it's more common in Far East Asia, Japan and China, in Egypt also, west of Africa, and in the United States. Now in UAE, maybe it's not as relevant. It's ranking number 14 as per GlobalCan data with ASR of less than 5%. So it's still there, but it's not in the top list anyway. Now, it's very important to know that HCC has a unique staging system. It's called Barcelona Clinic staging system. And we have 5, which is from 0 to D. However, there is a variation in staging globally, and this is linked to the differences in survival. So for example, in Japan, most of the majority present in early stages, 0 or A, while in Europe and America, the majority are C or D. And you can see on the right-hand side, the one-year survival rate is decimal actually for the stage D, but it's nearly 50% alive if you catch this disease early enough in stage B. Treatment, it's one of the examples, very good examples where you need really very good multidisciplinary team. You need good surgeons, not only the ordinary surgeons, but the transplant surgeons, and you need radiation oncologists, interventional radiologists, medical oncologists, and so on. Transplantation is the treatment of choice because this is actually 2 diseases in one disease. So you have the liver failure or liver cirrhosis, and on top of that, you have the HCC. So the transplant within certain criteria is the best treatment. But if you have a good liver function, non-cirrhotic, resection is also a good option for small tumors. However, we see more in the local regional or the multiple or large tumors, although they are liver confined, but they are not suitable for surgical options. And then we move to local therapy, and we have so many wide variety. Maybe HCC is the most common tumor where we use the local ablative therapies like RFA, microwave ablation, SIRT, TACE, SBRT, and name it. However, as a medical oncologist, I'll talk more about medical therapy or drugs. We have 2 major groups or classes. We have the TKIs. We have a long list, as you can see. Sorafenib was the first one, but then we have lymphatinib, regorafenib, ramucirumab, and name it, so many of them. And then we have the immunotherapy drugs, which I'll show you the clinical trials about these. So this is the historical. Until 2007, practically speaking, we had nothing. There was nothing working. We were giving doxorubicin to the patient just to give them nausea and vomiting and hair loss, but we know it didn't work and didn't improve anything. But then with the sorafenib, the door was opened wide that there are actually drugs which can change, and that's what the first drug ever shown to improve the overall survival in SHARP trial. It took 10 years to develop more drugs, so it was very slow. And then regorafenib, nivolumab, and then the base or the speed of the development go faster with multiple new drugs. Almost every year, as you can see in the slide, we have new drugs, and now we have the immunotherapy combinations also. The newest one and the newest kid in the block is Nivo-Epi, which was approved last year, but it started with atezolizumab in 2020 and Durvalumab in 2022. I think everybody is familiar with SHARP trial. Anybody has ever treated HCC, this trial is always mentioned and presented millions of times. It showed that there is significant improvement in overall survival by 3 months, and that also applies for the Asian patients as per Asia Pacific trial. So that was the standard, and it remained the standard and the comparative arm in the immunotherapy trials even up to today. Now, then REFLECT trial showed that lymphatinib is another active drug, although there was no improvement in overall survival, but definitely it's more active drug. It gives you higher response rate and better progression-free survival. So that's important point to keep in mind, especially now when we go for the comparative arms in the immunotherapy trials. Now, if I sit in the clinic tomorrow, I think the first question comes to my mind, is this patient suitable for immunotherapy or not? And if it is not, then I will go back to the old friends, which is sorafenib and lymphatinib, but most likely I'm going to use some sort of immunotherapy. Combination is the best option, and we have 3 valid. I can't say one is better than the one, but you can make your own judgment according to the data, which I will show you. And or even if you can't use the combination, single agent is also is a good idea, whether durvalumab or tislelizumab. So let me move to the combination. EMBRAVE 150 was the landmark trial which showed that immunotherapy can actually improve overall survival compared with sorafenib. And in this trial, they compare it to they combine atezolizumab with bevacizumab, as you know, and the primary endpoint, actually co-primary endpoint, was overall survival and BFS. More than 500 patients randomized 2-to-1. These patients need to have endoscopy because of the risk of bleeding, but otherwise they need to be Child-Pugh A, good performances, the usual criteria for clinical trials. So the trial was positive, very significant improvement actually in overall survival, early separation of the curves, 6 months the delta or the difference in the overall median overall survival, and statistically significant hazard ratio. Safety-wise, I must say that it is fairly safe combination if you exclude the bleeding risk. So if you already had endoscopy, no bleeding, no varices, then you can rest assured that the combination is good. And if you look into the serious side effects, I mean, as expected, 2 drugs will be slightly 23% if you look into the treatment-related, compared to 16% in sorafenib. The discontinuation rate, however, is low at 10%, one of the lowest. If you go into Himalaya trial, which is another concept of combining anti-PD-L1 with anti-CTLA-4, and actually a very interesting idea. It's only 1 dose, they call it STRIDE regimen, and that's based on some phase 1 and 2 data. It's a 3-arm, much larger trial, more than 1,000 patient comparison 1-1-1, STRIDE, which is durvalumab or durvalumab monotherapy or sorafenib. The primary endpoint was overall survival. There's significant improvement in overall survival in the durvalumab versus sorafenib. However, the durvalumab, although numerically is better than the sorafenib, but didn't reach the statistical endpoint. There is no difference in BFS in these 3 arms. Again, safety-wise, as you would expect, combining 2 drugs will give you a little bit more side effects, 17% versus 8% for durvalumab. For durvalumab and 9.4% for sorafenib. If you look into the combination, relatively low. If anything, it's actually lower than the sorafenib, 8% versus 11%. And durvalumab is one of the most tolerated drugs ever in this combination of drugs or in this cocktail of drugs you're going to see. And then we move to the most exciting or the most recent, to be honest, the CheckMate 9W study, because now we're moving to Nivo-Epi. We have good experience of this combination, other cancer sites like lung, renal, and so on. And Dr. Hassan just mentioned also in the neoadjuvant rectal cancer. Nivo 1 milligram, Epi 3 milligram, which is kind of a little bit more, the more toxic combination. Usually we like the 3 milligram and 1 milligram, but the good news that's only for 4 cycles. And then you can sail with Nivo and rest assured, then you will not even notice that the patient is having treatment. Versus lymphatinib or sorafenib. Now I must stress here that 85% of patients has lymphatinib, which is more powerful than sorafenib. To be fair, when you look into the trials, You should keep this in mind. The primary endpoint is overall survival. The trial was positive, as everybody knows. There was a bit of concern and noise about these crossing over of the curves, but there was a publication in Lancet if people want to go through it, and it's explained that probably it is not really directly related to the immunotherapy. Nevertheless, the trial was positive. The primary endpoint, the overall survival significantly improved and clinically meaningful and statistically significant. And more intriguing, more interesting, the objective response rate is one of the highest ever been in HCC, 36% with 7% complete response versus only 13% in the lymphatinib, which is higher than the sorafenib. So I found this particularly amazing. And based on these data, this combination was approved both in Europe and America. Now, treatment-related adverse events, as expected, Nivo, Epi will give you higher immune-related side effects, but the usual stuff, thyroiditis, pruritus, diarrhea, a bit of increase in liver enzymes, which we are very familiar how to handle it. And if you look into comparing with other trials, probably a little bit higher incidence of side effects, but this is more immunotherapy related and maybe numerically higher, but we know it's more hypothyroid and pruritus, which is not really serious. Okay, now this is one slide about very interesting trial, and this is a Chinese trial. And why it is interesting, because they combined immunotherapy with the TKI, camrelizumab plus rifaxitinib, which is actually I think, abatinib, the other name. And it showed that there is improvement in survival and very clear separation, very significant, actually 8 months, which is one of the best ever overall survival. And the BFS is also improved in contrast to other trials which failed to show improvement in BFS. However, the toxicity is much higher, 80% when you combine immunotherapy with TKI. But it looks like the TKI is the problem because most of it is hypertension, PPI, and increased enzymes. But the discontinuation rate is not very different from the other trials. It's about 17%, and it works in both viral and non-viral etiology. There's another trial, which is tislelizumab, which is non-inferiority. It showed that this immunotherapy is non-inferior to sorafenib. So if you are looking for immunotherapy treatment and you don't think that the patient is fit for the combination, this is also a good option. Very straightforward trial, more than 600 patients, 1-to-1, and it shows that there is no difference, and that's exactly what the trial wants to prove. And based on this, this drug is actually now in the guidelines. Now, for us in this part of the world, I think these are the 3 trials which are relevant for us. This slide doesn't mean to compare trials, but just to give you a flavor or an idea and to show you that when it comes, the 3 trials were positive. They met the primary endpoint, and they are in the guidelines. But if you look at the median overall survival, I cannot hide that the checkmate had the highest 2 years median overall survival. I know it's not wise, or it's not actually permitted, or it's a sin to compare in this way, but at the end of the day, this is something I have to look at. The objective response rate is the highest, 36%, and the median duration of response is 30%. And there were data presented at ASCO GI this month. We are still in January, yes. And it showed that those who achieve complete and partial response, they do amazingly much better than who did not achieve. And the 4 years data, again and again and again, as we have seen with this combination and other trials, emphasizes that those who go to that tail of the curve, I'm coming to the end. Guidelines reflecting exactly what I said so far. Atezo, BEF, and durvalumab is category 1. I don't know why they put Nivo, Epi in the other recommended regimens, along with durva, limva, sorafenib, and tislelizumab, but it is there, and it can be used according to NCCN guidelines. The ESMO guidelines is not very different. They put everything on the same box if they are eligible for immunotherapy, but they give higher category for atezo-bev, durvalumab, and also they gave high category for durvalumab monotherapy and tislelizumab. I don't know, because they also take into account the side effects and everything. But at the end of the day, everything is in that box. Whatever you want to pick is suitable. It depends what the patient you have. And with this exactly on 3 seconds left, I would say thank you very much. Questions later on. Thank you.
So we can invite the next speaker, please, Dr. Al-Murtada. He's a consultant medical oncologist with a special interest in gastrointestinal malignancy. Please.
Thank you so much for the kind introduction. Thanks for the invitation to speak to Dr. Farouk and Dr. Said. So today I'll talk about locally advanced pancreatic cancer and put that in the context of case presentation, try to prompt your thoughts about what do we do. There isn't much high-level evidence as my colleagues previously presented, so it's an evolving area of investigation and further clinical trials to find the best suitable treatment for those patients. So this is a tough disease. I'm sure all my colleagues who treated pancreatic cancer, we haven't really made all that progress that we've seen in so many different other solid malignancy, like Dr. Fathi showed us in HCC and the rest of it. This remains one of the deadliest cancers, unfortunately, and more than 80% present with locally advanced or metastatic disease, and only 15 to 20% do present with local disease that is resectable. But even of those who do present with local disease, majority will relapse, and the cure rate, as you can see, is only 9%, and survival remain very dismal for those patients. This is a case study. So this is an imaginary case of 48 years old gentleman who had no significant past medical history. PS0, presented with 3 months typical symptoms of pancreatic cancer, weight loss, epigastric or upper abdominal pain radiating to the back. His baseline blood tests were satisfactory, and normal LFT, CA19-9-200. He had a CT chest abdo-pelvis, showed 4.2 centimeter mass in the head of the pancreas with 180 specifically, not more, not less than this. There is a rationale to put only 180 here. So it's 180%, 180 degree encasement of the celiac axis and no other vascular involvement, no distant metastasis. EUS and biopsy confirmed moderately differentiated pancreatic ductal adenocarcinoma, and he was staged at T4N1 and 0. So these are the treatment options I've placed here to think about and to prompt the presentation and the discussion. So do we attempt surgery anyway? Do we give neoadjuvant chemotherapy and then surgery? Or do we go with neoadjuvant chemo, then radiotherapy or chemoradiotherapy or SBRT, then resection? Or just do chemoradiotherapy or SBRT and then resection or OncoSeal? And this is where it becomes hopefully interesting. Because this is fairly a new option. So I think we debate resectability quite a lot in the MDTs for pancreatic cancer, and this is because there isn't any very fixed set rules of resectability that applies to all patients everywhere in all institutions, and that's why it's more of a spectrum. So there are definitely resectable, no vascular involvement, no metastatic disease, to something in between when there is 180-degree encasement or less, more, and when it becomes borderline resectable, and then we'll move to the unresectable when there is more than 180-degree encasement of the SMA celiac axis, to something a bit more definitely unresectable when there is involvement of the big vasculature like the aorta or the celiac trunk or the common hepatic artery, and to those who are metastatic disease. And that's the distribution of the presentation or the incidence of different stages of pancreatic cancer. Because we know surgical resection can be or is the only potentially curative treatment for those patients, but unfortunately not many get to have surgery. And 30 to 40%, which is the main purpose of this talk today is they do present with locally advanced or unresectable tumor. There is 50 to 20% they are upfront resectable, and there's 40% who are definitely not for surgery because of the metastatic disease. So we're talking about this 30 to 40% of patients who will be a candidate for surgical resection. And this is the NCCN criteria of resectability, which is more or less summarizing in a table of what I've said about the spectrum of resectability. There are things that, there are pancreatic cancer that are clearly resectable, free of the vessels, that's straightforward resectable, to something borderline resectable, depending on the degree of involvement of the arterial vasculature and the ability of reconstruct the venous vasculature, to something more locally advanced due to a higher degree of involvement of the vasculature. What are the options here? So we'll look into what's available for those patients. New adjuvant chemotherapy approach. There is a rationale to do this. Improve selection of patients. We give chemotherapy for 3 months, 2 months, 3 months, 4 months for those patients, and we test the biology. If they are not, if they do metastasize during this time, those patients might have not been a good surgical candidate in the first place. And it does, a neoadjuvant strategy, as I'm going to show you, it does increase the resection margin, or increases the R0 resection. And it's also help with early metastatic disease, because this is a systemic disease in most of patients. So I'll talk about FOLFIRINOX data. What do we have for a neoadjuvant chemotherapy? What do we have for FOLFIRINOX? We have the SPAC-5F clinical trial that looked into 4 or 3 rather neoadjuvant strategy: gemcitabine, capecitabine, FOLFIRINOX, and chemoradiotherapy with capecitabine in borderline resectable pancreatic cancer versus going ahead with surgery straight away. So this will give you the answer to the first option of the question about treatment option for our patient. So R0 resection was higher in the neoadjuvant strategy as a whole, 23% versus 15% R0 resection. 12 months overall survival was better in all neoadjuvant strategies, 77 versus 42%. And the highest 12 months survival rate was with FOLFIRINOX at 84%. And these are meta-analysis. As I said at the beginning, there aren't many high-level prospective phase 3 clinical trials that compare these modalities. So we rely on retrospective meta-analysis and small case studies. So one of these meta-analyses looked into patients who received neoadjuvant chemotherapy, followed by radiotherapy or no radiotherapy, and then resection. And they looked into the rate of resection, and there was some patients who converted to resectable, even if they are locally advanced. So 17.6% of them had a resection, 53% for borderline, and 70% for potentially resectable disease. And the margin negative resection was 55% of the locally advanced. So you can argue there is, out of the 18% locally advanced, there were 8% had a negative resection margin, despite deemed initially unresectable with the negative margin. And unsurprisingly, you can see quite clearly the higher or the more advanced stage, the worse survival, and vice versa. This is another meta-analysis, looked into 13 studies of FOLFIRINOX for locally advanced pancreatic cancer, and had concluded that around the patient who's undergoing resection between 0 and 43. So there is quite variable to the response and the degree of resectability following neoadjuvant chemotherapy. And unfortunately, we can't pinpoint or exactly know how much chemotherapy contributed, because 64% of those patients in the FOLFIRINOX had some radiotherapy. So how much radiotherapy has contributed to an increasing resectability? So, and I'm not going to dwell into that, because this is a whole different talk. But if we talk about FOLFIRINOX, is it FOLFIRINOX or modified FOLFIRINOX? That's a question. Moving to the other neoadjuvant, potential neoadjuvant systemic treatment, gemcitabine nab-paclitaxel. And this is the data from the metastatic setting, the IMPACT trial that has showed superior overall survival with gem Abraxane compared to gemcitabine. So we know response rate is better for those patients. And in real life, I intentionally wanted to say in real data, real world data, the response rate and survival are nearly similar to the FOLFIRINOX. So there is a rationale that these could be equal. And there is a small data from this study that looked into the perioperative treatment of resectable pancreatic cancer, head-to-head comparison of gemcitabine nab-paclitaxel versus modified FOLFIRINOX, and essentially showed a patient who is receiving perioperative treatment, they have a similar outcome, indicating these two agents might have similar efficacy and benefit or comparable in a way. And as you can see in this trial, the resection rate was similar for patients 73 versus 70%. These for 55 patients. The number is not massive, but it still gives you an idea that resection rate for both were similar. In fact, in this trial, complete or major pathological response was a bit higher with Abraxane versus modified FOLFIRINOX. So there is an argument that Abraxane is as good as FOLFIRINOX. And we can see from comparing the PRODIGE FOLFIRINOX trial to the nab-paclitaxel IMPACT trial, the response rate is actually comparable. So 29% to 32%, although we know the difference in survival and PFS. How about a different combination? We know gemcitabine, Abraxane, FOLFIRINOX. How about gemcitabine and something else, like platinum? It's not definitely superior. Gemcitabine cisplatin is not superior to gemcitabine alone, except in patient with BRCA or PALB2 mutation, or those with a strong family history of pancreatic, breast, or ovarian, because of the BRCAness possibility that they respond more to platinum. And there is also retrospective data and small studies indicating that those patients might benefit from gemcitabine cisplatin particularly. How about NALIRIFOX? I'm sure Surveyor will be surprised to see NALIRIFOX here, but this is a combination that showed some promise in the advanced setting. And in fact, if you look at the objective response rate is 41% compared to the 36%. And there isn't any complete responder, but it is a treatment option, and the data is very strong in the first line metastatic setting. And when it comes to toxicity, is a bit better compared to the FOLFIRINOX. This is not projecting well. This is supposed to talk about now. This is about chemoradiotherapy. So we moved from chemotherapy. We mentioned about what's available to us with regard to chemotherapy. When it comes to chemoradiotherapy, this title is supposed to talk about chemoradiotherapy now. So again, not much of phase 3 high-level data, but the LAP07 clinical trial looked into chemotherapy followed by chemoradiotherapy and then resection. And there was some trend toward improving PFS, but no overall survival. And there is another trial that's the CONCO 007, like James Bond 007. 500 patients received FOLFIRINOX for those patients, followed by randomization to have chemoradiotherapy or continue the same chemotherapy. Again, we've seen a better R0 resection, 69 to 50%, but that did not translate to PFS or survival benefit. So how about SBRT after chemotherapy? So SBRT, in fact, this one of the trial, the Alliance A021501 trial, there's a 126 patient borderline resectable randomized to have FOLFIRINOX for 8 cycle or 7 cycle FOLFIRINOX, followed by SBRT. And this trial was terminated prematurely because of futility. So patient who had just the FOLFIRINOX done better. And there isn't anything better than the NCCN in the way they phrase the difficulty and the lack of high-level data in these settings. There's limited evidence. This is from NCCN, limited evidence to recommend a specific regimen of study, and practice varies, which is exactly what happens in reality. You won't find two people agree about resectability, for example, and it does sometimes include neoadjuvant therapy, sometimes include neoadjuvant chemoradiotherapy, and they put at the end clinical trial is encouraged, which is I completely agree with. And these are the treatment options which I went through. ESMO, more or less the same treatment options. OncoSeal, this is something relatively new from 2022, is tried and piloted in a couple of centers in the UK, USA, and Australia. It's a single-use brachytherapy, and it's currently limited in a few centers, only piloted so far. 98% of the radiation is delivered within 81 days, which gives an absorbed dose equivalent to 100 gray. It's an implantable brachytherapy into the tumor in the pancreas. It's given normally after 4 cycles of chemotherapy. And these pilot and small data suggested that there is a better control rate. They measured it at 16 weeks, and there was a better resection rate compared to the historic and data of chemoradiotherapy and chemotherapy alone. And this can be an option for some patients. So my take-home messages is MDT is imperative in selecting best treatment option or options, and definition of resectability can vary. It does differ between different institutions and different between two different surgeons, unless it's very clear-cut. Optimal management of locally advanced pancreatic cancer is very controversial. There is no internationally embraced standard approach, so it has to be individualized. Most of the data are from historic data or the metastatic extrapolation from metastatic setting or small studies. All patients with locally advanced disease are encouraged to participate in clinical trials. Testing for germline, BRCA, and PALB2 mutation is, in my opinion, very important, and it can guide and change a treatment option for those patients. NGS can offer potential second treatment options for those patients. All option, in my opinion, I would like to emphasize on this point, all patients who does respond, don't have metastatic disease, should be explored, should be offered that option of surgical resection, because sometimes even if we don't see the huge shrinkage of the tumor, they can have fibrosis and they can actually have an R0 resection. The adjuvant treatment, that's a completely different topic. It will depend on what the patient received neoadjuvantly and what is their fitness like, what is their margin, and it is, again, has to be individualized. So now what are the treatment options for our patient? If you can still remember the story of our patient, I think the strongest data here is for neoadjuvant chemotherapy, and I would go with this option. And with that, I thank you so much for listening.
Thank you, Dr. Marquis. Thank you.
So now is the time for the next speaker. I would like to invite very well-known Professor Humaid Shamsi. He's well-known to everyone. He is the president of Emirates Oncology Society, and he has a very big salutation, very famous nationally as well as internationally. So he will speak about ctDNA in colon cancer. Is this a game changer? And is changing in the precision oncology.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you so much for Dubai Health team for inviting me to be part of this successful event. I would like to discuss how to use ctDNA in a clinical setting of colorectal cancer. I don't endorse any of ctDNA assays or brands, and this is going to be my discussion. I'm going to convey the messages. How do I use it in clinical practice? This is my disclosure. I have only 15 minutes. This is a very big topic. I may be skipping some slides throughout. Anyway, Today, I will show you how do I use myself ctDNA in treating patient with colorectal cancer in the adjuvant setting, with all the controversies regarding this tool at the current time, as we know of science as of today. First of all, we have to understand one concept. The origin of ctDNA goes back to cell-free DNA. And all of us, we have small amount of fragments in our bodies. The problem is the ctDNA actually is mutated, is different, and only shedded by tumors into the blood. And this is the concept that we can use this as a tool to identify cancer or to monitor cancer as well, especially colorectal cancer. There is one concept we have to be aware of, which is CHIP, which is clonal hematobiosis of indeterminate potential mutations. And this could be also in our blood. This could be also detected, and this could also interfere with the ctDNA. So this is something we have to keep in mind. And some of the mutation, for example, as a KRAS, can be detected as a CHIP as well. So this something can give you a false positive result. Different tumors gives you different burden of ctDNA into the blood. Bladder cancer and colon cancer are the highest shedding tumors. If you look at the end of the graph, you have gliomas, you have thyroid, they shed less. So not all the cancers can be able to shed ctDNA into the blood. When you look at clinical trials, you have to understand and you have to ask yourself question, is this clinical trial using the tumor-informed or tumor-agnostic? Tumor-informed, basically, we take a biopsy, we assess the mutations, and then check this mutation from the plasma. But the tumor-agnostic, we go directly and we check the plasma for these mutations. The ctDNA can theoretically be used in a different setting for screening, neoadjuvant, adjuvant, and also assessing the clonal evolution of the cancer cells throughout stage 4 as well. Clinical trials. When you look at the clinical trials, you have to ask yourself a question, is this a prognostic trial or this adaptive trial? Prognostic, I'm just looking at the ctDNA used in assessing the risk of the recurrence or the survival. But adaptive is actually, I use this information to change the management. And there are different trials look at this from this perspective. Also, is this including stage 1, 2, 3, 4? Which stage is included in this clinical trial? Also, is this using tumor-informed or tumor-agnostic assays? And finally, is this phase 2 or phase 3? Many trials, I will highlight the most important. Of course, dynamic, you cannot discuss ctDNA without talking about dynamic 2, dynamic 3, also COBRA trial, and also the Galaxy and the Bespoke. If you would like a copy of the presentation, the conveners team has a copy. Please feel free to get a copy of this. But again, I broke down this adaptive trials and prognostic trial to understand how to use this information to make a clinical decision. One of the prognostic trial is the INTERCEPT program from MD Anderson, and they assessed many patients with stage 2, 3, 4, and they have more than 2,500 patients. Half of these patients had a positive ctDNA, and the time from finding ctDNA positive to actual finding of the tumor recurrence in the scan was around 2 months, and the patient with ctDNA positive, which was initially negative, up to 3 months, then they were able to detect the finding on this to confirm the recurrence on imaging. So ctDNA was actually an early sign for the recurrence before it was seen on the imaging. Another very large trial, the Alliance in 0147. This is the largest colorectal cancer and was presented in ASCO last year. And this was ctDNA assay in patients who are actually to be treated with FOLFOX in the adjuvant setting, and 20% of these patients actually they had positive ctDNA. You can look at disease-free survival. Patient negative had a better outcome when it comes to disease survival. Patient with over survival as well, negative ctDNA. So the bottom line is ctDNA is a prognostic in the setting of colorectal cancer post-resection. When we look at another trial, which is actually by Dr. Tai, who's an authority in ctDNA world, and she assessed the circulating tumor DNA analysis and stage 3 in the adjuvant setting. Very simple message. Patient with a negative ctDNA had a risk of recurrence between 9 to 30, positive ctDNA between 60 to 90. Almost they're going to come back. It's just a matter of time. The Dynamic 2 is a very important trial that to be aware of, and it does have a clinical implication in stage 2. It's an adaptive trial where we make a decision based on the ctDNA finding, and in this trial, they divide 300 patients to a positive ctDNA versus negative ctDNA, and the patient actually were assessed based on that to make a decision regarding giving chemotherapy, and the disease-free recurrence was actually equivalent between the two arms, and the ctDNA guide management, the recurrence-free survival was similar between the standard treatment versus ctDNA management, but there was less chemotherapy utilization in stage 2 in patients using ctDNA. So ctDNA was actually helpful to reduce the use of chemotherapy in this population. But again, this is a very small trial. COBRA study was a very similar design, but actually, unfortunately, this study was terminated early because different reasons, but the bottom line was uncertainty of the stage 2 use of the ctDNA. It was terminated. And another trial, which is very important, which is the Dynamic 3. The Dynamic 3 is a very important trial looking at the stage 3, and the patients were actually randomized to either ctDNA informed management versus versus standard management. And the ctDNA informed management were actually patients with ctDNA positive or ctDNA negative. The negative one, you have to de-escalate because there is no evidence of disease, so you're trying to give less treatment. The positive one, you're trying to escalate. So let's look at the ctDNA positive arm first, and the escalation arm, the escalation in the very last part, where the plan, if there was no chemotherapy, you'll give some Xeloda. If you were planning Xeloda, you will escalate to 6-month oxaliplatin-based. And more than 1,000 patients were randomized. And they were a little bit more of higher risk T4 N2 in patient with the ctDNA-informed escalation. And the preliminary analysis actually did not show recurrent-free survival much difference between the two arms. And the primary endpoint was not met in this study. I will skip the slide just for the sake of time. And the conclusion was ctDNA-informed treatment escalation, including from oxaliplatin doublet, did not reduce recurrence, and the ctDNA clearance was, as we can guess, favorable outcome. My conclusion for this study was ctDNA-informed escalation did not reduce recurrence-free survival, but maybe the study was a little bit underpowered, imbalanced cohort, and also equating the Xelox and Folfox to Folfixiri. And again, ctDNA clearance in large proportion of patients could be potentially primary endpoint for future studies. Let's look at the Dynamic 3, the other arm, which is the de-escalation arm. Again, if you are planning to give more chemotherapy, you will give less. And in this study, the recurrence-free survival, again, there was no much difference. And the conclusion of this study for patients with ctDNA negative stage 3 colon cancer, the ctDNA-informed decision used less or reduced oxaliplatin, better safety, and non-inferiority versus standard of care was not confirmed. ctDNA-informed de-escalation strategy, again, we want more information before making this standard of treatment. The BESPOKE, it's an observational study by Dr. Bashtun Kasi, and basically this is in stage 2 and stage 3. What they did, very simple thing, they did a serial measurement. They let patients go through their normal pathway of treatment with resectable colorectal cancer. And what they did, they just followed these patients with a serial ctDNA testing throughout up to 24 months. And again, we know this, the ctDNA is very prognostic for outcome when it comes to the positive or negative result. But again, benefit from adjuvant chemotherapy observed in the MRD positive, but not MRD negative patient. Very important, actually, data from the BESPOKE, which was the patient perspective. We've been talking about our perspective, but about the patient perspective. This is the only data I'm aware of, actually, which was published regarding the patient perspective. Patients like to use the ctDNA. 73% reported result reduced anxiety. 87% felt they were receiving the right treatment. 92% would continue using ctDNA. 96% value the additional information. So patients were happy, satisfied, but maybe not those ones with the negative imaging and positive ctDNA, but definitely it can give also some anxiety based on my own experience. The Dynamic rectal, maybe Dr. Hassan was going to talk about this, also used the dynamic protocol to inform the decision, either standard treatment versus ctDNA informed. ctDNA positive will get 4 months of adjuvant chemotherapy. Again, there was similar recurrence-free survival. The ctDNA guided approach reduced the use of the chemotherapy. So the sample size was lower. But there was very interesting finding, which actually I agree with, which I see in my clinical practice. Notable proportion of recurrence in ctDNA negative group were observed in the lung. So the lung actually doesn't really reflect very well. So you could have someone who has some recurrence in the lung, early recurrence in the lung, and the ctDNA is negative. The prognostic and adaptive trial of Circulate, it's a very complex trial. Actually, I may not go through it in details, but anyway, it's a very complex protocol that has, the Vega trial, Galaxy, and Altair trial, and it was presented at different stages. I have only 3 minutes left, so I'm just gonna skip this. The conclusion, positive post-operative ctDNA have significant lower disease-free survival, and ctDNA positive patient derive benefit from adjuvant chemotherapy. I will just pass the Pegasus duration of testing. Are you sure I have 15 minutes? It sounds like 5 minutes only. Study design, complex design. Anyway, the bottom line is actually from this slides here, I would like to show you the areas that you cannot really depend on the ctDNA when it comes to the recurrence. This includes lung, as I mentioned earlier, the peritoneum, and also local recurrence. These areas don't tend to pick up in the ctDNA, but liver, pericardium, ovary, distant lymph metastases, they pick up very well in ctDNA. Ongoing trials, multiple ongoing trials. The latest data published in ASCO GI actually about the Altair, it was just talking about the finding and how many patients were enrolled in the Altair trial. Out of 5,000 patients, 148 patients were included in the Altair trial. The ISMO guidelines, NCCN guidelines, bottom line is it's not ready for the prime time. And this is the message from the NCCN and also from the ISMO, clearly saying that maybe it's not ready now for clinical trial and should be used in the setting of the clinical trials. How do I use in the last 2 minutes ctDNA today? I use it only for escalation treatment. I do not use it for de-escalation. And for example, I have 52 years old, stage 2 colorectal cancer, low risk, positive ctDNA. I gave the patient Capox for a few months, for 3 months, and ctDNA has been negative and continue monitoring this patient. So it's helping me in taking care of this patient, especially with stage 2. Another patient, stage 3, low risk, Capox for 3 months, and then patient become positive, and then metastasis to the liver. This gave me indication that patient can have recurrence. I couldn't do anything. There's no data to escalate the treatment or give more chemotherapy. In fact, giving him more chemotherapy will not make a difference. I used actually, if I can make it negative, I can give some patients some Xeloda to lower their burden of disease for some time. But again, this is based on the practice, and there's no evidence to support this. Positive finding. One of the issues as well, sometimes you could be waiting for a month and then suddenly you didn't have enough information or enough genomic data to report to the patient. So it could be disappointing for the patient. Plus the cost could be very costly if there is no coverage from insurance. In fact, we are actually finishing our paper, more than 100 patients that we have in Burji Cancer Institute with the colorectal cancer. And we're finalizing how this actually affected our decisions in treating these patients. Also, we are finishing another paper from supposed to be 2025 regarding the latest advancement in the ctDNA. It's a review paper with Dr. Saeed and other colleagues, and Dr. Deborah Mukherjee, trying to understand the current status of science of using ctDNA in colorectal cancer. And with this, I would like to conclude. I have 15 seconds. ctDNA is evolving. It could be prognostic. We have more confident prognostic value, predictive value still. Current guideline does not recommend the ctDNA. We should consider using it in the right patient only after we counsel this patient. Thank you.
Thank you, Dr. Hamid. You can join us, please, on the panel. And I would like to invite the panels, Dr. Ahmed Al-Kindi, the consultant radiologist from Rashid Hospital, Dr. Falah, is an radiation oncologist from Al-Zahra, and Dr. Sayyid Karim from King's College, consultant oncologist. And our speakers, please, to join us in the stage. Okay, so so the topics are so interesting, and I would like to start with cancer rectum, and I have so much interest in the watch and wait, and actually it might take our job in the future that we were all discussing. So my first question, what is the criteria of choosing patients for watch and wait? This is Dr. Ghazal. How you choose your patient? Which one is for watch and wait? And is this part of the guidelines? And there is a percentage of relapse. What's the percentage of relapse? And if there is a relapse, are you still going to do another trial of chemotherapy or chemoradiotherapy? And why it is only in the lower third of the rectum? Why not in the middle third? We use it only for the lower third. And which stage? A lot of questions and
Thank you. So many questions. The short answer is it is not restricted, by the way, except for the upper rectum, perhaps, because you don't need radiation therapy to the upper rectum. But mid-rectum to the lower rectum were included in these trials. If you follow the OPERA trial, which is the main one that looked at watchful waiting. So anybody who achieve a complete response by pelvic MRI, by endoscopy, is a candidate for follow-up on watchful waiting. So there is no limits. You could start with a T4 or T3, N1 or N2, as long as you finally, by pelvic MRI, by endoscopic with biopsies, you are deemed a complete responder. You could go on watchful waiting. And the data I showed you, only 9% on that group developed distant metastasis, where patient who had surgery end up with a 25% distant metastasis. So you are not compromising outcome by doing a watchful waiting approach. Now you can add the ctDNA that Dr. Hamid talked about in the mix. The problem, it's not approved by many insurances still, and it is expensive. But if your ctDNA is 0, if by endoscopically and biopsies you are negative, pelvic MRI is saying you are in complete response, this patient can live normally without surgery. And what we know from the data, that 1 in 4 on these patients, 1 in 4 may recur in the first 3 years mainly. So if you pass 3 years, it's very rare that you see any recurrence. If you recur within these 3 years, you can have a salvage mesorectal excision, or some data now or on even local excision, and your still outcome can be just as good as if you have done surgery in the beginning. So you are not compromising life. And in fact, you are improving quality of life because keeping a rectum is much better than removing the rectum.
So the other question is that sometimes after the, yes, please.
Thank you so much, Dr. Hassan. And I just want to add that patient and center and doctor factors are important in watch and wait. The patient needs to be compliant, needs to do what you ask the patient to do. If you have a patient who will disappear for 2 years, this will not be a good candidate for waiting. And I have seen that. If you have a center where the MRI machine is 10 years old, or he's going to move to somewhere where maybe access to MRI or endoscopy is a struggle, their insurance is basic level or whatever. So you got to be careful and take this into account, just from my own experience.
No, totally agree. This is a given. You have to follow what I mentioned. Every 3 months, MRIs and endoscopy, the first 2 years.
Do you take biopsy? Do you retake biopsy after the therapy?
Yes, you can, and it's up to the surgeon or the endoscopist. Sometime if we see something we don't like, we may do EUS. So we can do alternate EUS with regular endoscopy, biopsy as needed, as depicted by the surgeon or gastroenterologist if needed.
I advocate for biopsy all the time if there is anything suspicious.
Biopsy after the therapy?
Yes.
Yes.
I know some surgeons, they don't like it. They just want to go with the look, but I prefer to confirm any finding.
With the initial assessment, they all do biopsies, but I'm talking about the follow-up. If it's exactly the same, the pelvic MRI is negative.
What do you think?
Sometimes there is complete response. The mucosa even completely normal, and you don't know where was the tumor.
We don't take unless we see something. I'm not saying that you have to
Yeah.
take biopsy every single time. No, if there is nothing, definitely.
Definitely, you are right. We have to take a biopsy. Dr. Ahmed Al-Kindi, is there a rule of MRI? We are speaking before and after to choose the, or let's say after completion of therapy. Sometimes, because of the effect of radiotherapy, there will be some changes. And is there a way to differentiate between these changes is related to the radiotherapy, or is it recurrence or relapse?
So thank you. First of all, thank you for your question, and thank you for the opportunity to be here. Just allow me, if you don't mind, to just relieve some ambiguity in some of the radiological terms. So mostly when we use MRI pelvis or rectal cancer, either staging or restaging, we use T2 and diffusion weighted image. And these are the two sequences, the workhorse, to look for these two changes, or for the changes. Now, how reliable is the MRI in determining the complete or clinical complete response? It is quite good, and the studies actually tested how positive predictive value of the MRI in detecting these, and using both the T2 and DWI, like the diffusion weighted image. Diffusion weighted image is basically looking for the water molecules, are they restricted or not? It's basically according to some complex MRI physics to look for these. And it looks for cellularity of the cellularity of that abnormality in correlation to T2. So if we see a scar, which is basically T2 dark signal intensity, and that there is no diffusion weighted image, then we would say this is a complete response. And there is grading system as well, according to T2. They have been tested. So as I mentioned, like the positive predictive value in one of the studies recently published from MSKCC, combination of oncology, radiology, and surgery, they said that it's 0.86 in the complete, the positive predictive value. So it's quite good. So when we look for this, we look for T2 again, which is shows the scarring, post-treatment changes, and we correlate this with the DWI, which is diffusion weighted image. If we don't see any diffusion weighted diffusion restriction, then we would call this a complete clinical or clinically complete response. And there is again grading system for any foci of residual, let's say, diffusion restriction, then we will raise the suspicion of recurrent disease. Again, this study, in reference to this, very quick, they mentioned that there is also false positive. As you can imagine, this is 0.86 positive predictive value. But very interesting also, they showed that in 22% of cases, it showed early recurrence than the endoscopic evaluation. Like later on follow-up, they showed those 22% of cases they tested and scans, they showed actually later on recurrent disease, so earlier than this. Thank you.
Just one common mistake, I just didn't mention that, the timing of evaluation. We had patients, second opinion, they came within 4 weeks from their last chemo treatment or radiation treatment, and that's wrong. We should not evaluate these patients at 4 weeks. It's the longer you wait, up to 12 weeks is the optimal, the better, because you have continuing response. Because you could do endoscopy at 4 weeks, you still see a scar or even an ulcer, and surgeon said, oh, you need APR or abdominal, etc., low anterior resection, where after another 4 to 8 weeks, they are in complete response. So please, you have to wait 12 weeks.
You mean you have to wait after completion of therapy?
Yes. Yes.
Okay.
So next question, Dr. Karim. High resolution MRI remains the key for detection of the regrowth, while on the other side, post TNT, the clearance of ctDNA predict the late recurrences. So how do you integrate MRI and ctDNA in watchful waiting strategy?
So thank you for your question. Thank you for Team PMOC
for such a wonderful conference. So coming back to your question, I would think that this just augments your clinical decision making when you have got an MRI which is clear, an endoscopy which is clear, and then if you have a CT DNA which is also clear. So it just augments and gives you more reassurance. So you have to see all the three modality in its total, and then just continue the watchful wait. So I think it just adds on an extra safety feature.
One question in this watch wait policy, we still do digital rectal examination in all these patients with all these modalities of treatment and so on? Because I think probably we are ignoring an important issue.
Well, depend on how low is the
Well,
tumor.
yeah, it
Sometimes it's a 7-8 centimeter, you cannot feel it. But yeah, I think this is very important point. Digital exam is always. Now, what happened when they take you to the flexible endoscopy unit, they will do a digital exam at the same time.
Just so we don't forget it. Because
Yes. I ask, are we done with the Dr. Humaid?
You're a panelist. You're asking questions as well.
So we have data back on ctDNA and adjuvant setting. We have data and all data on chemotherapy that the earlier you start chemotherapy, the better. In fact, I remember one trial, they gave it within 1 week of surgery even, and it was better than waiting a month. So how do we reconcile that with the data that, okay, we can wait now for ctDNA or serial ctDNA, and once you turn positive, now I will give you adjuvant therapy?
Well, Doctor, as I mentioned in my presentation, this is a very slippery slope. When it comes to the adjuvant setting and doing a serial measurement, there is no clear guidelines regarding what should you do with this information, and that's why I always counsel my patient about a very clear plan. If this is going to be positive, this was what will I do? If it's negative, we'll continue monitoring. The problem is, even if you give chemotherapy, there are no data to support this will improve outcome. We do it to make us feel better. Having said that, data also shows patients who receive chemotherapy and have clearance, not escalation, but who are planned to give chemotherapy and who has clearance, they tend to do better than the ones who stays positive. So again, I think at the current time, counseling patient and assessing the plan before ordering the ctDNA, have very clear plan about what chemotherapy you will give. Patient finish FOLFOX, and then will you give him more FOLFOX? Will you change the treatment? Again, every patient is different, but I tend to give the patient has positive disease after finishing chemotherapy to change the chemotherapy to another treatment modality or giving Xeloda. This is what I do. Maybe I'm wrong. Until we have more data, will be more robust data, we'll be able to make decisions. But the current time, I think it's still a difficult area to counsel patient and take decisions.
Thank you. Moving to the next topic, Dr. Fatima, regarding HCC. Now we have 3 trials, Emerald-1 and ABC-HCC, as well as talent test shows clear PFS gain from the combination of tests as well as systemic therapy. So do you think this is the standard today in your practice? Tests combined with systemic therapy? Yes.
We have good data that it improves the BFS, and we have multiple trials, and I think there are still some going on, like durvalumab plus bevacizumab and TACE, and we have also pembro, lymphatinib, and TACE, and we have, I think there are some trials coming up also, durva-tremi. So we have some trials, and even in the old days, I think, especially for those who they have multiple or big lesions where we know that TACE will not be enough, I think we probably need to sooner combine them with systemic therapy, because you may lose the opportunity. And we know that TACE sometimes, especially when you use it frequently, you can push these patients' liver function, and they can go to what we call it post-TACE syndrome, and their liver function can deteriorate. So maybe I would probably add some systemic therapy for these patients. But there are exceptions, of course. If it's poor liver function and you have a small lesion, I mean, you feel that taste will be fair enough for quite some time to save them the toxicity. I think it's a multidisciplinary and good correlation with the clinical and also with the rest of the team, how experienced your team is and what available options, because now we have also CERT, we have histotripsy, we have intraarterial, so there are so many options available.
So when do you choose only TAS or TAS plus systemic therapy? What is the criteria?
Yeah, I mean, to be honest, I don't think there is a set criteria. It's case by case. It's multi. This is exactly where you need a multidisciplinary team, and you need to look. If you have a very good interventional radiology team, and I have good experience, I think TACE has a very good role. But if you have multifocal disease and the liver functions just about, you don't want to waste your time with the TACE, because this is obviously a systemic disease and you need to move to systemic therapy. But there are cases where you can combine both.
Okay, moving to the next topic now, the pancreatic cancer, Dr. Murtaza. Yeah. So Dr. Murtaza has already mentioned that the neoadjuvant chemotherapy followed by surgery is his choice. So I think we'll ask Dr. Farah as well, do you think that the neoadjuvant chemotherapy only is enough, or chemoradiotherapy should be the choice up front before the surgery?
That's for inoperable cases, yes. That's the treatment of choice to get best control. Other than that, I think you should go for chemotherapy and then surgery if possible. Other than that, because pancreatic tumor is not a very sensitive tumor. It needs a high dose of radiation. It is surrounded by a lot of sensitive organs, sensitive that all around. And then the end of radiotherapy, you get a very melted, fibrous area that is difficult for surgeon to go in. So it's better to avoid it unless you go for palliative.
Radiotherapy only for palliative?
Yeah.
Not as a new adjuvant?
No.
Dr. Murtaza?
Yeah, that's a very good point. I think, yes, there isn't any, local control, symptom control, as Dr. Falah mentioned, there is a role. Increase R0 resection, but because this is an ultimately systemic disease, it doesn't really improve PFS or survival, which is what multiple meta-analysis showed. I think in the UK, what we used to offer those patients who we plan for surgery, but they end up having no surgery for whatever reason, there is a rationale to consolidate with chemoradiotherapy for prolonging the duration of local disease control. But as a new adjuvant strategy, I don't think it will improve PFS or survival. So I think it's a systemic disease and the treatment is systemic chemotherapy.
Next from Dr. Hamid. Dr. Hamid, now the ctDNA, you use it to decide the duration of chemotherapy? I mean, once you reach negative, you stop chemotherapy?
No, as I mentioned in my talk, I never use it to de-escalate treatment. And again, if the patient stage 3, he has all the indications, for example, for treatment, for adjuvant treatment, I'll continue.
It was mentioned that it reduces the duration of chemotherapy.
No, utilization of chemotherapy in
utilization.
Stage 2.
That's
stage
dynamic.
Stage
2 is done. Stage 2 is stronger data than stage 3.
Yeah. For stage 2, it can help you to make a decision regarding giving chemotherapy. But for stage 3, the dynamic 3 trial did not really, give us a final conclusion for de-escalation.
It doesn't change the outcomes, huh?
No,
I understood
the escalation of treatment did not make a difference in the outcome. And that's why my conclusion was we need more data to make final recommendation regarding the use of your ctDNA in the adjuvant setting. But definitely for the stage 2, you can still, I'm talking about stage 3, but stage 2, you can use it actually with some confidence in the data, published so far.
Is it included in the guidelines now, the ctDNA?
I presented the ctDNA, the guidelines, ESMO and ASCO. They say you shouldn't be using it until further notice, until we have more data.
I have just one comment on the circulating tumor DNA. So excellent presentation, Prof. Ahmed. So as you rightly said, from patient perspective, they do like it. Some of them, they will come asking because it's a prognostic. So they need this reassurance of negative circulating tumor DNA, which gives them maybe like a more objective hope that there is no, or the risk of recurrence is low. So I think it's also important for the patient or important for us and the patient to look after this point. So to give this reassurance, yes, there isn't circulating DNA.
That's why I mentioned, Doctor, we have to be very clear about the plan with the patient. We have to give them long-term plan from beginning. If they agree in our terms and condition to use ctDNA, we go forward. If they don't, then I will not use, because this will cause a conflict between you and the patient regarding for example, stage 3, ctDNA negative, why should I give chemotherapy? No, you have to be very clear. You will still use it. Just going to help you in the future.
Thanks so much, Mr. Ahmed. I think it's very interesting, very emerging area, but I must admit that there's a lot of confusion, particularly with the patients. They think it's predictive. I think most of the patients, they think it's predictive, and they are, as Dr. Murtada said, they are in the hope that it's negative. But if it is positive, it will become really difficult subject to tackle. And as Dr. Ahmed said, you need to be prepared to these scenarios. And I think I must admit, there is more use of the ctDNA and more belief in the ctDNA than the available data, and even among the oncology community across the board. I see patients coming for second opinion where they are clearly, according to the phase 3 data, that they need chemotherapy or they don't need chemotherapy. And most of the discussion are revolving about the ctDNA, which is the guidelines sit clearly that these are prognostic and not predictive. But I think most of the patients and some clinicians, they use it as predictive.
That's why it's important to select the patient.
Yeah, and as Dr. Ahmed, set the concept from the start. Otherwise, you will go into a lot of trouble with the patient.
Thank you all, the panelists and the speaker. We will conclude the session. We'll invite the next patient, moderator of the next session. Thank you.
Thank you very much.
Thank you for the excellent discussion. Hello. We have two more sessions. I know it's late in the evening, so please bear with us. Next speaker will be Dr. Maha Al-Sindi. She is a consultant medical oncologist in Bahrain Oncology Center. She has a special interest in the treatment of breast and gynecological cancers. So Dr. Maha will be talking about treatment advances in platinum-resistant ovarian cancer. Please.
Thank you so much. This is a satellite symposium for AbbVie. So I'm very glad to be here with you today to talk about beyond platinum treatment advances in platinum-resistant ovarian cancer. Okay, so this is the disclosure by AbbVie. So little background about ovarian cancer. So we know that ovarian cancer, it's the 8th most common cancer occurring in women worldwide, and it's the second highest cause of death from gynecological cancers. There in 2022, there were approximately 325,000 new cases of ovarian cancer, and approximately the majority of them, unfortunately, end up with a very bad outcome. And by 2050, there is going to be the number of women dying from ovarian cancer will increase, and it's projected to increase to up to 70%. So we know it's the majority of patients with ovarian cancer are postmenopausal, diagnosed more than the age of 50. And again, we know that most of these patients end up receiving several lines of treatment, and their time for recurrence becomes shorter and shorter, and the majority of these women eventually subside with bowel obstruction and very bad outcome. So again, and we know if for anybody who treats ovarian cancer, we always tell patients, unfortunately, it's a disease of relapsing and remitting, and the majority of patients, up to 70%, end up relapsing within 3 years of the first-line treatment. and 30 to 50% of 5-year survival of newly diagnosed patients with ovarian cancer. So we have to improve. There is definitely a need to improve the first-line treatment and to improve the outcome for women with ovarian cancer. And again, we know that what happens usually is as we treat patients, usually from first line, whether they receive surgery and then followed by adjuvant chemotherapy, this really depends, their progression-free survival becomes shorter and shorter with time as they become more and more as they become basically platinum resistant. And eventually patients succumb with bowel obstruction to death. So we know that platinum-resistant disease represents a large unmet need in ovarian cancer. For many years, we were using platinum agents over and over again until patients end up becoming platinum-resistant. And at that time, we only had single-agent chemotherapy with very minimal response. So we know the standard of care for advanced ovarian cancer and platinum-based chemotherapy. Initially, response to chemotherapy is over 75%. However, 25% of patients with early stage disease and up to 80% of patients will eventually become platinum resistant with their disease. And then, as we mentioned, as they become platinum resistant, the overall response rate is dismal, 4 to 10% approximately in patients using single agent chemotherapy. And there was lack of overall survival data in these patients until we have more lines of treatment. So it's a lethal disease with very few efficacious targeted treatment. So this is the clinical trials that looked at the platinum resistant over the past 12 years. As you can see, there was nothing. We had no treatment up to 2022. And I remember when I was doing my fellowship, we were participating in the Soraya trial. And it's really, we saw here where we saw signal of patients who were recruiting patients with platinum resistant ovarian cancer. And these patients really started to have an improvement in their progression-free survival and overall survival. Again, we see here the PFS as patients received first relapse, second relapse, third, fourth, and fifth. You can see the both median progression-free survival and the median overall survival for these patients is becoming subsequently less with the treatment. And we only know when we are treating patients in a curative intent, we tend to prioritize patients for the PFS more than probably pushing treatment rather than, again, maintaining quality of life. However, in later lines of therapy, the expectations sort of change. We try to maintain patients' quality of life while balancing as well their progression-free survival and hopefully aiming for overall survival. So while extending overall survival is an important goal, in patients who have advanced disease, it's important as well to maintain their quality of life. And again, there has been no approved treatment demonstrating a significant overall survival until now in platinum-resistant ovarian cancer. So with the ESMO clinical practice guidelines, gives us a decision in terms of when do we use platinum for these patients. So we know that platinum is not an option when the patient is either platinum refractory, so they are progressing during platinum, or if they have early symptomatic relapse. So we still use the sort of definition of platinum free of being less than 6 months as patients who are not responding, or patients who are platinum intolerant, or we have patients who unfortunately have severe allergic reaction to recurrent platinum exposure. So again, we mentioned that unfortunately in this setting, we have subsequent treatment with either single agent chemotherapy plus minus the addition of bevacizumab that came as based on the trial, which I will be discussing shortly. So again, we have these single agents like liposomal doxorubicin, topotecan, docetaxel, gemcitabine, pemetrexed. And if you look at the overall response rate, the maximum overall response rate you'll get is 30% with paclitaxel. And the median PFS for these patients is around 3 to 4 months, maximum reaching 6 months with paclitaxel again. And again, there is really minimal overall survival benefit for these patients. So we usually go for subsequent monotherapy in this selection, and the selection would be based on toxicity in the majority of this setting and the presence of previous toxicity and the patient preference. So again, these are just this trial that looked at the platinum-resistant ovarian cancer, and these are results from the single-agent chemotherapy. As you can see here, the overall response rate is quite dismal. Again, ranging from 4 to 13%, and the median overall survival is about, the median PFS is almost 3 months to 4 months. And again, we know we shouldn't be comparing, but these are the average, and it reflects what we see in real life. Again, we mentioned very low response rate, very short PFS, and the overall survival is at best reaching up to a year. So we know that the earlier trial, which was the trial that looked at using either single agent chemotherapy plus or minus bevacizumab, and in this patients who had progressive disease, less than 6 months completing previous platinum therapy containing of platinum therapy. And again, in these subset of patients, only 7% of patients had prior bevacizumab therapy. And that's probably why we're seeing, that now we're using more and more bevacizumab in the upfront setting for all of the patients based on the data that we have from the solo trial. So again, this looked at the primary endpoint, which was investigator-free survival. And again, bevacizumab may be recommended in combination with either weekly paclitaxel, liposomal doxorubicin, or topotecan, in patients who either have not been exposed or has contraindication to bevacizumab. And again, we see here that bevacizumab improved the median PFS with a hazard ratio of 0.48, and it improved GI and abdominal symptoms. However, it did not improve overall survival. So the trial met its primary endpoint, which was progression-free survival. And again, it is better than using single-agent chemotherapy. And we can see here the median PFS 6.7 months versus 3.4 months, and a hazard ratio of 0.3, almost 0.4. And you can see overall response rate. However, we mentioned that there was no overall survival gain in this trial of the combination of bevacizumab. And if we look at the exploratory analysis looking at which chemotherapy backbone we use, we see here that perhaps weekly paclitaxel ended up doing a little bit better, but can we do better than paclitaxel as chemotherapy? And we know there is a lot of emerging biomarkers in ovarian cancer. We know that the ESMO guidelines recommend doing BRCA testing, germline or somatic, at diagnosis, regardless of the stage. So we know that now HRD testing is I think mandatory, or we should be doing for all patients who have especially high-grade serous ovarian cancer. And there are also some additional biomarkers that we do in advanced settings, such as HER2 protein, NTRK, alpha-folate 1 receptor, MMR, BRAF, MSI, tumor mutational burden, and RAT mutation. So there really has been a lot of changes that happened, and one of the most significant discoveries has been the discovery of alpha-folate 1 receptor and ADC in ovarian cancer. So what is alpha-folate 1 receptor? So alpha-folate 1 receptor is a protein encoded on the FOLR1 gene that acts as a receptor for folate. It plays an important role in embryonic development, cell migration, and invasion. And it's overexpressed in nearly 90% of ovarian cancer, and it's rarely expressed in non-malignant ovarian tissue. And it's a promising therapeutic target, and it leads to proliferation, survival, and growth. So again, we mentioned that it's expressed only on the surface of ovarian cancer cells. And so how does it work? It binds to the alpha-folate 1 receptor expressed on tumor cell, and it's internalized into the cell, and the payload is a microtubule disturbing agent, DM4, which is released, and it stops microtubule formation, disrupts cell division, and induce cell death. And how do we detect alpha-folate 1 receptor? Basically, it's an immunohistochemistry test, so it can be very easily done by our pathologist. And again, we see 32 to 36% of high-grade serous ovarian cancer that have been shown to have positive alpha-folate 1 receptor using the Ventana FOLR1 assay in the mirvetuximab trials. And when do we say that the test is positive? The test is positive if more than 75% of viable tumor cells with moderate 2+ or 3+ membranous staining, and that would make the patient eligible for treatment with mirvetuximab, which is an alpha-folate 1 receptor. And this is the biomarker what we call biomarker-led treatments. So as we mentioned, the Soraya was the single arm open label trial that sort of put mirvetuximab on the market, and this was approved, it received accelerated approval, especially in platinum-resistant ovarian cancer, an area where we didn't have really a lot of treatment option. And based on that, we then saw the results of the Mirasol trial, which was mirvetuximab versus investigator choice of chemotherapy in a platinum-resistant advanced high-grade epithelial ovarian cancer, primary peritoneal or fallopian tube cancer. It was an open-label phase 3 randomized study in patients who have alpha-folate receptor high platinum-resistant ovarian cancer. So the patient had to have platinum-resistant disease with a platinum-free interval of less than or equal to 6 months. They had to have alpha-folate 1 receptor, the positive staining of more than 75% of viable tumor cells, high-grade serous histology. Platinum, that's very important as well to mention, that primary platinum refractory disease were excluded from the trial. So patients who had the platinum-free interval of less than 3 months were excluded. They allowed a heavily pretreated population, so 1 to 3 lines of chemotherapy. They allowed prior bevacizumab and PARP inhibitor, which is standard of treatment. So almost all patients received bev and PARP inhibitor, and we'll see the baseline characteristics. And again, patients with BRCA mutations were allowed. And they were randomized 1:1 to mirvetuximab or investigator choice of treatment, paclitaxel, liposomal doxorubicin, or topotecan. And the stratification factor was based on the chemotherapy choice and the prior line of therapy. The primary endpoint was the median the progression-free survival by investigator. And the key secondary endpoint was overall response rate, overall survival, and the quality of life subscales. So it included all patients' intention to treat. And again, some additional secondary endpoints included safety, tolerability, duration of response, PFS2, overall response rates, and some post hoc analysis of patient-reported outcome. And again, to mention the inclusion criteria, as you can see here, they excluded patients who had a platinum-free interval of less than 3 months, and they allowed if it was more than 6 months or more, if they had complete or partial response after 4 cycles of chemotherapy. And that included in the first-line setting, approximately 14% of patients. And in the second and third-line setting, those patients were included approximately 86% of the population. And again, if we look at the baseline demographic characteristic, you can see it's balanced. As you can see here, the prior exposure, the majority of patients, 60%, received bevacizumab, 50% received PARP inhibitors, almost 100% of patients received previous taxanes. And if you look at the previous lines of therapy, the majority of patients received either 2 or 3 lines. So 50% of patients in this trial received at least 3 lines of therapy. So we're talking about a heavily pretreated population. And this was presented in ASCO 2023 by Dr. Kathleen Moore. And we can see here, this was the primary endpoint, which was the PFS by the investigator. The median PFS was 5.62 versus 3.98 with a hazard ratio of 0.65 and a statistically significant p-value. And you can see that patients end up, the separation of the curves happen before even the 3 months scan. And you can see here that this is the change from the baseline of the target lesion. And you can see here that 80% of the participants in the mirvetuximab arm experienced tumor reduction. So if we look at the overall response rate, it was 42%. If we look at tumor reduction rate, it's almost 80%. And if we look at the clinical benefit rate, it's reaching to 90% in comparison to patients who are on the chemotherapy arm who only had 50% reduction in the tumor response. So some exploratory analysis endpoints that were done was based on the type and number of prior treatment regimen. And if we see here, these are the baseline demographics based on the previous PARP inhibitor and prior lines of therapy. So they looked at the PFS in patients who are PARP naive. So probably these patients had or BRCA wild type. And we know, and generally these patients and have a poorer prognosis and a harder to treat subset of patients. And you can see here that the median PFS is 5.3 versus 4.2 with a hazard ratio of 0.74. And again, this is exploratory analysis. And we can see that these are the patients who have been on a PARP inhibitor who do a little better. Again, probably because these subset of patients have a more favorable prognosis with a hazard ratio of 0.58. And again, if we look at the prior lines of therapy, so if you receive 1 or 2 lines of prior therapy, your median PFS is 5.68 versus 4.4 months with a hazard ratio of 0.61. And again, it's the significant p-value. And if you receive as well 3 lines and prior, again, you still end up doing a little bit better than single agent chemotherapy and a hazard ratio that is, again, significant. And again, here we see just the overall survival. These are the PARP naive patients, and these are the PARP treated patients. We see that the hazard ratio is more pronounced in the subset of patients. And again, this is hypothesis generating, and we shouldn't be, selecting patients based on that. So again, we see here the overall survival. If we look at, so all the patients end up benefiting, whether they receive 1 or 2 lines or 3 lines of therapy. And here we see the final overall survival analysis that was presented in the SGO meeting in 2025. And we see that the final PFS of 5.59 versus 3.98 and a hazard ratio of 0.63. And again, a 37% reduction in the risk of progression. And we can see if we look at the subset analysis, we can see that the majority of patients, again, they all favor the mirvetuximab group. And here again, if we put this just to see where it falls, we see that it is one of the benchmarks of the median PFS in the platinum-resistant setting is the Marisol trial. And again, we mentioned that the Aurelia trial, only as 7% of patients had prior bevacizumab, whereas in the Marisol, the majority of patients received bevacizumab as standard of care. And here we see the final overall survival. Again, we see 16.85 versus 13.34. And again, a 32% reduction in the risk of death. And we see, if we look at the subset, again, of population, we can see that the majority of this, whether you're exposed to prior bevacizumab or PARP inhibitor based on the numbers of line of therapy or the type of chemotherapy, all favoring the mirvetuximab group. So I'm just going to move on a little bit for the sake of time. Again, if we see the complete response, 13 versus no responses in the chemotherapy, median duration of response, almost 7 versus 4 months, and the median PFS2 is almost as well almost double in the mirvetuximab arm. And again, if we look at treatment tolerability, so if we look at any treatment leading to either dose discontinuation, so it's actually lower with the mirvetuximab group. However, dose reduction was slightly higher. And again, the outcomes of, so did that affect, so dose modification or stopping the treatment, does that affect the outcome? So here we see the efficacy results. And to give you just the gist of it, it didn't really matter. Patients still end up doing better if they receive mirvetuximab, even with dose modification. So did not really compromise efficacy and the overall survival. So just a quick point about patient-reported outcome, which is very important when we're treating, especially in the advanced setting, that we're not actually causing the patient's quality of life to deteriorate. And here they looked at the EORTC OV28, which measures disease-specific symptom in patients with ovarian cancer. And just to see that actually the assessment of abdominal and GI symptoms were better in patients who received mirvetuximab, and it was lower. And even when we looked at symptom score, it was lower in patients who received mirvetuximab group. So it was statistically significant difference favoring mirvetuximab in terms of the GI or abdominal symptom, which is very important for any woman with platinum-resistant ovarian cancer. And again, even the quality of life scale, which included just 3 measures, which is global health status, role and functioning, and fatigue symptoms. And again, all of these, as you can see, is higher with the mirvetuximab group. So it was statistically significant, again, seen and in favor of the mirvetuximab group, and the deterioration over time was more in the chemotherapy arm. So there was a higher number of patients who maintained or improved their ovarian cancer specific measures of health quality of life. There was significant improvement were observed relative to chemotherapy across all time points in terms of abdominal or GI symptoms, and patients who were treated with mirvetuximab maintained their quality of life, whereas patients treated with chemotherapy had deterioration in all quality of life subscale aspects, and it was clinically meaningful difference in fatigue were seen in both between arms favoring mirvetuximab. And again, here we see these are the NCCN guidelines. We see that again, mirvetuximab is here as a preferred regimen, especially for patients who express alpha-folate 1 receptor more than 75% positive in tumor cells. And with that, I'd like, that's my last slide. Thank you.
Thank you, Dr. Maha, for the very nice presentation. And next, I would like to invite Dr. Arif Shihal, who's a consultant medical oncology at Sheikh Shahboud Medical City. He's going to talk about redefining possibility in the first line of advanced HCC.
Assalamu alaikum. Thank you, Dr. Dina, for your kind introduction, and thank you for the organizing committee for inviting me. I know it's like we are 1 hour late for the schedule. It's not my fault. But so I'm going to talk about hepatocellular carcinoma. I think most of the data have been presented by Dr. Fathi before, بس التكرار بيعلم الشطار. So we'll focus, and this is AstraZeneca sponsored meeting. So we'll focus on the STRIDE regimen. This is a disclaimer by the company and reporting outcomes and adverse event. As we know, hepatocellular carcinoma is broad spectrum of disease from early to late stages, and we still believe that in early stage localized therapy like TACE and other, and even resections is the standard of care. And we know there are many studies for even combination of immunotherapy with TACE is giving better result. However, we're focusing today about advanced HCC to differentiate between different role of TKIs and immunotherapy combination. So the treatment goals in HCC and in many solid tumor when it is an advanced disease is to achieve long-term survival and to preserve the quality of life of the patient, and this is very important. In advanced unresectable HCC, we know that there are the TKIs alone, there are TKI plus immunotherapy, and there is the double immunotherapy, Trimidurva in 2022, and maybe later Nivo-Ipi came into the market. And we know that there are a lot of unmet need, regarding treatment of HCC. And just to highlight, because Dr. Azribi talked in detail about Lenva and SORA study, but to show you, because we know that lenvatinib as TKI is better than sorafenib, but however, this was in terms of progression-free survival. If you look at the overall survival, there was no difference. The hazard ratio is 0.92, and the p-value was not significant. So in terms of overall survival, there is no difference between Lenva and sorafenib. The combination of immunotherapy, the combination of TKIs and anti-VEGF, we're talking about the bevacizumab in Brave 150 study, where they used Atizo 1200 plus Avastin versus sorafenib, which was the standard of care at the time. The primary endpoint was OS, PFS, and secondary endpoint as mentioned below. And we know that this study was positive, actually, with overall survival at 2 years, around 50% of these patients were still alive, and the median was 19 versus 13 months. The hazard ratio was 0.66. This was really significant. So the overall median was 15 months. But however, these patients were, highly selective, to avoid the bleeding, because we know if they have esophageal varices, there was 26% report of a bleeding. If you want to compare, the protocol, there was objective response. It was better in terms of, objective response. There was 8 complete responder versus only 1 in the sorafenib arm. Partial responder was better stable disease control rate. So in terms, that's why based on this data, the response rate, the PFS, the OS, I think we adopted this, and it's NCCN guidelines. It is category 1 option. This is like a very brief review about, highlighting the side effect that you see on the left-hand side, the upper GI toxicity. Severe one, 17%, the general one as was up to 26%, and adverse event leading to withdrawal was in 22% of these population. And there is also interruption according to the side effect of the associated arm. So the stride regimen, you want to focus about the stride regimen because, why tremelimab only 300 milligram, and this is the biology behind the pharmacokinetic, where they studied in phase 1 and 2 study called the study 22. They found they used different doses of tremelimab, and they found that 300 milligram prime the immune system, and it seems this dose it's associated with the higher survival benefit. So the stride regimen showed the highest efficacy compared with durva and tremi as monotherapy or in combination. So the single dose priming 300 as anti-CTLA4 antibody led to an expansion of the T cell clone, increased T cell proliferations. Then this was, according to this study, associated with the longer clinical response and survival. So the Himalaya study focused a little bit on it. These are adult patients. They have confirmed unresectable SCC. They should have good child score, child A, although in our clinical practice, we see more child score like up to B and C. BCLB not eligible for local regional B or C, no prior systemic therapy, ECOG good performance status, no portal vein thrombosis. And here, upper endoscopy is not required because there is no risk of bleeding, stratification according to the viral etiology, macrovascular invasion, and performance status. The stride regimen about 400 patients, tremi 300 milligram, only 1 dose, and durva then 1,500 every 4 weeks versus durva versus sorafenib. This 3-arm protocol randomization 1-to-1, about 1,170 patients. The primary endpoint was overall survival. So the study was powered enough to show overall survival benefits, secondary endpoint as listed here. And there are multiple testing procedures for OS superiority, non-inferiority, superiority. Then, at the end, they calculate the 36 months overall survival rate for the stride regimen. Baseline characteristic, as you can see, 83% are male. The median age is 65, 60% rest of the world, 40% Asian, 30% viral B etiology, 30% viral C etiology, and 40% non-viral. Very good performance status, majority of the patient, 20% are BCLC-B, and about child A, about 99%, so child B and is not included. The ALBI score, the majority are ALBI 1 and 2, about 90%. Microvascular invasion, 1/4 of this, extrahepatic, 53. And PD-L1 positive was in 1/3 of this patient, alpha-fetoprotein more than 100, about also 1/3 of these populations. So the combination of durva and tremi demonstrated sustained overall response benefit versus sorafenib, and this is the 6-year updated overall survival. And again, sorafenib, it was the standard of care for that time. And you can see there is consistency of result at 1 year, 1.5, 18 months, 2 year, 3 years, 36 months, 45 years, and now at 6 years of follow-up, you can see still around 17% of these patients are still alive. And you're talking about, HCC with some, bad prognostic criteria. The overall response rate, 20 versus 5. And if you talk about, response rate from Nivo Epi at 36, but, the control arm was 13. So it is triple here. If you talk about 20 versus 5, it is even a quadruple the response rate. CR3, partial response 17%, stable disease. And you can see that the median time to response was 2 months versus sorafenib 3 months. And this is very important because sometimes these patients are symptomatic and you need really, a rapid response rate where these patients can you achieve a reduction in the tumor size and you can have relief of patient symptoms. And extended long-term survival were well presented across all clinical relevant STRIDE subgroups. So if you look at the subgroup analysis, the combination was positive irrespective of the gender, race, HPV, HCV, performance status, the BCLB, MIV and EHS, post-discontinuation, anti-cancer therapy, treatment through progressions, and retreated patient with a TREMI and Durva. The long-term overall survival benefit was observed for participants treated with STRIDE regardless of the response. So even, you look at the response rate, you see like, you think like only patients who have CR and PR, they did, survive better. But it seems here in STRIDE, even the patient who achieved stable disease, they survive better. They have longer response and longer overall survival on TREMI and Durva. These are the adverse events. We know that immunotherapy, we build our learning curve how to deal with immune-related adverse event. The majority is related to the thyroid, hypo or hyper, and to the skin toxicity, some GI. But however, in this study, 20% of participants treated with STRIDE experienced immune-related side effect, and the rate of discontinuations was almost the same as other chemotherapy, immunotherapy trial. A checkmate 40 Nivo plus Epi3 proved to have also a good overall survival versus other dosing schedule. But here to highlight, for Epi, they use a higher dose, 3 milligram. And that ipilimumab in combination with Nivo was for longer duration than in TREMI. TREMI was only a single dose. And this is the checkmate 9DW. It was discussed in detail by Dr. Fathi. I'll go directly into the survival curve. This is the overall survival. And I think at the 3 years, there are still 40 patients versus 24. We discussed before the crossing of the curve in the early 6 months, and I think there is an addendum in the Lancet. This was studied again, and it seems the mortality here was related to COVID-19 infection more than any other. So there was higher proportion of patients receiving subsequent immunotherapy in the sorafenib and Limva arm versus Nivo Epi, and this is maybe also attributed to longer survival in the checkmate study. And again, when we talk about overall response rate, 36 versus 13, this is triple, the response rate. But however, in Himalaya and STRIDE protocol, it was 20 versus 5 for the control arm, which is 4 times the control arm. And again, the side effect and discontinuation was more or less the same. And so this is the ESMO guideline for the treatment algorithm. And you can find always that this combination of immunotherapy are available. And till now, TREMI durvalumab is category 1A option. However, Nivo Epi still category 1B. Probably in the futures, with more study, probably will find a difference in the categorization. And this is the NCCN guidelines, again showing that Atezo, Biva, TREMI, Durva is category 1 option. And you can see the other recommended regimen there. At this point, I stop and thank you very much.
Thank you, Dr. Arif, for the very nice presentation. And moving forward from the HCC, we have the next workshop, which is being sponsored by Novartis, and we're talking about the Pluvecto and MCRPC. And first presentation is by Dr. Said Hamad, who is going to talk about the clinical evidence of Pluvecto and metastatic castrate-resistant prostate cancer.
Thank you very much. I know you are all very tired now, so I'll be as quick as possible. Okay, so I was given a task to talk about role of lutetium in the MCRPC. I'll be quite brief, but we'll focus on what is practice changing soon. Okay, my disclosures. Just to say, we used to think prostate cancer is not that common here, but it's the second most common cancer in UAE. So it's not that uncommon. So lots of advances, thankfully. And as GGU oncologists, I think it's been amazing last 10 years for us. And the treatments that are available that have changed the lives of the patients, I think it's really, really amazing. I remember during my training, we used to get prostate cancer with cord compression. We don't see that anymore. I think that is one remarkable achievement. So focusing really on radioisotopes, we had radium-223. We started using it in Birmingham, but it was quite limited number of patients we could treat, and it was not then available in the GCC radi, so we couldn't have much experience here. And then lately we had gallium imaging become available, and that changed a lot. That changed a lot in many aspects in terms of how we stage our patients, how we assess response to therapies, and how now we can actually assess this patient for newer treatments. I think it's been really amazing. And then we had in the clinic the lutetium PSMA available for our patients. So natural history of the disease, I will not focus much on this. You're all well rehearsed in this disease area. So we're talking about patient with CRPC, but we hopefully in patient with hormone-sensitive disease, Pluvecto may start to become an important factor in those patients as well. So when I see a patient in the clinic, you may have seen this slide before. So when I see a patient at my clinic who have progressed from metastatic hormone-sensitive to CRPC, what I'm looking for, what did they receive first line, doublet versus triplet, what was the duration of the first line of therapy. I think it's really important to remind us as well. Of course, do molecular profiling, find out if they may be suitable for newer treatments as they're moving in early lines of therapy. PSMA uptake I marked, I think it's really important. So every patient, really, if you have opportunity, do a PSMA scan. I think it's really, really important. If you have any concerns about neuroendocrine features, especially if the PSA is low and then you're not taking much uptake, try and do a biopsy, convince your surgeon, please take a biopsy or interventional radiologist. You'll be surprised what you find. Extent of disease, I think that's also important. When your patient is progressing, is it just oligoprogressive disease where I can ask my radiation oncology colleague to burn that area or weld that area, or is it systemic disease? I think that's important. So I think these are important messages. So indications for PSMA, you know very well now where we use it. A lot more indications now than we had before. But today we are really talking about how we're going to use this imaging modality for patients in the clinic. Thankfully, PSMA target is expressed on 80% of patient with prostate cancer, so which is making it quite universal for our patients. So we can use it for majority of our patients, not that selective, so that's good. And the radioligand therapy obviously then works against this target, a target which is available 80%. So you don't have to do a biopsy, just do a scan, non-invasive, you can give them a targeted therapy. So targeted therapy just by doing a scan. I hope more of those treatments are available in other tumor sites as well. I remember I was in an NCRI meeting 10 years ago in Manchester where they were talking about similar sort of scans for breast cancer, for renal cancers, but never really took off. So I don't know where those studies are now. But, so, at the time they were talking about bringing those scans for different tumor types. So this is a summary of the 3 trials. We'll just focus on one of them really, but obviously the vision is a landmark study. It's really put Pluvecto in the treatment armamentarium. Obviously, these are the patients who were heavily pretreated, received an RP and chemotherapy, and this trial did show a survival benefit. So this is the publication of the study, and just to remind you, and the survival outcomes. So we had a very positive radiological progression-free survival, and as well as overall survival. So that really changed the practice, and we've been using Pluvecto since. But obviously, as things happen, we are trying to move these therapies earlier on. So that's move us to PSMA-4 study. So very important study, really. These are the patients with progressive disease who have already received an RP, but have not received taxane. So that's the differentiation here. So these are the patients who have received an RP. And this RP could have been used in CRPC, or now as we use in metastatic hormone-sensitive prostate cancer, randomized 1:1 into 2 arms. And obviously, people sometimes say maybe it's not a fair comparison, and that you just change the RP. But obviously, this has been done in all the trials that we treat currently of taxanes, for example, or other treatments. So all of the trials that control have been as such. The primary endpoint is radiological progression-free survival, and then we have key secondary endpoint including overall survival. These are the baseline characteristics. No surprises here. The only thing I noticed that was in the next slide actually here, that many of these patients actually had surgery or radiotherapy as an initial treatment, which may be different slightly than in our region where we see more de novo metastatic disease. I think that may be a differentiation factor here. And the RP use was split between abiraterone and enzalutamide, more enzalutamide than abiraterone. So this is the third interim survival analysis. We see a very positive overall, hazard ratio 0.49 favoring Pluvicto. Really important results. So it is really working early on for our patients, and we obviously are starting to use this in our clinic already for patients who may not be suitable candidate for taxane chemotherapy. We can have a discussion about this, and all subgroups are benefiting. So there's no heterogeneity, which is nice to see in the study. As overall survival, obviously there's a critique that we do not see a survival, but many patients actually crossed over. So that may be one of the reasons why we do not see a survival advantage here, because these therapies are now available in the clinics and you can use it. Although we don't see a survival benefit, we do see very important key secondary point improvements. See a PSA response. PSA is really good. Every patient, when they come to the clinic, they ask you a PSA. So it's important really, and then we can talk to a patient, tell them what the response they're getting. So very good PSA responses. In terms of time to PSA progression, also significantly delayed. So very good, clinic every 3 monthly you will have after you give a treatment which is effective. And in terms of objective response rates, we see complete responses, which we never really saw in patients with CRPC. This is amazing. Quality of life, I think that's what it differentiates us at this stage, because at this stage, we normally would use chemotherapy, and instead you're using a therapy which really improves their quality of life. I think that's really good as well. So when you discuss with the patient between the choice of having chemotherapy or Pluvicto, clearly what we see significant improvement in quality of life for these patients has a ratio 0.61. And they look at the brief pain in inventory again, that is better. So pain improves. What about EQ5D? It's a well-known measure in 5 dimensions. Also, this is positive. So patients are doing better, and not just having their disease control, but feeling better as well. Safety outcomes. Obviously, we have experts here who will tell us better in terms of what the safety results are, but overall toxicity is less. And the mean dose they have used up to 42 gigabecquerel and exposure up to 9 months for these patients. Grade 3 and 4 toxicity, if you look at it, actually looks less than an RP change, surprisingly. What are the side effects? Dry mouth and some GI upset. And obviously, we do see some myelosuppression as well in our patients. Time to first skeletal event. This is also delayed, although we do use bone modifying agent for these patients in this setting. So these are the conclusions from the study. So obviously, it has shown to be a positive study, positive RPFS, improvement in quality of life. We do not have a survival difference, but that may be due to crossover. And with this, I'll conclude my presentation. So MDT is really important. That's what I put it here. I think the decision for our patients should be discussing MDT. It's important that we have nuclear medicine colleagues should be present in MDT, which remains a challenge today to bring them into our MDT. But I think that's just something we need to look forward in 2026. And these are my takeaway measures. I think I've described all of them already. Thank you very much for your time.
Thank you, Dr. Hamad, for your presentation. I know you have another meeting, so we'll go forward with our next speaker, and we're happy to have Dr. Manir Ghassani, who is the Chief Medical Officer of the United Theranostics Associate Professor of Neurosurgery and Radiology in Mount Sinai, USA. He's going to talk about the predictors of response of Pluvecto to metastatic CRPC.
Assalamu alaikum and good evening. I know I might be the only one or maybe one of a few but sitting and standing here between you and the dinner. So I'll try to be quick. And Dr. Hamad set me up very nicely for a lot of material that needs to be reviewed before we actually go deeper into the treatment response assessment. And so I'll try to be very quick and go through a lot of data, although it's important to make sure that we drive through the key data which actually help. As Dr. Hamad mentioned, now there are so many options, and it is exactly where a proper selection is going to be very important in finding the ideal candidates who are going to benefit from lutetium PSMA therapy. A couple of words on theranostics. One of my very close friends, John Boscombe from London, actually coined this term in 2004, and then ultimately with Frank Hauser, he originally did that, and ultimately, in fact, presented in EJNM 2019. So the idea there is that you are using a treatment strategy that combines diagnostics and therapeutics. So the diagnostic agent is first picking a target. And then in that target, it finds whether the patient is going to benefit from that treatment. And then using that target, but switching the isotope is when you actually deliver their therapy. So what are the different components? Is a diagnostic component is confirming not only the presence, but also extent of disease. It's very important. That keyword is extent. If you find that in addition to intensity, it's homogeneously expressed across the tumor sites, it's going to be a very strong predictor of response. And then once you have found that, you want to make sure that you deliver that treatment at a maximal level to the target and avoid the organs at risk as much as possible. So here's the schematic of it. And basically, all of these components are the same. So you first find in the lab a target that's expressed. So in this example, I'm putting somatostatin receptor 2, but it could be PSMA. You have a vector, and then you have a linker, and you want to have a diagnostic agent that confirms the ultimate expression. Once you have confirmed it, all you have to do is find a therapeutic agent. In our case, it's lutetium-177, and deliver that treatment after the fact. So as you already saw in the presentation of Dr. Hamad, that this is the PSMA receptor, and there's a majority of it is extracellular, some transmembrane, and even smaller is cytosolic component of it. So let's now take a deeper dive into the treatment response assessment and what are going to be the predictors. So first we'll look at baseline PSMA PET. As I mentioned, the theranostic concept requires that you do diagnostic imaging first. Obviously, we assume that these patients have to have a PSMA PET first. What you look for is the total tumor SUV mean. At least in these studies, which are, I'm including the ones that are all the way to most recent ones, the total tumor SUV mean is the most robust. What is the problem with that? The problem with that is that currently, despite all the AI that we use in radiology, we are still far from optimal. So if you look at the list of AI products that are approved in US, there are about 1,100 as of about a few weeks ago. Out of them, about 85% are in radiology. So you know radiology is taking the lead in development of AI, but when it comes to this particular aspect, even though we use the AI to start off, it still takes about 15 to 20 minutes of our time per patient to refine that total tumor SUV mean. I think in the future, once it is refined, hopefully in another 2 to 3 years, this will become the most predominant use. Currently, it's still something that needs to be desired in terms of its development. That brings us to more practical use, which is two of them, the SUV mean and SUV max, which I'll now go through it. This is very quick. It takes seconds to put that cursor on a lesion and you get the SUV mean and max, which is why in a day-to-day use, this is a much better option than total tumor SUV mean. And again, it showed a significant response. And in fact, I'll go through a little deeper on these. If I have to spend just a few minutes on these slides, it will be more important than many other slides, including the case examples. Of course, I'll show that to you, but this is a very, very important factor. And our colleagues in Australia and my colleagues in US have been remarkable in showing how powerful this is. So if you get a very high SUV mean, in this particular one, greater than 10.2, the median RPFS was 14.1 months, versus lowest quartile, less than 6, it was less than half. So always, if you're referring a patient for a potential candidate, ask for these numbers, because it will help you a lot if this patient needs and benefiting from lutetium-177 PSMA versus other forms of therapy. Same way as SUV mean, very high PSMA expression. Both are reflecting high PSMA expression. And it is much more predictor of treatment compared to cabazitaxel. And Louis Ahmed, my colleague from Australia, has taken a lead in some of these developments of how you can differentiate the response assessment even before you start the treatment. Threshold consideration, so the mean of 6.9 did not show superior response. So always look for that. While this is not very common, it may happen in a minority of patients, but it's important to select out the patients who will likely benefit from other options, including PARP inhibitors, chemotherapy, and other emerging options that are coming up. We, in fact, have, and thanks to Novartis, I'm a co-chair of Mars Shot Foundation for research. And so far, we have given about $6 million in various research projects. The highest amount, which was $1 million, was given to Amir Iravani at Washington University. And that's where it was thanks to Novartis support. We are picking out these patients who have a lower expression and giving them rapid 2 doses rather than waiting for 6 weeks apart to see if we can turn that signal to a higher expression by giving 2 front loading of lutetium PSMA. If that's successful, in a few years from now, we might be showing you something different approach. But at the moment, we are still looking for lower SUV mean as a not good candidate for these therapies. SUV max is also predictive, but less than SUV mean. And then NCCN guidelines, which we follow in US and internationally, of course, they are followed as well, also summarizes here in 25, just last year, that if you have a USA recommendation of SUV mean to identify patients who will derive less benefit from, although I grant that this is not very common. Most of the PSMA expression in prostate cancer patients will be at a higher level of SUVs in patients with prostate carcinoma. Total tumor volume is highly prognostic, as I mentioned, but the issues are the AI in deriving that. By the way, if we are using 20 minutes with AI, if you ever have to do it without AI, it's about 45 minutes of time per patient it takes to derive that total lesion. Number of PSMA lesions are also independently associated with survival outcome in Lancet. Now, what do you do if your patient is referred from somewhere else and you don't know what qualifying scanner they may have used for that? Or even worse, if you have one scan done from somewhere else and now the second scan is done with you in your institution or somewhere you know, one way to get around that from scanner variations is actually looking at tumor to salivary gland ratio. This it corrects for the differences in the scanner. So you can actually look at that ratio and see how powerful it is. Is that ratio maintained from your prior scan to the current scan? That again is going to help you in making sure that patients have continued high expression of PSMA. Heterogeneity and intensity of tumors, we follow these quite often. If there are heterogeneous areas, and if there's low expression or a cold area in the liver, for example, we know those patients do not respond well. So look for those signs as well. Bone metastases generally show inferior response, not necessarily inferior absolute level, but inferior compared to others. So I just don't want somebody to walk away from the fact that if somebody has bone metastases, they don't benefit from lutetium PSMA. In fact, I'll show you my own examples where all the bone disease have been wiped out using the PSMA-4 data in those patients. So not that they don't respond, but relative to the lymph nodes, they are slightly less responsive. And here's that data. So lymph nodes respond better. I'll again emphasize that point in another slide, that lymph nodes in generally achieve a highest absorbed doses. Why? Because if you look at the radiation biology, the bone lesions have dense material because it's a calcium. And so as a result, for the radiation to penetrate, you need a higher degree of radiation. Lymph nodes are soft. And per volume, the amount of radiation gray dose deposited is generally much higher in the lymph nodes. Visceral metastases, particularly liver, are independently associated with worse response. So my recommendation would be that if you are getting a PSMA PET for consideration of lutetium PSMA therapy, look for liver metastases. And particularly if they are heterogeneous, those patients are one of the few who will not respond that well to lutetium PSMA therapy. So response rates were only 30% versus 50% without the liver involvement. Major difference. Again, emphasizing the point that lymph nodes are generally very nicely responding to lutetium PSMA therapy. Now, what do you do if there is a heterogeneity? We are generally successful in US insurance system where we have to appeal for FDG PET because they have already approved PSMA PET. But if we tell them that FDG PET is a very good prognostic indicator, also helps in patients who don't respond well, they generally approve FDG PET. So in a selected patients, using the FDG PET will be very important, not only in selecting patients who don't respond, but also their prognostication, because if there's a high degree of FDG uptake expression, many of these patients may have neuroendocrine or other differentiations of prostate carcinoma. Only meaningful association is when there's early rise or stable PSMA. So this is one of the things we do. If the patients have early rise of PSA, we don't stop the lutetium PSMA therapy. We'll still give one more, but consider FDG PET. And if the FDG PET is negative, continue your treatment. That mismatch is very important in looking for that. So NCCN guidelines also say this is what we use to get FDG PET approved, because once we send that to the medical director of the insurance company, they accept the fact that these need to be treated appropriately by doing the FDG PET in them. So they mentioned that in their multiple publications that you need to consider that dual tracer imaging in the appropriate cases. The changes in the total tumor volume is also very prognostic. And we use the AI because there, the total tumor assessment using the AI alone, the differences between first and second are corrected by the fact that AI is not perfect. So there you can use the 2-cycle differences and figure out if there's a major change in the tumor volume. Very strong predictor if that happens. And we routinely do SPECT-CT. In fact, we do it 4 time points, and we are trying to do a study to figure out if only 1 time point after each cycle will be sufficient. But that has also been shown to be predictor after second cycle for treatment response. And then changes in the SUV max and mean are less helpful compared to other data. And then scintigraphic response using the SPECT CT after first cycle is also a very strong predictor for all of these: PSA response, progression-free survival, as well as overall survival. This is a key publication that really emphasizes that point. And then as a result of this, NCCN guidelines have also incorporated post-treatment SPECT or PET imaging. In terms of patients, you saw Dr. Hamad show some of the data about the blood work and labs. Very important to make sure that you follow that some of the parameters are known to have poor outcomes. So very low hemoglobin is associated with poor outcome. Not only it's a reflection of their poor, comorbidities, but hemoglobin carries the oxygen to our tumor sites. As a result of it, a higher free radicals are created with a higher hemoglobin. So important to make sure, and if necessary, you should consider blood transfusion for these patients as well before you administer, if they are clinically indicated, before you administer lutetium PSMA therapy. High alk-Phos and LDH, also markers of worse outcomes. And prior chemotherapy exposure, which is why we currently follow the PSMA-4 data, because it also helps in figuring out which patients are going to be more responsive with less morbidity. So giving these treatments earlier is also critical. Circulating tumor DNA, I saw some of the earlier presentations about ctDNA. It can also be used in our prognostication as well. And here's one study just last year showing that the low pretreatment ctDNA fraction predicts superior biochemical response. Genomic alterations, you saw Dr. Hamad mention some of those. We also use them because these are associated with diminished response as well. So NF1 and FOXA1 are associated with favorable outcomes on the other hand. Quantitative analysis outperforms visual assessment. As I mentioned, it's still in evolution using the AI and refining the AI. Consider alternative therapies if the mean is in the lowest quartile or if there's extensive visceral disease, particularly liver disease. Don't discontinue. This is very important. Just because you have done a PSA and after first cycle it went up, don't discontinue, because look at this, 44% achieved the PSA 50 response on the subsequent cycles despite early rise. And I think there is something to say about the lutetium PSMA resulting in pseudo elevation of PSA after the first cycle. So optimal patients, this is the key summary: SUV mean more than 10, high tumor to liver ratio 1.5 or higher, absence of particularly cold hepatic metastases, and no FDG positive PSMA negative disease. If you consider these, this is a key slide. And if you have all of these parameters met, these patients will be very responsive to your lutetium PSMA therapy. So now that you already have seen the other data, I'm going to fly through these in the next 3 to 4 minutes so I can try to save you some time. But this is why we are currently giving these treatments early on. Shift from survival urgency to quality of life, because these patients are in the early stage. So you're not looking at patients dying in a few months. You need to be mindful about their quality of life. Cumulative toxicity, again, in the longer treatment window, you have to keep in mind that it's 8.4 months versus 6.9 months with vision trial. Key points in each slide I'll try to summarize. These patients have baseline bone marrow reserve and sparing the future options. So if they need to give chemotherapy after the lutetium PSMA therapy, something to keep in mind for bone marrow reserve. If they have a low volume disease, normal organs may end up getting higher volume treatment. So again, keep in mind, although I have to say majority of the patients, including the ones that I'll share with you, had actually higher volume disease despite the fact that they never had received chemotherapy. Those patients will do better with your treatment. So let's now share that real life experience. This patient is an 86-year-old male, Gleason 8, 12 years ago, radical prostatectomy, rising PSMA. Rising PSA and PSMA PET shows oligobone metastasis. And then the patient has rising PSA again. Patient also got ENZA and depolupron, no prior chemotherapy. And this is this patient's PSMA PET. Extensive skeletal metastatic disease. This is what I was referring to, that the bone metastases relative to lymph nodes respond less, but you will see in the subsequent slides how powerful these patients respond anyway. So here's his pre-cycle PSMA PET. 3 cycles later, it's all gone, all of it, except the left shoulder area. Everything else is completely gone away. And I'll show you individual lesions. Generally in radiology, we say that if the density of the CT increases, you have to worry about metastatic disease progression. After using the PSMA PET, we have learned that that's not the case. Look at the CT density here as opposed to here. It got denser, but that's a healing response. The reason being that this is a key marker. All of that intensity of uptake is completely gone. You put this and this together, that means that increasing density is a marker of remodeling, not progression of disease. Same thing here. Look at this density. The density went up, but the uptake is almost gone there. Another example right there. And then, so his PSA now is undetectable, no adverse effect. And in fact, he finished 5th cycle by the time I come here. This was prepared a few months ago. And excellent quality of life. This summer in 25, he asked if he can go to hike. He's originally from Switzerland. And I allowed him to go. I said, you have to be mindful. You have to go between your 2 cycles. So I planned it in a way that he doesn't get harassed at the airport carrying a lutetium inside of him. So I planned it 3 weeks after his cycle. I said, now you can go to Switzerland. Went hiking with the family all the way to the Swiss Alps. Very good quality of life. Another example, 81-year-old, Gleason 4+3/7, PSA 79, metachronous high volume metastatic disease, congestive heart failure. He has comorbidities as well, coronary artery disease, LAD stent, no symptoms from current treatments, which is good. Here is his PSA trend, low volume PSA, but it's rising serially. An extensive metastatic disease. Now, 2 cycles later, his individual intensity starts to go down. I'll show you, here's where I can show you why we use the mean and maximal SUVs. Each one of them has about 30 to 40% decline in SUV values after 2 cycles. So this is a good marker because you can imagine if I had to do a manual ROI for total lesion tumor burden, this would be about an hour worth of work. But here, the SUV mean and max are a matter of seconds, we get that. Third case, I'll end with this case, extensive treatment history. And he gets now, after all of these treatments, the PSMA PET, and it shows extensive disease. I mean, look at the degree of SUV values. This is about 50 to 55 SUV in his prostate bed. And just 2 cycles later, almost everything is wiped out. Again, soft tissue. Because the delivered gray dose in the soft tissue is so high, his disease in the prostate is almost gone, and multiple levels as well. There were at least 4 sites in the prostate. They all, you can see from here to here, they all disappeared. In addition, he also had bone metastases. They also disappeared. So look at this lesion here, and there's no uptake there after 2 cycles. This lesion here, completely gone after 2 cycles. So in conclusion, very established strong efficacy in advanced disease with vision trial, demonstrating 15.3 versus 11.3 months overall survival advantage. Expansion to the earlier stage, PSMA-4 trial, shows that taxane-naive patients who have progressed after only one ARPI, that led to the FDA approval just about a year ago in this particular setting. Favorable safety profile and quality of life associated with specific side effects like dry mouth, nausea, fatigue, and superior safety profile compared to hormonal therapies, and undetectable levels and excellent quality of life. The power of theranostics using that PAIR technology, it's applied in prostate cancer, but it is going to be applied in the others in the future as well. Thank you. I am 20 seconds ahead of my schedule. Thank you.
Thank you so much, Dr. Munir. This was really interesting, and we'll be having a nice discussion hopefully at the end. Next, I would like to welcome my dear friend and colleague, Dr. Dalia Shorvagi, who is consultant medical oncology, previously in Dubai Hospital, currently in SSMC, and she's going to present one case.
Assalamu alaikum, everyone. Thank you, Gina, for the kind introduction. Thank you, Novartis, for the invitation, and congratulations for the Dubai Hospital team for the great event and meeting. So my patient, he's 70 plus years old, male patient. He's not from UAE, he's from Sudan. He presented in 2022 with urinary-related complaints and back pain, had MRI done in the country he was living, and it showed multiple bone metastases and prostatic enlargement. His baseline PSA was around 1,000 and had TURP biopsy from the prostate, and it showed confirmed it to be a prostatic adenocarcinoma Gleason 4+4. Baseline PSMA at that point showed the prostatic lesions, multiple bone mets, multiple lymphadenopathy. In September 2022, started in this country on Casodex, Soladex, and denosumab, and he was in regular follow-up, and his PSA dropped to 3 in November 2023. However, in 2024, the patient was admitted. He came to UAE with he was living with his family here, and he admitted to the medical ward with generalized body stiffness, recently, severe back pain, bilateral, especially in the shoulder, in the neck and limb. Also experienced weight loss in the last 2 months with poor appetite. And this is his scans in July 2024. Entire spine studied with as well as the pelvic bone, sclerotic lesions, and there were no pathological compression seen. So pathology reviewed at our hospital, and it confirmed the same diagnosis of adenocarcinoma 4+4 in up to 85% of the biopsy with perineural invasion positive disease. At this point in 2024, his BSA was around 230 and testosterone level was 0.4. And the patient was discharged from the medical ward as a case of metastatic castrate-resistant prostate cancer to bone failed on endocrine therapy with elevated HRH and hyperthermia. So his baseline PSMA at our hospital was done, and he started in second-generation androgen receptor inhibitor plus ADH. And this is his baseline PSMA. As you can see here, widespread bone metastases all over the skeleton and as well as the pelvic bone included. So the patient PSA initially started to drop on second-generation novel hormonal agents, and by time, unfortunately, it started to rise again by the December 2024. And we did in December 2024 another CT scan that showed disease progression. As you can see here, widespread disease progression, mainly involving the bone. So the patient started at this point of time on the Pluvecto. He completed 4 cycles as per May 2025 with significant drop of the PSA, clinical improvement of the physical activity, less pain. The patient is back to his physical activity, and as you can see here, this is the the scans after 4 cycles of Pluvecto as per May 2025 in comparison to the initial one, as you can see here. So there is a very significant response in terms of disappearance of almost all the bone lesions after 4 cycles of Pluvecto. With that, I think this is my last slide, but the only thing, the BSA also significantly dropped over about 3 months from starting the Pluvecto therapy, and more importantly, as we just heard from Dr. Munir, that also the patient adverse event, and from Dr. Said Hamad, the adverse event, it was quite tolerable treatment without significant drop of the platelet or hemoglobin count. And with that, I thank you so much for your.
Thank you, Dr. Adalia. Next, I would like to call Dr. Ahmed Dawood, the Chief of Medical Oncology in Dawam Hospital, and he's going to present the second case.
So, good evening. I think I have a very long case. It might take 30 minutes, so be patient with me. 25 minutes, okay? So I'll make it short. This is a case with just people sleeping. It's a case, common case between me and my dear friend, Dr. Jawar Ansari. So it's a very interesting case. So this is 58-year-old male, diagnosed 2018 with local advanced prostate cancer, clinical T3B, N0M0, glycemic score of 9, patient young and fit, ECOG performance status of 0, no comorbidities. So patient had radical prostatectomy, bilateral pelvic lymph node dissection, pathology came PT3B N1, and there is a positive margin lateral margin. For that, patient received adjuvant regen therapy and Zoladex. His PSA was decreased to 0.02, and during follow-up, we found that the PSA started to rise, CT scan showing indeterminate lung nodules, and should we consider this biochemical relapse? Should we consider this as metastatic disease? But patient started on enzalutamide, was seen significant drop in the PSA, but over time, the PSA started to rising again. So PSMA scan show it, there is a multiple PSMA with peritoneal nodules, mediastinal lymph nodes, as well as liver metastasis. So liver biopsy being taken just to confirm this is prostate cancer. There is no any neuroendocrine differentiation. So it came to prove this is metastatic adenocarcinoma prostate primary, chromogranin and synaptophysin both negative. So the question is, with this patient to go for docetaxel chemotherapy or PSMA lutetium therapy? We know that in many settings, we consider docetaxel as universal, a gold standard in castrate-resistant metastatic prostate cancer. But what in the reality that less than 50% of the patient, they receive docetaxel. Most of the patient might receive novel hormonal therapy, where we know that the activity in novel therapy, hormonal therapy after hormonal therapy usually is not the best option. So what to do in this patient? We considering the lutetium PSMA therapy, and we noticed that there is significant drop in the PSA through the treatment cycles, and by cycle 6, you can see how significant response in the liver. It's almost disappearing of the liver metastasis. The same as you see here, excellent response. The same, another cut, and for the pelvic lymph nodes, peritoneal deposit as well. So we have an excellent response with a good tolerance. This is the hematological toxicity. You can see very well tolerated, and we have only grade 2 thrombocytopenia and grade 2 anemia. Thank you.
Thank you, Ahmed. Next, would like to call Dr. Muhammad Farouk, consultant medical oncology Dubai Hospital, and actually the president of the PMOC. And he's going to share with us one case.
Thank you, Dr. Ahmad. Will take maybe 10 to 15 minutes for my case, so please bear with me. Let's move forward. So this is going back nearly 5 years, 6 years old gentleman presented to emergency department with few months history of fatigue, weight loss, bony pains. Medical history included diabetes, he was hypertensive, hypercholesterolemia, and ECOG PS at the time of presentation was 2/3, so not really fit at that time. So in the emergency, these are her labs. Blood count were normal. He was in acute renal impairment with creatinine of 9.5. This is actually 9 times higher than normal. Derange electrolytes, and PSA was done, and it was 231. So emergency doctor arranged an ultrasound AP, which reported obstructive uropathy. He underwent bilateral hydronephrosis on ultrasound, enlarged prostate, and he had bilateral nephrostomy inserted. So significant improvement in renal functions after nephrostomy, and then he had a prostate biopsy which confirmed adenocarcinoma, Gleason 4+5=9. So then he had a staging PSMA PET scan, which, as you could see, he had multiple bone metastases, lymph node metastasis in the left para-aortic region. So in summary, so this is 68-year-old gentleman, poor performance status. He was quite symptomatic, high PSA, Gleason 9 prostate cancer, high volume disease. So he was started on first-line therapy with ADT plus enzalutamide at that time. So this is just a response assessment scan. The top 3 slides are from the staging scan, and the bottom 3 are after 4 to 5 months of therapy. As you could see, this has been significant improvement in the bone lesion as well as in the uptake in the left para-aortic lymph nodes. And this is what we would normally expect in prostate cancer, starting ADT. More than 90% patients had quite significant and rapid response in terms of PSA. So pretty quickly, his PSA normalized. Moving forward, this was his PSMA PET scan this time last year. Continued to have an excellent response with no PSMA avidity in the bones on the PSMA PET scan. Around July last year, as you could see, his PSA slowly started to go up, and his PET scan reported a lesion in the, I think this is T12 vertebral body. So slowly rising PSA. This is the only lesion which was progressing, and the rest of the scan was stable. So we sent him for palliative radiotherapy. So it was a T12 vertebral body lesion. As I said, the rising PSA, we sent him for palliative radiotherapy and decided to continue enzalutamide plus ADT, and molecular profiling was requested. So he's progressing at this stage slowly. So further follow-up, this was earlier this month. His PSA rapidly went up, and this is his most recent scan from December last year. About a month ago, as you could see, there are multiple metastatic bone lesions, clearly progressive disease on ADT plus enzalutamide. So this is his foundation liquid results. So he has HRR mutant disease. And so just a summary. So elderly gentleman, high risk, high volume prostate cancer in 2020. So he was on first-line therapy for almost 5 years. Some progression 6 months ago, we gave him some palliative radiotherapy. Didn't really respond much. PSA continued to rise. And now he has significant progression on the PSMA PET scan, HRR mutant, ECOG performance status around 2. So what is the most appropriate next treatment options? I have a number of questions. Should we give him palliative chemotherapy? Should he continue enzalutamide and add a PARP inhibitor as he has HRR mutant disease? Should we switch abiraterone enza to abi and plus niraparib? Consider lutetium therapy, or we can add number 5 as a single agent PARP inhibitor. So I think we have experts in the panel, so we can discuss this in the panel discussion. Thank you.
Thank you, Dr. Farouk. I will invite the panelists, please, to come to the podium here. Dr. Dalia, Dr. Munir, and Dr. Farouk, please. So I think you raised the question, so you left us to answer. Huh? So I will start with Dr. Munir, and he's been mentioning since yesterday that about the MDTs and discussions, and such a patient when you see in the MDT.
Yeah, so based on the data that I shared and earlier Dr. Hamad had mentioned as well, knowing that this patient has disease progression in the previously treated site with a very rapid decline in the previous site, but currently given the data from PSMA4 while watching for the adverse effects, I think this patient could be a very good candidate for lutetium-177 therapy. Of course, that's not the only option. You have multiple other options, including the mutation-driven therapy with PARP inhibitors as well. But I think, one of the options clearly is lutetium-177 PSMA therapy would be very, very effective. Bone lesions in general, as I mentioned, because of their density, may not get the best response, but that's theoretical. In real life, we find that, as I showed you, those examples that I showed with you, they're not exceptional. Many of them actually bone lesions respond well. So I think this would be a good candidate for lutetium-177 PSMA.
I guess the next question is, would you sequence after progression on lutetium therapy, would you sequence with the PARP inhibitor or ARPI plus PARP inhibitor? What would
Yeah, that's a good point. And the other thing I didn't get a chance to mention in my presentation, but since we have now experience going back to when Endocyte started these trials and then Novartis subsequently acquired Endocyte, is that there are some preventive measures that we usually put in our practice. And the idea there is, as I showed earlier in my presentation, that you need to be mindful that sequencing is important. Just because you're giving the lutetium PSMA earlier doesn't mean you need not to consider the need for additional therapies down the road. So the bone marrow support, dietary changes, preemptive hydration, as well as we have some of the biotin and other measures over the counter that patients use to make sure that if the sequencing wise, if later on chemotherapy, PARP inhibitors, combination, if anything is necessary, that you leave that reserve available for these treatments.
I'll ask Dr. Jawahir. He's not our panelist, but actually Ahmad has mentioned the case, and I think you were on board with this case. So, and also the panelists. The patient was a metastatic hormone-sensitive prostate cancer, turned out to be mCRPC. But we can see that his PSA was increasing, and the PSMA was positive. So we have two factors here. Do we really need biopsy from the liver? It was very clear. PSMA positive, PSA is increasing. What is the possibility that this lesion might be a neuroendocrine tumor?
So it's hard to say which patients develop neuroendocrine disease. This patient at that time had rapidly progressive disease, and in our clinical practice, it can be heterogeneous as well. Although there was PSMA avidity, I am biopsying the liver for all these things. And for us, it's been a steep learning curve the last 3 years with PSMA scans as well. I found a lot of heterogeneous disease as well, and I've got many instances where I've been proven wrong as well. So for this patient, for instance, you would expect very aggressive pattern. Patient is still alive actually, and subsequent line therapy, I was still planning cabazitaxel for him. He's been running away from cabazitaxel, although we've had it ready for him for the last 2 or 3 months. So you would expect that by now, I mean, he was actually the first patient in the GCC and the Pan-Asia area actually to get Pluvicto, and he's still doing fine. I mean, he has progressive disease now, but he's still alive and potential for further therapy. The question is, yes, I would still biopsy if I get another patient now. Anywhere, his PSA was not very high. The graph looks quite dramatic, but it was only around 10, 15, multiple liver metastases. patient PS0 at the time I did the liver biopsy. In fact, I recommended chemotherapy for him at that stage because the data from PSMA4 was quite early on, and we still had the mindset at that time that any liver mets equals chemotherapy. Of course, the patient refused chemotherapy, so that emboldened me to consider Pluvicto for him. And I'm pleased to note that despite the odds of 30% against 50%, he actually responded really well. But at the end of it, it gave him a good 6 to 8 month period where he was asymptomatic, performance status 0. This is a good example, really, and he wanted to consider it again because he did so well on it. So I'd be happy to do the same thing again.
Can I ask a question to Dr. Jawahir also and Dr. Munir? So the same patient, your patient, Dr. Jawahir, with appearance of new liver lesion, did you consider FDG PET together with PSMA for this patient?
So I didn't find that that would add anything different. For instance, even if I had 2 or 3 FDG avid lesions which were not PSMA avid, I would still give him Pluvicto purely because I'm not attempting a radical curative treatment. So if I still had a couple of FDG avid lesions, they may have been excluded from the clinical trials, but from a clinician perspective and day-to-day scenario, I would still treat the patients even if there were a few PSMA non-avid lesions which were FDG avid. It doesn't change my treatment plan. So I would not do FDG PET, and I would consider treating the PSMA avid lesions. The PSMA non-avid lesions or the FDG avid lesions supposedly can be treated by a subsequent modality. It's not curative. At the end of the day, it's palliative therapy. So if I treat 70 to 80% of the disease, I'd be happy with that.
I think that point is so critical, and I can actually give you an idea of the current state and where we are going in the future. Hopefully, we'll have more solutions. So FDG PET, and I understand no matter what part of the world you go, you already have done one PSMA PET, and the economics of imaging is something you need to be mindful of, right? Uh, Here, there's a different scenario why you need to be restrictive in use of imaging. There's a different scenario in US where the insurance companies drive these decisions. So my recommendation would be use what you have available to the maximum. And to that point, there are, in fact, markers on the PSMA PET that can tell you 3 things. One, could this be a neuroendocrine dedifferentiation that can be potentially picked up by dotatate? Another one picked up by FDG PET. And third, is there a cold area on the PSMA PET that will be helpful to you? So if you find, and always consider reviewing it with the nuclear medicine physician or radiologist, if you see a liver lesion and if there's homogeneous expression across the board, that's generally a marker that you're not going to have neuroendocrine dedifferentiation. That dedifferentiation occurs when there's a small cold area. That's one of the earliest markers that tells you that this patient may be progressing to neuroendocrine. This is a current status which we use it maximally, and in our experience, a number of patients, even despite the liver lesions, as long as there was homogeneous expression, we had the response similar to what you showed on case number 2 earlier, where the disease responds to the lutetium PSMA therapy or Pluvicto. Now going back to the future, what we are working on, as I mentioned, my Marshot work. One of the other grant that we give is given to Stanford University, where they are designing a PET system that can, with single acquisition to the patient, can acquire multiple biomarkers. So imagine 5 years down the road, if the system is successful, in one exam, you can get a PSMA, dotatate, and FDG all in one sitting using different signal markers. And then you can put it together and say, well, it's purely PSMA avid, no dotatate, no FDG. This is not a neuroendocrine differentiation.
Ask a quick question, practical question. So what do you do by cycle 3? I mean, sometimes I find the post-therapy scans can be quite hit or miss, really. They sometimes look quite good, and I'm not sure if sometimes got to do with the timing of the post-therapy scans as well. So if the post-therapy scans are consistently looking good, but the PSA is rising, what do you do by cycle 3? If you've got a PSA rise, but post-therapy scans look fine.
So that is one of the strongest indicator for FDG PET. And in our case, we go to the insurance companies and we tell them that, look, you have to balance out the patient's future treatment needs against what is the current status. And if you don't know that status, you're going to drive spending money in a wrong direction. Patient will suffer, the outcome will be worse. And then so we prepare a script, and I usually send it along with the approval request. And if necessary, then I go on a phone call and appeal that too. I have to say about 8 to 9 out of 10 times, I get the approval for FDG PET. But if there's one indication for FDG PET, it's exactly that. On the third cycle scenario you posted, it helps guide the treatment quite effectively.
If it is FDG, would you stop therapy?
Yeah, consider chemotherapy or PARP inhibitors or combinations. Yeah.
Dr. Farouk,
Last question I want to ask you. So patients who receive Pluvicto 6 cycles, excellent response, you put them on follow-up, right? And on further progression, would you consider re-challenge? And what is your criteria for considering re-challenge?
So it's interesting. Currently, the re-challenge has, and I had mentioned that yesterday at one of our workshops too, that we took the lead in re-challenging in neuroendocrine tumors using the Lutathera, and we have great experience. Probably one of the largest volume of cases in the world for additional challenge with Lutathera. With PSMA and with Pluvicto, we just started doing that, and we have built the experience. In fact, the patient that I showed you, the one who had extensive bone metastases, that patient ended up getting 7th and 8th cycle. This was about 7-8 months ago that I showed that. And that patient has done well. So anecdotally, it works. Currently, we have a few other options as well. Novartis has opened up an actinium PSMA trial as well. And so down the road in the future, you may have access to alpha particles as well. But currently, if the patient has a great track record of prior treatment response, definitely you can consider re-challenge.
Since you mentioned you have the highest number of cases in the world, so this will be the final question. But actually, I think this is the essence of the presentations today. So you spoke about very nicely how to assess the response to Pluvicto, and we mentioned multiple sides of the treatment. So, and adding to Dr. Jawahar, when he said the patient refused the chemo. So when it comes to us, a patient who is fit, who is young, and who is having multiple lesions of the liver, multiple lesions of the bone. So the patient, yes, is fit for chemotherapy, but does this mean that he is due for chemotherapy if he's having a PSMA with, you mentioned clearly the mean SUV and the SUV, and we can see that this patient can be responsive to Pluvicto. Just because the patient is fit and does not have a large tumor burden, we'll put him on chemo because he can tolerate chemo, or this patient might respond to Pluvicto.
That's a great question. Not uncommonly, this gets discussed in our MDT as well, where this dilemma comes up. The patients who refuse the chemotherapy, oftentimes after the MDT, the discussion goes back, so the primary oncologist will go back and discuss with the patients. I find that about 20 to 30% of the patients, when you share the results of MDT, they would change their mind and say, okay, now, that recommendation came, especially if there's a low volume disease or low SUV, where you will benefit from chemo, more so knowing that the PSMA, lutetium PSMA therapy may not work as effectively. But others are still looking at the overall quality of life and other questions. And when they look at the data of the quality of life benefit of Pluvicto versus chemotherapy, I would say about 6 to 7 out of 10 would still insist on getting the Pluvicto. And that's where oftentimes, while we are practicing the science, oftentimes the patient preference at the end of the day also drives the decision on which direction they go.
Right. So the question about, you mentioned 6 cycles and would you re-challenge actually. This is very interesting because we are not using Pluvicto, we are using homemade lutetium PSMA I'm talking about Saudi Arabia. So what we are doing, I have seen most of my patients cannot tolerate beyond 3 or 4 cycles. We stop it. We stop it and then re-challenge it later on. So this is something, and a lot of oncologists I've discussed, they are also doing the same way. They're saying, yes, we can stop it at 3-4 cycles. Do we really need to give 6-8 cycles? Or can we stop in between 3-4 cycles and then give further progression, 3-4 cycles? I'm personally doing it, and one of the reasons is because we are using lutetium PSMA maybe in the later stage, or our patients are not tolerating. We are getting a lot of fatigue is very, very, very common in our patient, in addition to cytopenias. So that is what we are facing with our patients. And in most of my patients, 3-4 cycle, we stop it, and then we not re-challenge, but restart again later on when they progress.
Yeah, so that brings up the point. I can't tell you the experience anything other than the lutetium PSMA 617 because we started participating in the expanded access program well before Pluvicto was approved, not only for PSMA4, but even for vision trial. And so I have exclusive experience with only lutetium PSMA 617. A little bit of background on the formulations. There are different types, and it's not just the PSMA molecule that you need to be mindful of. You also need to be mindful of lutetium 177 itself, because there's a carrier added and a non-carrier added lutetium 177. The carrier added means that there is a longer half-life lutetium 177M in there. And that, it's a metastable one, but it's a longer metastable. And the washout of lutetium 177 PSMA 617 non-carrier added is at a 6.7-day half-life. What that means is that it's cleared out of the body after that half-life calculations, biological half-life. But if there's a carrier added one, it has years and years of half-life clearance. So that stays in the body and creates that fatigue and other impact, including the bone marrow effect as well. So you need to be mindful about the formulation, not just the PSMA 617 versus others that are out there, but also on the lutetium 177 side as well.
Thank you so much. I think I've delayed you enough. Thank you. Thanks for the panelists, thanks for the speakers. And I think, Micheline, when and where is the dinner? Okay. In an hour or now? 8:30? Okay, 8:30. See you at the dinner. Thank you so much.